स्टार्ट एक मिनट जो कर देगा तो शुड वी स्टार्ट okay. Hello everyone, am I audible? Let me just check. Okay. Hello everyone, am I audible? So yes, I have checked. Okay, so we can start the session now, and for today's session I am going to complete most important topics of the lower limb. So in this session we will know all the topics of the lower limb, which is highly important for your competitive exam of FMG. So in FMG, a few of the topics are there which you have to know, about the contents, you have to know the boundaries, you have to know about the muscles, you have to know about their innervations and the nerves and the joints, which is highly important. So yes, Vicky 888, okay dear. So we can start the session now, and this session will be highly beneficial for you. So please be live, and if you have got any doubt regarding the topics which I am teaching, you are not understanding anything, or you want me to repeat, or you have got any query regarding the topic, any MCQs which you are not able to understand, you can definitely ask me and I will reply in the chat box. Other than that, I also want that you should be aware of all the MCQs which is highly important for a particular topic. So for the today's strategy, so if I talk about today's session, how I have planned the session is that one topic I will take, and just after completing that topic, few MCQs related to this topic will be solved. So that means after every small topic, the topic can be of 15-20 minutes, or the topic can be of half an hour. We will have an MCQ session which will be consist of the MCQs of the previous year and the most important MCQs which is conceptual and has to be understood by you. So this is the whole idea how I am going to cover entire lower limb, and tomorrow I am going to cover entire upper limb. The session will be highly beneficial for you, so I want everybody to be live. Okay, so let's start the session. Now the first thing by which I am starting the topic of today's session is the cutaneous innervation or the cutaneous nerve supply of the lower limb. Why it is very important, I will tell you, because when I am talking about cutaneous innervation, you should be, so this is the first topic which I am going to help you to understand, because so many image based question has been come as a previous year, where you have to know the cutaneous innervation, you have to know the dermatomal distribution of that area. So in one line, if I talk about innervation of lower limb, okay, if I am talking about the nerve supply of the lower limb or innervation or the cutaneous nerve supplying the lower limb, these are the branches which is derived from the lumbar and the sacral plexus. So these are the branches of lumbar plexus and these are the branches of sacral plexus. So most of the cutaneous nerves which is giving innervation to the thigh is provided by lateral and posterior cutaneous nerve and the cutaneous branches of femoral nerve. Anterior cutaneous nerve of the femoral in addition gives innervation to anterior aspect of thigh and also gives innervation to the medial aspect of the thigh. Cutaneous innervation, if I am talking about the cutaneous innervation of the leg, in anteromedial aspect, it is supplied by saphenous nerve, posteromedially by sural nerve, and anterolaterally by superficial peroneal nerve. So, and we will also talk about the cutaneous innervation of the foot. So, I just want everybody to please note down. When I will talk about innervation or the individual nerve, I will talk about the details of individual nerves like sciatic nerve, obturator nerve, femoral nerve. I will also show images regarding the cutaneous innervation of the lower limb. Here also the dermatomal distribution and cutaneous innervation will be discussed. So let's slide. And also after completing this, we will have an idea about the branches of lumbar and the sacral plexus. So cutaneous nerve supplying the lower limb. I want everybody to write important basic point which you should not leave, and you should be well aware of that point. So the first point about cutaneous innervation is most of cutaneous innervation of the thigh is provided by, so basically in one line, if I am talking about cutaneous innervation of the lower limb, so you can just write, if you want, you can write this point also, cutaneous cutaneous nerve supply of lower limb are derived from branches of lumbar and sacral plexus, so it's also important, I will tell you about all the branches of lumbar and sacral plexus after completing this point. Lumbar and sacral plexus. So my writing is okay. Are you able to understand? I just want everybody to take a notebook and write all the things which I am telling. All these points are highly important. Okay. And we are not going to have a cut short study of these topics because these are to be repeatedly asked in the examination. Now, most cutaneous innervation of thigh, most cutaneous innervation of thigh is provided by lateral and posterior cutaneous nerves of thigh, posterior cutaneous nerves of thigh, and also from the cutaneous branch of femoral nerve, and from cutaneous branches of femoral nerve. Okay, dear. So these are the 2 points. Now, what about the cutaneous innervation of, so particularly area wise, you have to also know area wise cutaneous innervation. So in this diagram, if I show you this diagram, you can understand the cutaneous distribution. So you have an idea of cutaneous distribution. So here you can see we have got the anterior and posterior aspect. We can see the lateral cutaneous branches. We can see the ilioinguinal branches is also higher up. Lateral cutaneous nerve of thigh is giving innervation. We have got also anterior femoral and posterior femoral cutaneous nerve is there. Posteriorly, if you go anterior and posterior aspect of the leg, we have got the saphenous nerve. In the medial aspect, we have got superficial peroneal nerve. Anterolaterally, we have got the sural nerve, and on the dorsum of the foot in between the great toe and adjacent toe, we have got the deep peroneal nerve. So once we will complete the session, I will share this PDF notes because you should have an idea of all the images. So in this image, you can see all the cutaneous distribution of lower limb, both from the ventral and the dorsal aspect has been shown to you. Okay. Now, basically, let's talk about the different areas and cutaneous innervation, which is highly important. So anterior cutaneous, so let's talk about first point is anterior cutaneous nerve. Anterior cutaneous nerve, which is a branch from, in bracket you can write femoral nerve branch. So anterior cutaneous nerve is a branch from femoral nerve, supplies anterior aspect of thigh and most of medial aspect of thigh. That means not only anterior aspect of thigh, but a part of medial aspect of thigh is also getting innervation from anterior cutaneous nerve. Now cutaneous, the second point, done with this. Now the second point, cutaneous, I will make it more clear. Okay, cutaneous innervation of leg, cutaneous innervation of leg. So anteromedial aspect, is provided cutaneous innervation by saphenous nerve. Anteromedial aspect by saphenous nerve. the posterolateral aspect by the sural nerve innervation. And what about anterolateral aspect? So anterolateral aspect by superficial peroneal nerve. Okay, that means in short the cutaneous innervation of the leg is having three nerves. We have got anterolaterally, we have got superficial peroneal nerve giving innervation, posterolaterally sural nerve, and anteromedially saphenous nerve. Anterior cutaneous nerve is basically giving innervation to the anterior aspect of thigh and medial aspect. Most of the cutaneous innervation of thigh is given by rest. Most of the cutaneous innervation of thigh is provided by lateral and posterior cutaneous nerve of thigh. So done with this. Now so this is again a front of thigh in which you can see. So please don't get confused by the upper aspect, that is also a distribution in the lower abdominal wall. Here you can see the femoral branch of genitofemoral nerve giving innervation to the area around the femoral triangle. Lateral femoral cutaneous nerve which is compressed, and the condition is called as, if anybody can give me the answer, what is the condition where the compression of lateral cutaneous nerve take place? The lateral cutaneous nerve is compressed, and that condition is called as meralgia paresthetica. Medial most part will be having obturator nerve, then there is medial cutaneous nerve, there is intermediate anterior cutaneous nerves, all giving innervation. Now cutaneous innervation of dorsum of foot, cutaneous innervation of dorsum of foot cutaneous innervation on dorsum of foot is mostly provided by superficial peroneal nerve. Is mostly provided by superficial peroneal nerve. Cutaneous innervation to the sole of foot is mainly provided by cutaneous branches of medial and lateral plantar nerve. Medial and the lateral plantar nerve. Then, so these are basically the cutaneous distribution, most important cutaneous distribution in of the lower limb which you have to know. And also there is important dermatomal distribution for the area. So I will also talk about that. Let me just come to the clinical aspect. Before that, I just want, so there is also given, but I would like if we talk about the dermatomal distribution. So let me just check with the students, are they understanding or not? So yes dear, any doubt you can ask me. Okay, my dear students, if you are not understanding anything, please let me know. I will be explaining it once again. So okay, so what is important is that you have to also know about the dermatomal distribution. Actually a table has been shared, but I want that most important part you should be writing it by yourself, because the question has been asked from the previous year, and the most important dermatomal distribution has to be known. That at one side you can make okay, here I am just enlarging this. Yeah, so on one side you can write dermatome, and other side area supplied. Area supplied. Okay, one side dermatome and other side area supplied. Now write out L1. If I am talking about L1, The L1 is supplying, dermatomal distribution is over inguinal area. That means area over inguinal canal. Area over inguinal canal. L2, anterior and lateral part of upper two-third of thigh. Upper two-third of thigh. Okay. L3, L3 anterior, lateral and medial part of lower one-third of thigh and the knee area. One-third of the thigh and the knee area. This is the dermatomal distribution for the L3 region. Okay, now L4. L4 is giving innervation to medial side of leg and also the medial malleolus. Also the medial malleolus. This is the distribution for L4. Medial side of leg and medial malleolus. L5. L5 is giving innervation to lateral side of leg, medial half of dorsum of foot, and dorsum of first web space, and dorsum of first web space. Okay, so this is the dermatomal distribution for L5, lateral side of the leg, medial side of the dorsum of the foot and dorsum of first web space. S1 is having the dermatomal distribution to posterior surface of ankle, posterior aspect of ankle, and lateral half of dorsum of foot. This is the dermatomal distribution of S1. S2, posterior thigh and the leg. S2 is having dermatomal distribution to posterior of thigh and leg. S3 has got the dermatomal distribution around gluteal area, is having the dermatomal distribution around gluteal area, around perianal region, perianal region, and that of groin area. S4 is having the dermatomal distribution to perianal skin and the groin area. So done. So in short, I have given you all the dermatomes, and the distributing areas are the area where this dermatomal distribution is present. So that is already given to you. The next important point is to know about the lumbar plexus and all. So it's very important that you should know about lumbar plexus. So here I just want everybody to write down the heading lumbar plexus. So till now, let me just check with the students. I would like to check the mobile and let everyone to know, is there any doubt which you are not understanding? So students, are you able to understand anything? Okay, anything which you have not understood? Actually till now we have finished about and seen how there is distribution of cutaneous distribution on the lower limb anterior and posterior aspect, and we have also discussed the dermatomal, most important dermatomal distribution areas, dermatome and the distribution areas, and MCQs are asked from these topics. So I just want everybody to have a note on this. Okay, the dermatome and the area distribute. Okay, after that, the next point is to know Write down the heading, the lumbar plexus. Lumbar plexus. The lumbar plexus. Okay, the lumbar plexus. So if we talk about a lumbar plexus, what is it? So this is the web of nerves. How we can define lumbar plexus? It is web of nerve. It is web of nerves. The word plexus means bunch of nerves or web of nerves in the lumbar region, and it is formed by taking the actually it is formed by the first four lumbar nerves L1, L2, L3, L4, and a contribution can be taken from the subcostal T12 nerve, that is the last thoracic nerve. So exactly ventral rami of the fourth lumbar nerve has got a communicating branch which also communicate with the lumbosacral trunk and to that of the sacral plexus. So lumbar plexus is the web of nerves. It's a web of nerves in the lumbar region. It is formed by the division of first four lumbar nerves, that is L1 and L4, and contribution of subcostal nerve, that is T12. Okay, contribution from subcostal nerve. Now we can just note down the ventral rami of L4 nerve. The ventral rami of L4 nerve communicates with lumbosacral trunk, which is contributing to, which will also communicate to sacral plexus. Now the nerves, it's important, basically if I talk about basically the nerves of the lumbar plexus, it is passing in front of the hip joint and mainly supporting the anterior part of the thigh. So they are giving support to the anterior part of the thigh. Other than that, it is important that you should know the branches of lumbar plexus. So if I talk about, then we will come to the clinical aspect. So here we have also we will talk about the branches later. But one of the branch which needs to be understood is the lateral. So we have got many nerves of the lumbar plexus. We have got much more lumbar plexus, but one of its branch is the lateral cutaneous nerve of thigh. So when the lateral cutaneous nerve of thigh is compressed, the pain will be in the lateral aspect of thigh, radiating till that of the so if I talk about radiating till that of the lateral aspect of knee, and it will lead to pain in this area. It will lead to the pain in this area, causing meralgia paresthetica, causing a case that is called as meralgia paresthetica. So that is highly important for you to know. So meralgia paresthetica is a condition of pain and numbness, tingling sensation in the lateral aspect of thigh till the level of lateral aspect of the knee joint, and it's quite painful. And the reason of meralgia paresthetica, if I'm talking about meralgia paresthetica, the reason of meralgia paresthetica is wearing tight cloths, obesity, or any kind of lumbar injury. There is compression of the nerves, and basically you should avoid sitting at a particular position for long duration of time. You should just break your one posture So you should not be prolonged sitting on one posture, standing on one posture. That is not good for the nerves. Okay. Now, so we'll talk about that. I will write this. Before that, I just want you to show this image. So if you will see this image, you can understand the important branches of lumbar plexus. So the important branches here of the lumbar plexus are iliohypogastric, ilioinguinal, genitofemoral nerve, the lateral cutaneous nerve of thigh, the direct branches of psoas and iliacus, femoral, accessory obturator nerve and the obturator nerve, and lastly I told you L4 ventral rami communicate with the lumbosacral trunk. So basically one by one I will tell you about the branches. Basically firstly you can write down just the name of the branches of lumbar plexus. So here you can write down the heading nerves of lumbar plexus. Nerves of lumbar plexus. So nerves of lumbar plexus, that is highly important for you to understand. Nerves of lumbar plexus. So the nerves are iliohypogastric, nerve. So firstly I just want to write the name and we will have the details afterwards. Ilioinguinal nerves. Actually, if you want, you can write also. It is basically the root value is L1 only, but it can communicate with T12. So you can write T12 L1 is the root value. T12 L1 is the root value. Then we have got genitofemoral nerve. And the genitofemoral nerve root value is L1, L2. We have got lateral cutaneous nerve of thigh, lateral cutaneous nerve of thigh. The lateral cutaneous nerve of thigh. If I talk about lateral cutaneous nerve of thigh, the root value is L2 and L3. Then we have got obturator nerve. Obturator nerve. And when I am talking about obturator nerve, the root value is L2, L3 and L4. L2, L3 and L4. Then we have got femoral nerve. And femoral nerve is L2, L3 and L4. Both. So actually both obturator and femoral nerve is having same root value. Here the femoral nerve is from the ventral rami, dorsal division of L2, L3, L4, and obturator nerve is from ventral rami, anterior division of L2, L3 and L4. Other than that, we have got some direct branches. So these are the main branches. Other than that, we have got direct branches from the lumbar plexus to the muscles, like short direct branches, and we have got the direct branches to psoas major. So you can write down direct branches also if you want. So here itself you can write down this point. Direct branches from lumbar plexus. Short direct branches. Short direct branches. If I talk about short direct branches, L1 and L3 is the root value, and this is given to psoas major muscle. Another short direct branches are there, and these short direct branches are given to other group of muscles. Again it is T12 to L4, and these direct branches are given to quadratus lumborum, and lumbar intertransversus muscle. So done. So we have done with the nerves of lumbar plexus also, and the next condition which I already told you, meralgia paresthetica, is caused due to compression of lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. So lateral cutaneous nerve of thigh is compressed and the condition is called as meralgia paresthetica. Now the important branches has been shown in this image. Also how it is formed has already been written, but I just want everybody to concentrate on the important branches and their distribution. That is important for all of you. So it's also important that you should know about the distribution. Ma'am, can you please write down the root value for the nerve branches? Punit, yes, I have written. If you will see, Punit, is it okay? I have written also. Punit? Yes, dear, you are absolutely right. I have just written here the root values also. Can you see? Ilio. Okay, dear. And one by one, I am going to tell you about the distribution of these nerves because that is highly important. Okay, dear. So let's talk about the important branches. So branches of lumbar plexus, their distribution and all. And after completing one set of topic, we will discuss MCQs from the previous year of examination and also few MCQs to test how we are knowing these, to know how which type of question will be asked in the upcoming exam. So branches of lumbar plexus, the first branch which I want everyone to understand is the iliohypogastric nerve. The first one is iliohypogastric nerve. Okay, iliohypogastric nerve. Iliohypogastric nerve, if I am talking about this, as I told you, Punit has also asked me the root value T12 and L1. So, if T12 and L1 is the root value, but in option, if only L1 is given, that is also right. Okay, it takes contributing from T12, but the major root value is L1. T12 and L1 is the root value. Now, if I talk about the innervation, which it innervates which all muscles. So, if I talk about innervation, it innervates transversus abdominis muscle and abdominal internal oblique. Okay, and if I talk about its important branches, so it gives anterior and lateral cutaneous branches. So iliohypogastric nerve is also giving, it's also giving anterior and it gives anterior and lateral cutaneous branches. Lateral cutaneous branches. Got it? This is about iliohypogastric nerve. The rest is, the next nerve is ilioinguinal nerve. Ilioinguinal nerve. Ilioinguinal nerve. If I talk about ilioinguinal nerve, L1 is the root value. Contribution can be taken from T12, but basically L1. And it gives following branches. So the branches are, if I talk about the branches of ilioinguinal nerve, it gives, again it innervates the same muscle of the abdomen, transversus abdominis muscle, and abdominal internal oblique muscle. Abdominal internal oblique muscle. And if I talk about its cutaneous branches, it is giving anterior scrotal nerves and anterior labile nerves. So anterior scrotal nerves will be given in males and the anterior labile nerves will be given in female. So the cutaneous branches are anterior scrotal nerves and anterior labile nerves, labial nerves. Okay. Now, next nerve is genitofemoral nerve. Okay. Then we will have the, okay. Now, next nerve is, please write on the list. So, we have written till ilioinguinal nerve. Next nerve is, the third nerve is genitofemoral nerve. And when I am talking about genitofemoral nerve, it will again have two parts. One is the genital and one is the femoral. So, genitofemoral nerve. Genitofemoral nerve. So, genitofemoral nerve, again the root value is L1 to L2. And it gives innervation to a muscle, that is cremaster muscle in males. And it gives femoral ramus and genital ramus. So, basically femoral ramus means giving innervation to the skin of the femoral triangle, genital is going to the genital areas. Now, the next is lateral femoral cutaneous nerve, lateral cutaneous nerve of thigh or lateral femoral cutaneous nerve, lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. So, if I am talking about lateral cutaneous nerve of thigh, the root value will be L2, L3, L2, L3. And it is actually giving distribution to lateral aspect of thigh. So, it's a cutaneous nerve. So, cutaneous distribution is over lateral aspect of thigh. Now, talking about the next nerve, obturator nerve. So, briefly I am telling you about these. Why? Because these individual nerves will be discussed in detail, like femoral, sciatic, obturator. Sciatic is a branch from the sacral plexus. So, basically all important nerves of the lower limb will be discussed as a separate topic. So, next is the obturator nerve. Next is obturator nerve. Okay. So, if I am talking about obturator nerve, again the root value is L2, L3 and L4, gives innervation to muscles of medial compartment of thigh, medial compartment of thigh, muscles of medial compartment of thigh, and it gives innervation to obturator externus muscle, adductor longus muscle, adductor brevis muscle, gracilis muscle, pectineus muscle, gracilis pectineus, and adductor magnus muscle. Okay, and it also gives cutaneous distribution to medial aspect of the thigh. So small cutaneous distribution to medial most part of the thigh. Cutaneous distribution to medial most part of the thigh. Here you can write. So medial most part of the thigh is also receiving cutaneous distribution from obturator nerve. The next is femoral nerve. So we will have the next. So we have done this. Now the next is femoral nerve. Femoral nerve. Wait a minute. So femoral nerve is the nerve of anterior compartment of thigh. So it will give innervation to all the muscles of anterior aspect of thigh. So write down femoral nerve. Again the root value will be L2, L3 and L4. And femoral nerve is giving innervates muscles of anterior compartment of thigh. Muscles of anterior compartment of thigh. Muscles of anterior compartment of thigh, and basically it is giving innervation to muscles like iliacus, pectineus. Actually pectineus is the muscle of medial compartment, but it is also giving innervation from femoral nerve via branch from trunk. It gives innervation to sartorius muscle and quadriceps femoris. When I am talking about quadriceps femoris, it means quadriceps femoris is consist of four muscle group, that is vastus medialis, vastus lateralis, vastus intermedius and rectus femoris, and it also gives cutaneous branches. The name of cutaneous branches of femoral nerve are, if I talk about cutaneous branches of femoral nerve, it is giving anterior cutaneous branch and saphenous nerve. It is giving anterior cutaneous branch. It is giving anterior cutaneous branches and it is giving saphenous nerve. Now talking about, so we have written the important branches and direct branches. So we'll talk about direct branches. So write down direct branches. Direct branches from lumbar plexus to the muscles. So direct branches from lumbar plexus to the muscles. So from L1 and L3 root value, it is giving direct branches to psoas major muscle. And I have already written also T12 to L4 direct branches is given to quadratus lumborum and lumbar intertransversus muscle. Intertransverse muscle. So done. So that means we have finished the topic of lumbar plexus, everyone. Then I just want to give you we will come to the MCQs, but before that I just want everybody to have an idea of sacral plexus also, because sacral plexus is a plexus of nerve which is giving mainly motor innervation and sensory innervation to posterior thigh, most of the lower part of the leg and that of the foot, and a part of pelvis also. So basically you have to just know how it's formed and you have to just know about its important branch name. Okay, so sacral plexus formed by, so next heading is write down S, sacral plexus. So actually dermatomal distribution I have already written, so I am not going to repeat it once again. We will talk about the sacral plexus important formation and branches. So when I am talking about sacral plexus, It is formed by lumbosacral trunk. It is formed by lumbosacral trunk. It is formed by anterior division of first sacral nerve, and it is formed by the portion of anterior division of second and third sacral nerve. Portion of anterior division of the second and third sacral nerve. Second and third sacral nerves. Got it? So this is all about the sacral plexus. And nerves of the, if I talk about the nerves of the sacral, so basically you can see it is taking contribution from lumbosacral trunk, from the first sacral and portion of the second and third sacral also. The nerve converges towards the lower part and it traverses through the lower part of greater sciatic foramen, and thereafter it gives several branches. And the important branches are, if I talk about the, just write on the name of important branches of sacral plexus. So write on the heading, nerves of sacral plexus. Nerves of sacral plexus. So the name of important nerves of sacral plexus are following. So if I talk about the nerves are superior gluteal nerve. So yes, as Punit has told me to write the root value, so I am writing the root value also, L4, L5 and S1. So L4 to S1. And if I talk about the superior gluteal nerve is giving innervation to, so it is innervating gluteus. If you want to write, I will write quickly, gluteus medius, gluteus minimus and tensor fasciolata. Inferior gluteal nerve, if I talk about inferior gluteal nerve, the root value will be L5, S1 and S2, and it gives innervation to gluteus maximus muscle. Now, posterior femoral cutaneous nerve. So we have done with this. It also gives other branches like posterior cutaneous femoral nerve, posterior femoral cutaneous nerve having the root value S1 and S3. Perforating cutaneous nerve, and if I talk about perforating cutaneous branches and nerves, the root value will be again S2 and S3. Now talking about direct branches. So let's talk about fifth point, direct branches from sacral plexus. Direct branches from sacral plexus. So if I talk about direct branches, the direct branches are given to piriformis muscle, S1 and S2. It is also direct branches is given to obturator internus and quadratus femoris, obturator internus muscle, and the next is quadratus femoris muscle. Quadratus femoris muscle is a quadrangular muscle covered by the gluteus maximus muscle. So root value of quadratus femoris is L4, L5 and S1. Root value of obturator internus is L5, S1 and S2. And by the name only it is given that it is giving innervation to these particular muscles. Now done with this, now I would like to show you an image where dermatomal distribution of anterior and posterior aspect of thigh has been shown. So very clearly you can see dermatoval distribution of anterior and posterior aspect of thigh, which is very, very important for you. Okay. And so basically these are the importance and basically contribution. So basically before that, these are the branches of the sacral plexus, and other than that, if you want to add on more, so it also gives few important branches which is formed from its sciatic nerve, common femoral, superficial femoral, and that of peroneal nerves and all. So you can just continue the list. The dermatomal distribution, I have already covered this part, so I am just removing this, and here itself I am utilizing to write more of the branches. So please rub this. Okay, so please now, so we have seen this dermatomal distribution, and basically we have seen all the important branches also. Other than that, few more branches are there. So basically these are direct branches. After that you can continue, you can just write down branches of sacral plexus. So that means I am continuing with the list of sacral plexus branches. Just write down the name, because these branches will be separately done in the topic of nerves. So basically we have got 6. One as the sciatic nerve, root value is L4 to S3. That means L4, L5, S1, S2 and S3. We have got other nerves like common peroneal nerve or fibular nerve, common peroneal nerve, that is L4, L5, S1 and S2 root value. Okay. So why I am not writing the details of sciatic nerve and common peroneal fibular branches and all, because that nerves will be separately taken as a topic. Okay, so other than that, there is superficial peroneal nerve. So actually common peroneal nerve will further divides into superficial and that of deep peroneal nerve. So if you are getting confused, you can, oh, just a minute. Oh, okay. Why? So branches of I have already written. Please let me just write it once again. Okay. So I think you have also written. Basically, I didn't wanted a dermatomal distribution. I have already written. So just rub it. Okay. Yeah. So this is peroneal nerves. Okay. So please rub it and write it once again. So I have already written that it gets swiped out. I am so sorry for that. So this was A and B. Superficial peroneal nerve was a branch from. So till 5th I have written, no, 5th I have written direct branches. Now the 6th is sciatic nerve. 7th is common peroneal nerve. Sciatic nerve root value, if you want to write, L4, L5, S1, S2 and S3, common peroneal nerve. Its root value is L4, L5, S1 and S2. Okay. L4, S5, S1 and S2. Okay, two branches it gives, and that two branches which it divides into superficial and deep peroneal nerves. Okay, done with this. Now other than that, there is also other nerves. There is tibial nerves. Tibial nerve is also a branch from common peroneal nerve only, and this tibial nerve is actually root value will be L4 to S3. That is, it's a larger branch or division of the sciatic nerve. And we have got again the tibial nerve will divide into A and B two nerves, that is medial and lateral plantar nerve. That is medial and lateral plantar nerve. Okay, done. So all these are the branches. I just want, before proceeding to this MCQ, I just want everyone to have a look on the dermatomal distribution. So what is important for you to know about the dermatomal distribution, which is very important, so that you can have an idea and you can solve the image based question. So that is highly important that you should know about the dermatomal distribution. Okay. So we can see here the dermatomal. So this is anterior aspect. This is the anterior, and this is the posterior aspect. This is the anterior, and this is the anterior, and this is the posterior aspect of the lower limb. And you can see the nerves distributed in the anterior and posterior aspect. And you have to just tell the nerve distribution. So you can see the distribution area of posterior aspect of thigh, S1, S2 is there. Anterior aspect is L2, L3, L4 and L5. So this and dermatomal list of distribution I have already given. If you want to have a look, you can just go once again on that. Yeah. So for example, L1 region is giving innervation to inguinal area, L2 into anterior lateral aspect of upper 2/3 of thigh, L3 onto the anterior lateral medial aspect of lower 1/3 of thigh, L4 on the medial side of the leg in the medial malleolus, and L5 into the lateral aspect of the leg, S1 into the posterior aspect of the ankle and that of the posterior dorsum of the foot. S2 is in the posterior aspect of thigh and also the leg. S3 is in the gluteal and perineal region. S4 is in the perianal skin and groin region. So this is all. Now, if you want, you just tell me, can we solve few MCQs related to this topic? Everyone, are you ready for it? Let me ask the students. So can we solve few MCQs related to this topic? We have done. After completing one topic, we will discuss the MCQ related to the topic. So here we have few MCQs related to the nerves, cutaneous innervation and dermatomal distribution. So let's solve this. So I would like to start with the first MCQ. Marked dermatome is, what is the marked dermatome here? So I mean to tell this area. I mean to ask this area. This dermatomal distribution will correspond to which of the following area? L4, L5, S1 and S2. So waiting for your answer. So according to you, which is the right answer, dear? Mark dermatomal distribution. Anyone wants to give the answer? Mark dermatomal distribution. Waiting for you to answer. So any live chart? Okay, I got an answer from Punit, and Punit ma'am supra topic करवा है ना. Okay, branches of sciatic nerve, superior gluteal, inferior posterior nerve. Yes, Punit. So I got an answer from Punit, and he is telling S2. That is D. Absolutely correct. So a thumbs up goes for him. A thumbs up goes for him. Yeah, absolutely correct. Absolutely correct, dear. So this is S2 is absolutely correct answer. Posterior aspect of thigh has got marked cutaneous distribution in this area. You are right. Okay, what Punit is asking, yes, it's a male, it is given anterior scrotal. Yes, you are right. Genitofemoral is having. Yes, ma'am, these notes are enough for the topic. Yes, dear. Yes, yes. This is Yes, Puneet, these notes are more than enough. This is not enough. I am teaching you more than enough. So please don't worry about that. I am preparing you for more than enough. Yes, all that nerves, Puneet, even after the notes, they are telling to read the book, but knowledge of these concepts by notes and read lines in the somewhat. Yes, dear. Yes, dear. मैम सुप्रा सुप्रा टॉपिक करवाओ, सुप्रा सुप्रा टॉपिक करवाओ. So Ankur Rajput, I didn't understand, dear, what happened. Okay, now let's move on to the next one. Next question. During laparoscopic hernia repair, a truck was accidentally a tack was accidentally placed below and lateral to pubic tuber. Post-operatively, the patient complained of pain. So, can you tell me which will be the right answer of the pain? Can you tell me which will be the right answer for pain? So, everyone, so below and lateral aspects. Here also the question is below and lateral aspects. So, that will help you to understand the right answer. Just during laparoscopic hernia repair. During laparoscopic hernia repair, below and laterally the ilium. So that is the right one. So just give me the right answer. So the distribution you can see is in the lateral aspect. So Medico is giving A, lateral cutaneous nerve of type. Punit is also giving yes, lateral femoral cutaneous nerve is absolutely right answer. Yes, it's an absolutely right answer. Yes. So a thumbs up again goes for you. All of you are absolutely right. A thumbs up goes for you. Yes, that is an answer. So thus the language is changed and another correlated question has been asked. Laparoscopic surgical repair of hernia was done on 50-year-old patient, following which the patient complained of pain in the lower limb. So which of the following nerve is injured? Iliohypogastric, ilioinguinal, lateral cutaneous nerve of thigh and femoral. So most commonly nerve being injured in this case. So in case of hernia repair also one of the nerve is basically injured. What is that nerve? So I am getting again a right answer from Punit. Absolutely great, Punit. So you are able to solve all the questions of INICT and NEET PG also. So yes, lateral femoral cutaneous nerve is absolutely right answer. Yes, yes, Medico, you are also right. Absolutely correct. So both of you, a thumbs up goes for you. Now, knowledge of segmental distribution is determining the level of intervertebral disc disease. S1 nerve root irritation will result in the pain along which area? If you want, I will give you the dermatomal distribution once again. So the knowledge of the knowledge of so if I am talking about the knowledge of so basically the question is a clinical question, but S1 nerve root, if you remember dermatomal distribution for S1 nerve root, that forms the right answer in this case. So that is absolutely forming like right answer in this S1 nerve root. S1 nerve root is irritating which area? That means if you have written the dermatomal distribution, you can give me the right answer. If you have written the dermatomal distribution, you can give me the right answer. Medial aspect of thigh, Medico, no dear, dermatomal distribution S1. No, if you want, can I show you the image once again? Dermatomal distribution. See here, dermatomal distribution, the image. Lateral aspect. Now tell me the right answer. Lateral aspect. S1 is giving innervation to medial, lateral, which aspect of the foot? Punit, I am showing you this image. I am showing you this image. Please see this and give me the right answer. Now give me the right answer. Dermatomal image once again I am showing you. So great toe means medial. Great toe is lying medially. Now give me the right answer. Okay, students. Punit, Medico. Now you can give me the right answer. So now what is the right answer here? S1 will give innervation to anterior aspect, medial aspect, lateral aspect of the foot or anteromedial aspect of the leg. Punit and Medico, what is the right answer now? Should I give? It's lateral side of foot, dear. It's lateral side of foot. See here. Can you see S1? So it's Punit, Medico. See here. This is the foot. This will be the medial side of the foot because it is great toe. So this is medial, and what will be this? Yes, Punit. This will be lateral. So this is lateral side of the foot. So the right answer will be lateral side of the foot. So the right answer will be lateral side of the foot. I'm just rubbing this because we have already seen this. Okay, ma'am, got it? Yeah. So that right answer will be lateral side of the foot. Now, which of the following nerves is blocked for the hernia surgery? Femoral catheter. Local anesthesia has to be given. Inguinal ligament, below inguinal ligament via femoral catheter. So anesthesia has to given below inguinal ligament. That is the hint which has been given to you. Below inguinal ligament. So anesthesia has to be given below inguinal ligament. So that will help you to approach to the right answer, dear. Cutaneous innervation below inguinal ligament area. Cutaneous distribution below inguinal ligament area. Yes, dear. What will be the right answer? Anyone? Then we will come to the new topic. Punit, Medico, no, femoral branch of genitofemoral. Who is this? Femoral branch of genitofemoral nerve. So femoral, Punit, you are absolutely right. Genitofemoral nerve, no. So femoral branch of genitofemoral nerve, Punit. So the Punit, please see, you have given the right answer, that is genitofemoral nerve. But in option you have marked B. It should be A. Punit, you have given absolutely right answer, Punit. But you have written B by mistake. So it will be A, genitofemoral nerve. The right answer is A, genitofemoral nerve. Yes, you have given absolutely right answer. Yes, absolutely right. Yes, now can we move to the next topic, that is the next topic, that is the front of thigh and the adductor compartment. The front of thigh and the adductor compartment. Okay, dear? Front of thigh and adductor compartment. So here we have to know about this adductor compartment. Okay, so that will be highly important for you. Front of thigh and adductor compartment. So basically, if I am talking about front of thigh, important topics to be studied in the front of thigh is the muscles in this area, and then you have to know about all the muscles, also the fascias, deep fascia covering the anterior aspect of thigh. You have to know the modification of these deep fascia. You have to know about the muscles, very important. You have to know about the femoral triangle, its boundaries and its content. You have to know about femoral sheath. You have to know the division of femoral sheath into 3 compartments, the structures in the individual compartment. And you have to know about the adductor region, the muscles of the adductor compartment of thigh, the medial compartment of thigh, and you have to know about the walls of adductor canal and the contents of adductor canal. So modification. So if I am talking about the whole of adductor, whole of the thigh, it is actually covered by a deep fascia, and the deep fascia of the thigh is called as fascia lata. What is it called as? It is called as fascia lata. The deep fascia of the thigh presents modifications, and it is termed as fascia lata. The modifications of deep fascia of thigh is in the form of iliotibial tract, it is in the form of saphenous opening, it is in the form of intermuscular septa. So these are the three important modification of fascia lata: iliotibial tract, saphenous opening, and that of intermuscular septa. Intermuscular septa. Iliotibial tract, saphenous opening, and intermuscular septa. Now, if you will see this fascia lata, which is shown in the yellow color, you can see it is covering the whole of the thigh region like a stocking, okay, like a tight stocking it is covering, and the fascia lata is also thickened on the lateral aspect to form iliotibial tract, and it is approximately wide, 2 inches wide, that is the fascia lata, and you can see the other structures has been shown. An oval hiatus is shown, where also you can see the great saphenous vein draining into it. So firstly, I would like to talk about fascia lata. So write down. Fascia lata is deep fascia of thigh, presents present two modifications, that is iliotibial tract, and saphenous opening. And that of saphenous opening. Now, let's talk about the first modification, that is iliotibial tract. So, fascia lata is thickened laterally to form iliotibial tract, and it is approximately a band-like structure, which is when you go for dissection also you will see this band-like structure on the lateral aspect of thigh. So, fascia lata is thickened the fascia lata is thickened on the lateral aspect of thigh, to form about 2 inches wide called iliotibial tract, called as iliotibial tract. Called as iliotibial tract. So if I talk about superior aspect, superiorly along the iliac crest, this tract splits into 2 layers and it encloses 2 muscles, that is tensor fascia lata and gluteus maximus. So it is splitting, iliotibial tract splits to enclose 2 muscles. So write down iliotibial tract, iliotibial tract splits to enclose 2 muscles, splits to enclose 2 muscles, that is tensor fascia lata and gluteus maximus, gluteus maximus. Now, so here I just want you to show this image. This is the iliotibial tract. You can use another color so that you can understand this. So this is the iliotibial tract which I am highlighting, and this is attached to the iliac crest superiorly, and it is splitting to enclose two muscles. This is the iliotibial tract. Lower down, if you will see, upper aspect it is attached to the hip bone, and lower aspect it is going towards the lateral condyle of tubercle, lateral condyle of the tibia. So it is attached to the lateral aspect of the knee joint, lateral condyle of tibia, which is also called as Griddy's tubercle. The other name of these tubercle is, it is also called as Griddy's tubercle. So this image is showing you the attachment of iliotibial tract, and the two muscles enclosed by or inserting into this, one is the gluteus maximus muscle and the other is tensor fascia lata. These are the two muscles which is inserted into the which is inserted in iliotibial tract. Now, we will talk about the fascicle compartment. So basically, the deep fascia of the thigh is forming three fascicle compartment. It is dividing the whole of the thigh into three compartments: anterior, medial, and posterior. Before that, I would also like to tell you about the saphenous opening, which is an opening in the fascia lata. So if you want, you can just write down this. So please write down about this also before proceeding to the next topic. Saphenous opening. So if I talk about saphenous opening, this is an oval opening. This is an oval opening. So saphenous opening is an oval opening which is located in fascia lata. So this is an oval opening in the fascia lata, in the fascia lata, in the upper medial part of front of thigh. The center of opening is lying 4 cm below and lateral to pubic tubercle, and it is vertical in length. So write down the center of opening lies saphenous opening. Okay. So write down the center of opening lies 4 cm below and lateral to pubic tubercle. Below and lateral to pubic tubercle. Okay. Now, other than that, so other than that, it's also important that what are the structures which is, if I talk about saphenous opening, it's closed by a membranous fascia. So this is, if that means saphenous opening, if I talk about saphenous opening, it's an opening in the deep fascia, but if I talk about covering of saphenous opening, so it is covered by a membrane, and that membrane is called as cribriform fascia. The saphenous opening, so you can write on this also. This is an important point. Many of the students get confused by this, that it is an opening in deep fascia, then it is called as cribriform fascia is not a modification of deep fascia. So the point is that saphenous opening is an oval opening in fascia lata, but saphenous opening is closed by a membrane. Saphenous opening is closed by a membrane of areolar tissue that is called as cribriform fascia. That is called as cribriform fascia. That is called as cribriform fascia. Now the structures piercing this is also important. So it's also important the structures passing procephalus opening. So write on the important point, the structures passing procephalus opening is very important. So we have written this. Now here we can see the ovoid hiatus, the saphenous opening, and I just want everybody to write on this point. So you can just write on here, heading, structure passing through, structures passing through saphenous opening, structures passing through saphenous opening are great saphenous vein, superficial epigastric and superficial external pudendal vessels, superficial epigastric and superficial external pudendal vessels, few lymph vessels connecting superficial and deep inguinal lymph node, superficial and deep inguinal lymph nodes. Done? Done? Fascicle compartments of thigh, fascicle compartment of thigh. If I am talking about fascicle compartment of thigh, the entire compartment of thigh is divided into three compartments, that is anterior, medial and posterior compartment. And again we have to know the important muscles and constituent residing in these compartments. So one by one I am talking about individual compartment. So first thing is that we have to know the anterior compartment of thigh. So here I just want you to enlarge this image, and here you can see this pink color highlighted area which you are seeing. This is the area which is the area of anterior compartment of thigh. And in the anterior compartment of thigh we have got these muscles, that is quadriceps femoris muscle and the sartorius muscle. We have got vastus intermedius, vastus lateralis, vastus medialis, rectus femoris, and we have also got the femoral artery, femoral vein and nerves. So we have got here the nerves. You can see this is the nerve, and we have got the artery and we have got the vein. So these are the three structures. So we have got nerve, we have got artery and we have got vein. So these are the important structures in the front of thigh. So muscles of anterior compartment of thigh is following. We have got sartorius, we have got quadriceps femoris, rectus femoris, vastus lateralis, vastus medialis, vastus intermedius and articular genu. If you will see this image, you can see articularis genu. When I am talking about articularis genu, it's a small muscle which is actually derived from vastus intermedius muscle only. It is derived from which muscle? It is derived from vastus intermedius muscle. We have got sartorius and we have got tensor fascia lata. Then the next point is to know about the muscles in detail. So basically before that I would like to introduce you with this compartment. So please write down. So let me just once again check with the student. Are you understanding everyone? Okay, it's okay. Bindu, please, Bindu is asking, please explain common peroneal nerve. Bindu, common peroneal nerve is the nerve or a common, Bindu, common peroneal nerve is the branch of sciatic nerve. Actually, sciatic nerve is dividing into common peroneal nerve and it is dividing into tibial nerve. So, tibial nerve is the larger branch of the sciatic nerve and common peroneal nerve is the smaller branch. Common peroneal nerve winds around the neck of fibula. It is winding around the neck of fibula and then dividing into deep peroneal nerve and superficial peroneal nerve. Deep peroneal nerve is the nerve of anterior compartment of leg, and superficial peroneal nerve is the nerve of lateral compartment of the leg. So yes, Bindu, I just want you to tell that this common peroneal nerve, tibial nerve, I have a separate topic for these nerves. Okay, what I have given you in the introduction part or the first part of lower limb is their root value and their location, but individually we will go into the details of all the nerves. Okay, between great toe, yes, medico, between the great toe and adjacent toe, deep peroneal nerve will give cutaneous innervation. So that is, we are going into Bindu, we are going into details of individual nerve. So sciatic nerve, common peroneal nerve, tibial nerve, femoral nerve, obturator nerve, these are all the nerves which will be studied in detail. Okay, so just now I have just given the name of these nerves. Please don't get confused, Bindu. I have just written the name of the nerves. These all nerves we are going to discuss in detail after completing these topics first. Okay. The first topic was just the introduction. So don't worry, we are coming to that topic in detail. Okay, Bindu, can I proceed? Okay. Okay, Bindu, is it okay, Bindu? Now, so what I was talking about is the anterior compartment of thigh. Anterior. So firstly, we will talk about anterior compartment of thigh. Anterior compartment of thigh. So basically, if I am talking about anterior compartment of thigh, you have to know the anterior compartment of thigh is laterally bounded by the lateral intermuscular septum and medially by medial intermuscular septum. So anterior compartment of thigh is bounded laterally by lateral intermuscular septum, lateral intermuscular septum, and medially by medial intermuscular septum, medially by medial intermuscular septum. Now content, if I talk about the contents, so if I talk about the contents of these compartments, so this compartment is containing muscles, and the muscles are quadriceps femoris, sartorius, tensor fascia lata. These are also containing, the other content is nerve is femoral nerve, the nerve of these compartment is femoral nerve, and the artery of these compartment is femoral artery. Okay, so this is exactly the details of the compartment. So individually let's talk about. So actually you must be wondering that why ma'am is showing these muscles. Okay, so basically students, you must be wondering why ma'am is showing iliacus psoas major muscle in this list. Actually the reason is that iliacus and psoas major muscle is the muscle of abdomen, means it's coming from the lumbar region, but it is inserting into the lesser trochanter of the femur. So I just want, and these are the major flexors of the hip. Iliacus and psoas major muscle are the strongest of the major flexors of the hip. So I want you to know about these muscle in the anterior aspect of thigh only, because that is important, that you should be knowing these muscles. So let's start. Okay, so that is also important, that you should not skip these muscles, because these are the muscles which is also exactly it's why it is important, because these are the muscles which is also seen in the lumbar region, but it is inserting into the lesser trochanter of the femur. That is what psoas major and iliacus. Psoas major muscle and iliacus muscle. So see here, if you will see this, so we are concerned about psoas major and iliacus. So if you will see the psoas major muscle, it is originating from the transverse process of lumbar vertebra. So it is originating from the transverse process of the lumbar vertebra, and also the if I talk about these muscles, so what you can see that the muscle is originating from the transverse process of the lumbar vertebra L1, L2, L3, L4, and also from the vertebral bodies, and inserted into the lesser trochanter. You can see inserting into the lesser trochanter of the femur. So that is very, very important for you to understand about these muscles. That is the psoas major muscle. Okay. So let's write it about that. So firstly psoas major muscle, then iliacus I will talk about. So origin and insertion is very important. So let's talk about psoas major. Please write on the heading psoas major muscle. Psoas major muscle origin. So the origin takes place from the transverse process of T12 and L4, transverse process of T12 and L4, and lateral aspect of disc between them. Lateral aspect of disc between them. Insertion. If I talk about the insertion of psoas major muscle, it is inserting in the lesser trochanter of femur. It is inserting into the lesser trochanter of femur. Okay, this is about the origin and insertion. Transverse process of T12, L1, L2, L3 and L4, and insertion is into the lesser trochanter of femur. Now the nerve supply. If I talk about the nerve supply, lumbar plexus via anterior branches of L1 to L3 nerves. Action, if I talk about the action of the muscle, so the action is flexion of hip joint. The action is flexion of hip joint. So this is the important about the psoas major muscle. The next is iliacus muscle. So here also you can see the iliacus muscle is originating from the hip bone iliac fossa. So this is iliacus, I for iliacus, and this is originating from the hip bone iliac fossa. Inserting is the same, the lesser trochanter of the femur. So that is very, very important for you to understand. Next is iliacus muscle. Okay, so write down about iliacus muscle. Write on the heading iliacus muscle. Iliacus muscle. Origin. So if I talk about the origin of iliacus muscle, origin is upper 2/3 of iliac fossa. Upper 2/3 of iliac fossa. Upper 2/3 of iliac fossa is the origin. Insertion is Insertion is lesser trochanter of femur, base of lesser trochanter of femur. Okay, nerve supply. So the nerve innervating iliacus muscle or giving innervation to iliacus muscle is femoral nerve. And action is, if I talk about action, again it is flexing the hip joint. So action is flexes and rotates the hip joint medially. Flexes and rotates hip medially. So actually together, if I talk about these iliopsoas muscle, they are the flexors of the hip joint. They are the important flexors of the hip joint. They are the most important flexors of the hip joint. Now done. Now talking about psoas minor muscle. Psoas minor muscle. Okay, so we have got just the next one is the psoas minor muscle, which also you have to know. Actually, all these I have skipped out, but one thing is important, that you should also be aware of these muscles, because in relation to the anterior aspect of thigh, they also ask about these muscles. So it is important that you should be aware of these muscles. Psoas minor muscle. So let's talk about the psoas minor muscle, which is highly important for you to understand. So we'll talk about origin. So I just wanted to show you this image. So actually, if you will see the psoas minor muscle, which is lying above, so it is originating from the lateral aspect of the bodies of T12 and L1 vertebra, and it is inserting into the pectineal line of the iliopubic eminences. So it is inserting into the hip bone, pectineal line and iliopubic eminences. So write down psoas minor muscle origin from the lateral surface or bodies of T12 and L1 vertebra and intervening intervertebral disc. Insertion is into the pectineal line and iliopubic eminences. Nerve supply, if I talk about the nerve supply, it is from anterior ramus of nerve, that is L1. And if I talk about the action is weak trunk flexors. Weak trunk flexors. Weak trunk flexors. Got it? Now talking about the other muscles. So let's talk about the first one, that is the sartorius muscle. So here you can see this is the sartorius muscle, which has been shown in this image. Actually, why it is very important for you to know about the sartorius muscle? The reason is that sartorius muscle is important. Why? Because its action, question about the action of sartorius muscle has been asked so many times. Ma'am, after this topic, please explain easy way to explain the dermatome. Okay. Mr. Lombor, exactly, if once you are knowing the nerves, like when I will teach you the femoral nerve obturator nerve, when I will teach you about the sciatic nerve, tibial nerve, it will become highly easy for you to memorize, okay, because you will understand the nerves and their distribution. So once I will explain the nerves and correlate once again with the dermatomal distribution, and basically important areas of dermatomal distribution is important. So basically once we will do all the muscles and once I will finish the nerves, it become easy for you to understand. So please don't worry about this. Acha, medico, what is eminences? Okay, iliopubic eminences. In hip bone, there is a elevation that is called as iliopubic eminences. In hip bone, there is a elevation that is called as, so hip bone is made of, medico, we know that hip bone is made of, if I talk about the hip bone, it is actually having three parts. It is having ilium, it is having pectineus, it is having the pubis part, it is having the ischium part. So in the pubis part also you will see, when you will see the pubis part and all, you will see there is also in the hip bone a pectineal line, and elevation means, if I talk about iliopubic eminence, it's a slight elevation, rounded elevation which is seen in the hip bone, that is called iliopubic eminences. Okay dear? Okay, eminence means slight elevation. Okay, it's a slight elevation seen in the hip bone, that is iliopubic, means elevation is in between the ilium and the pubis bone. Okay. Now femoral nerve, so what is the attachment? So origin, when I am talking about the origin of sartorius muscle, you can see what it is written here, ASIS, and insertion is pec anserine. So that means origin of, sartorius muscle is from, if I talk about origin of sartorius muscle, origin of sartorius muscle is, if it is originating from anterior superior iliac spine. So where from it is originating from? Anterior superior iliac spine is the origin. Insertion, if I talk about insertion, the insertion is into the medial aspect of, tibia, and actually medial aspect of the proximal tibia. Actually when I am using the word proximal medial aspect of tibia, there is insertion of all other muscles also. So there is insertion of also semitendinosus and that of gracilis muscle. So there are three muscle which is having a common insertion. What are these three muscle which is having a common insertion? We have got semitendinosus muscle, we have got gracilis muscle, and we have got sartorius muscle. These are the three muscle which is commonly inserting into the medial proximal aspect of tibia. So these three insertion together is called as pec anserine. The nerve supply of sartorius muscle is femoral nerve. And the action is, it causes flexion, it causes abduction, it causes lateral rotation of the hip and flexion of the knee. Nerve supply and action. Now, if I talk about the nerve supply of sartorius muscle, it is from the femoral nerve. What is the nerve supply? Just a minute. What happened? Okay. So, if I talk about the nerve supply, it is actually okay. Is it clear now? It's actually from the its innervation is from femoral nerve, and its action is, please note down, action of sartorius muscle is very important. It is causing abduction, flexion and the lateral rotation of the hip, and it is causing flexion of knee. So it is important for you to note down, this is the action of sartorius. It is causing flexion of both hip and knee. So sartorius muscle is causing both the flexion of hip and the knee, and it is also causing abduction and lateral rotation of the hip joint. So this is basically highly important for you to understand. Now let's talk about quadriceps femoris muscle. So when I am using the word quadriceps femoris muscle, it means it is consist of four muscle. So here you can see The superiorly you can see this is the rectus femoris muscle. Which muscle is this? This is the rectus femoris muscle. And morphologically, if you will see the rectus femoris muscle, what you can appreciate about rectus femoris muscle, it is bipinnate in nature. It is bipinnate in nature, and other than that, it is having vastus medialis, vastus intermedius, and vastus lateralis. Okay. Vastus, let's talk about quadriceps femoris muscle. Quadriceps femoris muscle is made of four individual. Quadriceps femoris muscle is made of four muscles. It is made of four muscles. That is rectus femoris, that is vastus lateralis, vastus medialis, vastus intermedius, and that of articular genu. Actually, why I have written articularis genu? Because vastus intermedius part is also vastus intermedius. It's a part of vastus intermedius muscle only. So basically, only four muscle is there. If I talk about this, is exactly you can get confused with this fifth point. So just for remembrance is important that vastus intermedius is giving rise to articularis genu muscle. So basically, quadriceps femoris is consist of four muscle, that is the rectus femoris, vastus medialis, vastus intermedius, vastus lateralis, and articularis genu is a part of vastus intermedius muscle. Now let's talk about the muscle one by one. So I would like to firstly talk about vastus lateralis muscle. Vastus lateralis muscle. Vastus lateralis muscle. Vastus lateralis muscle. Now, origin of vastus lateralis muscle. If I talk about origin of vastus lateralis muscle, it originates from greater trochanter. It originates from intertrochanteric line. It originates from greater trochanter. It originates from intertrochanteric line and linea aspera of the femur. Okay, insertion. Patella, it is inserting into the patella by quadriceps tendon, tibial tuberosity of patellar ligament. The nerve supply is femoral nerve, and the action of vastus lateralis. If I talk about the action of vastus lateralis, it extends and stabilizes the knee. It extends and stabilizes the knee. So this is the whole detail of vastus lateralis muscle, which is originating from the greater trochanter. It is originating from the greater trochanter, so intertrochanteric line and linea aspera. So all these parts are the parts of femur. Okay, my dear students, you have to know the idea that where these muscles are located. Okay, at times you can get confused ki itna detail par main, why we have to study so much detail of these muscles, because we know that there are 206 bones and there are multiples of the muscles. So each and every muscle becomes very difficult for you to understand. But you should have an idea of location of these muscle and a certain important muscle, like for example sartorius muscle, action and its attachment is most important. Quadriceps femoris muscle, as I already told you, it is made of four muscles, so that inserts into the patella bone. So that insertion is only important, that is inserting into the patella bone. So that is enough for you. And if I talk about its attachment, so it will be like, for example, by the name only you can remember, vastus lateralis means it lies on the lateral aspect of the thigh. Vastus medialis means it lies in the medial aspect. Rectus femoris, when you will cut, beneath it you will get the vastus intermedius muscle in the intermediate location. So vastus lateralis originating from the femur, and all these muscles, all these four muscles are together inserting into which bone? Together they are inserting into the base of patella. So that is important. Together these muscles are inserting into the patella bone via quadriceps tendon, via which structure? Quadriceps tendon and in tibial tuberosity. The nerve supply is femoral nerve and the action of these muscles. So the common action all the muscles of anterior compartment of thigh has got a common nerve supply, that is femoral nerve. So if I am talking about all the muscles of anterior compartment of thigh, they are having a common innervation by femoral nerve, and they are having a common action, that is they extends the knee and stabilizes the knee. Vastus medialis, now if I am using the word vastus medialis, it means it will originate from the medial side of femur and will insert into quadriceps tendon to the base of patella. The nerve supply is femoral nerve and the action is it extends the knee. It extends the knee. This is vastus medialis muscle. Now, vastus intermedius muscle. So, if I am using the word vastus intermedius, it is originating from anterolateral aspect or anterolateral surface of the femur. Insertion, as I told you, it is commonly inserting into quadriceps tendon. Nerve supply is femoral nerve and action will be similar, that is extension of knee. Articularis genu, as I told you, it is a small muscle on the anterior aspect of lower femur. It is a small muscle on anterior aspect of the lower part of the femur. It is inserting into the suprapatellar bursa. Nerve supply is femoral nerve and the action is it is pulling the suprapatellar bursa during the position of extension of knee. So it is articularis genu. It is pulling the suprapatellar bursa during the extension of knee. It is pulling the suprapatellar bursa during the extension of knee. Okay, dear, pulling the suprapatellar bursa during the extension of knee. Articularis genu. Got it? So we have done with all the muscles. The next important topic is femoral triangle. The next important topic is femoral triangle. So you can see a yellow dotted area has been shown here. So you can see a yellow dotted area has been shown in this image, and you have to understand the boundaries, you have to understand the contents, and you have to understand the roof and the floor of femoral triangle. So femoral triangle is located onto the anterior aspect of thigh, and its boundaries are superiorly, or the base is formed. If I talk about superior aspect of the base, it is formed by inguinal ligament, which is extending from anterior superior iliac spine to pubic tubercle. So if I talk about inguinal ligament, it is formed from the lower part of the arched fibers of external oblique muscle, and it is extending from anterior superior iliac spine to pubic tubercle. If I talk about its medial boundary, medially it is bounded by adductor longus, laterally it is bounded by sartorius muscle. So medially it is bounded by adductor longus muscle and laterally it is bounded by sartorius muscle. Laterally, it is bounded by sartorius muscle and medially by adductor longus muscle. Now, coming to the contents which is lying inside, and so this is about its boundaries. Now, in this image, let me first explain you, then I will, here we can see the muscles forming the floor of femoral triangle has been shown. So, here we can see all the muscles which is forming the floor of femoral triangle. So, if I talk about the muscles which is forming the floor of femoral triangle, we have got following muscle. We have got the mnemonic for the muscle is epi. The mnemonic for the muscle is epi. APPI. Okay, A for adductor longus. So as you proceed from medial to lateral, the muscles are epi. A for adductor longus, P for pectineus, P for psoas major muscle, and I for iliacus. I for iliacus. So we have got following muscle. We have got adductor longus muscle. We have got pectineus muscle. We have got psoas muscle tendon, and we have got the iliacus muscle. So we have got 4 muscles forming the floor of femoral triangle as you proceed from medial to lateral. As you proceed from medial to lateral, so that muscles are, that mnemonic will be epi, APPI. So muscles are from medial to lateral. Okay. Now the important contents which is lying. So actually it is also important to know the contents. So if I talk about the roof of femoral triangle, it is formed by skin and superficial fascia. So roof is formed by skin and superficial fascia, and important contents are lying in the superficial fascia. So we will have superficial inguinal lymph node, we will have great saphenous vein in it. So basically in that case, roof is having a is formed by fossa lata, having a saphenous opening, and the superficial fascia which is covering it will have important contents like superficial branches of femoral artery, superficial inguinal lymph node will be there, and there will be the femoral branch of genitofemoral nerve and branch of ilioinguinal nerve. So all these are the contents of roof of femoral triangle. What contents exactly lie inside the femoral triangle? So if you will see the important contents as shown here, from medial to lateral. So medial most part has been shown with green color. What is this green color? This is actually femoral canal. Upper part of it is called femoral ring. So green color is for the lymphatics. What it contains? If I am using the word, if I am showing you and enlarging it, this green color area is the medial most content, and this will contain the this will contain deep inguinal lymph node. Then we will have the femoral vein as shown in blue color, the femoral artery in red color, and the nerve, femoral nerve as the lateral most content, which is lying in outside the femoral sheath. So basically these are important contents. Other than that, we have got 6 branches of femoral artery as the content, 3 superficial and 3 deep. We have got important nerves as the content. So we will also have important contents like the lateral femoral cutaneous nerve of thigh, deep inguinal lymph node, femoral branch of genitofemoral nerve. So all these are the contents of femoral triangle. So let's write the details of femoral. After this description, I want everybody to write the details of femoral triangle. So please write down. Femoral triangle. It is triangular. It is triangular depression. Femoral triangle. It is triangular depression on the front of thigh. On the front of thigh. On the frontal upper 1/3 of thigh below inguinal ligament. And the apex of femoral triangle is directed downwards. The apex is directed downwards. Now let's talk about boundaries. So it is important to understand the boundaries of femoral triangle. So it is bounded, if I talk about lateral aspect, it is bounded by the medial border of sartorius muscle. So lateral aspect, it is bounded by medial border of sartorius muscle. Medially, it is bounded by medial border of adductor longus, and base is formed by inguinal ligament. Apex of the femoral triangle is formed by the meeting point of, it is formed by the meeting point of adductor longus and that of sartorius muscle, and that of sartorius muscle. Okay. Boundaries. So write down the boundaries of femoral triangle are as follows. Laterally it is bounded by medial border of sartorius muscle. Medially it is bounded by medial border of adductor longus muscle. Base is formed by inguinal ligament. Base is formed by inguinal ligament. Base is formed by inguinal ligament, and apex apex is formed by apex is formed by Meeting point of apex is formed by meeting point of medial border and meeting point of medial border of adductor longus and sartorius muscle and that of sartorius muscle. So this is about the boundaries of femoral triangle. And if I talk about the important points about, let's talk about the femoral triangle floor. Femoral triangle, so if I talk about the floor, it is gutter shaped and it is muscular. It is gutter shaped, and muscular. So from medial to lateral, it is formed by following muscles. So if I talk about from medial to lateral, it is formed by following muscles. It is formed by following muscles. Okay, it is formed by following muscles. So the important muscles which is forming the floor of femoral triangle is following. So that muscles are iliacus. So from medial to lateral. So yes, API is the mnemonic, no sorry. So the mnemonic is AP, APPI. What is the mnemonic dear? APPI. So we will have adductor longus. We will have pectineus. We will have psoas major muscle. And we will have the iliacus muscle. And we will have the iliacus muscle. So these all muscles are forming the floor of femoral triangle. All these muscles are forming the floor of femoral triangle. Got it? Now let's talk about the content of femoral triangle. So basically the content has been shown in this image also, and basically here I just want you to show an artery for more elaborate description of the branches of artery. So here if you will see, this is the external iliac artery, and below inguinal ligament it will form the femoral artery. So basically this line is, so basically this is the this is the inguinal ligament. Okay, what is this? That is the inguinal ligament. So the important branches are, if I talk about external iliac artery, and below the inguinal ligament it is called as femoral artery. What is it called as? It is called as femoral artery. It is called as femoral artery. The important branches are three branches it gives. So basically three branches it gives, and the important three branches superficial is external, superficial epigastric, superficial external pudendal, and superficial circumflex iliac. These are the three superficial branches. It also gives deep external pudendal. It gives profunda femoris artery. This larger branch which is given here on the lateral aspect, this is profunda femoris artery, and other than that it gives muscular branches. So all these branches which I have highlighted here, basically 6 branches of the femoral artery is given in the femoral triangle. I will write down the name. So this image is showing you femoral artery. Femoral artery is the continuation of external iliac artery below inguinal ligament, and 6 branches of femoral artery are the content of femoral triangle. Okay, and lower down when it passes through the adductor magnus hiatus, it changes its name to popliteal artery and traverses in the popliteal fossa. Now here this is again, actually I just want you to show this image which is showing you profunda femoris artery. Now profunda femoris artery is the largest. If I talk about profunda femoris artery, it is the largest branch of femoral artery, and it is giving important branches. So it is giving medial and lateral circumflex femoral artery. Important branches are medial and lateral circumflex femoral artery, which will subsequently medial and lateral circumflex femoral artery, which also gives other branches. So medial lateral circumflex femoral artery will other again give ascending, transverse and descending branches. So profunda femoris artery will further give ascending, descending and transverse branches. Other than that, the profunda femoris artery will also give perforating arteries, and it will give muscular branches. What it gives? It gives muscular branches. So all these are the branches of femoral artery. So let's write the content of the roof and the content of. So we'll write the content here. So firstly, I would like to write the contents of the roof. Femoral triangle. So please write on the heading. Actually, any doubt, you please let me know. Happy, yes, you are right, Osama. You are right, Osama. Actually, the thing is that why it is separately important to write the contents of roof and contents of the triangular space lying inside. So femoral triangle, exact contents lying inside, because students get confused in these two topics, and basically all a few contents are similar only, but few contents are different. For example, in superficial fascia there lies superficial inguinal lymph node. In the femoral triangle inside there is deep inguinal lymph node, which is also called as lymph node of Cloquet or Rosenmuller. Okay, so that is one difference. Other than that, it will have femoral artery, femoral vein and femoral nerve as the content, and medial most content is the femoral canal, which contains the deep inguinal lymph node. Other than that, we have got few nerves also as the content. For example, lateral cutaneous nerve of thigh is the content of femoral triangle inside, but the genitofemoral nerve branch, femoral branch, and that of ilioinguinal nerve will be the content in the superficial fascia of the roof. Great saphenous vein is the content in superficial is in the content of roof, and it's passing through the deep fascia opening, saphenous opening, and drain into femoral vein. Other than that, we will have three superficial branches of femoral artery, that is superficial external pudendal, superficial circumflex iliac, superficial epigastric. These are the contents of roof part. But other than that, three more branches are the content of the femoral triangle inside. It will have muscular branches, it will have deep external pudendal, and it will have the profunda femoris artery as the branches. So that is very, very important for you to note down. So please write on this. Write on the heading roof of femoral triangle. Roof of femoral triangle. Roof of femoral triangle. Roof of femoral triangle. It is formed by roof of femoral triangle. It is formed by fascia lata. It is formed by fascia lata having saphenous opening. The superficial fascia the superficial fascia so the superficial fascia the superficial fascia overlining the roof contains contains superficial branch of and accompanying veins. It contains superficial branches of femoral artery and accompanying veins. Okay. So if you want, you can write down the name of three superficial branches of femoral artery and the three superficial branches of femoral artery. Basically, I am targeting about the content of the roof. So the three superficial branches of femoral, as I have shown you in the image, anyone wants to write that answer? Anyone remembers the name of superficial branches of femoral artery? The three superficial branches of femoral artery is superficial circumflex iliac, superficial epigastric, superficial external pudendal artery. So that is superficial circumflex iliac artery, superficial circumflex iliac artery, superficial circumflex iliac artery, superficial circumflex iliac artery, superficial external pudendal. Yes, Osama is absolutely right. Yes, Osama, you are absolutely right. Superficial external pudendal artery. So in between, it is important that I should also ask you about the important branches, and you can write so that I will get an idea of conversation. Okay, yes, you are absolutely right. Superficial external pudendal. One more, superficial epigastric artery. Superficial epigastric artery. Absolutely correct, Osama. Absolutely correct, dear. Absolutely correct. So basically, superficial fascia overlying the roof will contain superficial branches of femoral artery and the accompanying vein. Also, so these are the first important content. The other important contents is upper part of great saphenous vein. Upper part of great saphenous vein. Upper part of great saphenous vein. Superficial inguinal lymph node. Superficial inguinal lymph node. Femoral branch of genitofemoral nerve. Other than that, okay, so other than that, fourth one is femoral branch of genitofemoral nerve. Femoral branch of genitofemoral nerve. And branches of ilioinguinal nerve. Ilioinguinal nerves. So done. This is all the contents. These are all the contents of roof of femoral triangle. So if you want, I will just enlarge once more. Roof of femoral triangle will contain three superficial branches of femoral artery. It will contain branch of ilioinguinal nerve. It will contain superficial inguinal lymph node. It will contain femoral branch of genitofemoral nerve. So that is all the great. So it will contain the upper part of great saphenous vein, superficial inguinal lymph node, femoral branch of genitofemoral nerve, and the branch of ilioinguinal nerve. So these are the contents of the roof of femoral triangle. Now I would like to talk about the contents. So please write on the heading the contents of femoral triangle. So the content, so write on the heading contents of femoral triangle. Contents of femoral triangle. Contents of femoral triangle. So when I am talking about the contents of femoral triangle, the important contents of femoral triangle as following. It contains femoral artery and its branches. It contains femoral artery and its branches. So basically when I am talking about the word femoral artery and its branches, I mean to tell about the 6 branches it gives. It gives 6 branches. So femoral artery and its branches, so 6 branches. 6 branches are the content of femoral artery. What are these? 6 branches. So they are superficial epigastric artery, 3 superficial and 3 deep. So superficial epigastric, superficial circumflex iliac, artery, superficial external pudendal, superficial external pudendal artery. So basically these are 3 branches. So basically these are the 3 so exactly, yes Bindu, you're right, these are the 3 superficial branches which is the content, and other than that 3 deep. If you remember in the image I have shown you the 3 deep branches. And what are the 3 deep branches? The 3 deep branches are deep external pudendal, muscular branches, and profunda femoris artery. So they are deep external pudendal artery, deep muscular branches, and profunda femoris artery, So these are the 6 branches. So femoral artery and its 6 branches. These are the femoral artery and its 6 branches which is forming the content of femoral triangle. Femoral artery and its branches is forming the content. Okay, also we have got femoral vein as the content. So other content is femoral vein and its tributaries. The contents are femoral vein and its tributaries. The other content is femoral nerve. The other content is deep inguinal lymph node. Actually, deep inguinal lymph node is the medial most content. So, if I am talking about the lymph nodes, it forms the medial most content of femoral triangle. So, deep inguinal lymph node, deep inguinal lymph node, deep inguinal lymph node is the medial most content. It is also called as lymph node of Rosenmuller. It is also called as lymph node of Rosenmuller or lymph node of Cloquet. Deep inguinal lymph node. Other than that, it also contains lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. So branches of femoral nerve also, nerve to pectineus. Nerve to pectineus is also the content, which is a branch from femoral nerve. Femoral branch of genitofemoral nerve. Femoral branch of genitofemoral nerve is also the content. Femoral branch of genitofemoral nerve is also the content, and fibrofatty tissue, and that of fibrofatty tissue. So all these are the contents. So we can see all these. That is the content of femoral triangle. We have got a femoral artery and its branches as the content. We have got the vein. We have got the vein as the contents. That is the femoral vein. Then we have got the femoral nerve as the content. We have got deep inguinal lymph node as the content. Then we have got the lateral femoral cutaneous nerve of thigh as the content, lateral femoral cutaneous nerve of thigh as the content. Then nerve to pectineus, femoral branch of genitofemoral nerve, femoral branch of genitofemoral nerve, and fibrofatty tissue. So all these are the contents of the femoral triangle. All these are the contents of femoral triangle. Now talking about, now I would like to show you this image where you can understand the important content. So here, this is the artery which is the content, the femoral artery. This is the vein. This is the vein which is the content, and this is the nerve which is the content. So basically in this image, three contents has been shown. So basically three contents has been shown in this image. The femoral, so we can see here FN means femoral nerve is the content, femoral artery is the content, and femoral vein is the content. These are the three contents. Okay, can you see here? From medial to lateral, we have got the three contents: vein, artery, and nerve. But other than that, medial most content ki baat kare, if I am talking about the medial most content of the femoral triangle, that is the deep inguinal lymph node. We have also got the muscle as the content. So we have got this is forming the floor muscle, adductor longus, which is also forming the wall. We have got the pectineus muscle. We have got I for iliacus and psoas major muscle tendon, PM for psoas major muscle tendon, and this green color highlighted area is the boundary of femoral triangle. One more image is there which is showing you the femoral sheath. So I just want everybody to pay attention to this femoral sheath. What is this? This is the femoral sheath, and this femoral sheath is covering upper 3 to 4 centimeters of the femoral vessels. So we will have the femoral sheath. So this is a femoral, FS means femoral sheath, which is covering the upper 3-4 centimeters of the femoral vessels. And here we will have femoral nerve, which is lying outside the femoral sheath. We can see the sartorius muscle, and we know that sartorius muscle will form the lateral boundary. The adductor longus muscle will form the medial boundary, and we will have pectineus and iliacus and psoas major muscle as the muscle of the floor. Now the next topic which you should understand is the femoral sheath. What is the next topic? Is the femoral sheath. So when I am talking about femoral sheath, it is a funnel shaped fascicle sheath. As this is a schematic diagram to make you understand the femoral sheath. So it's a funnel shaped fascicle sheath, as you can see in this diagram also. You can. So this is showing you the femoral sheath. Okay, so if you will see the femoral sheath, here we can see the femoral sheath. It is a fascicle sheath which is covering upper 3 to 4 centimeters of the femoral vessel, femoral vein, artery. It also contains the femoral lymph node. So the medial most content of femoral sheath is the femoral it's containing the femoral canal, which contains the deep inguinal lymph node. So femoral sheath is a fascicle sheath enclosing upper 3 to 4 centimeters of femoral vessel, and it is dividing into three compartments. It is divided into three compartments. Medialmost compartment is called as the femoral canal. What is the medialmost compartment called as? Medialmost compartment is called as femoral canal. The intermediate compartment is containing femoral vein, and the lateralmost compartment is containing femoral artery along with the femoral branch of genitofemoral nerve. So this diagram is showing you the schematic diagram of femoral sheath. This diagram is a schematic diagram showing you the femoral sheath. Okay. Now, so let's talk about, so I also would like to tell you about femoral canal. Actually, femoral canal is the medial most compartment of the femoral sheath, and the upper border of femoral canal is called as femoral ring. And a fibroareolar tissue is called as femoral septum, which is covering this this ring, and it contains deep inguinal lymph node of Cloquet. So actually, if we are talking about the femoral ring boundary, anteriorly there will be the inguinal ligament. So yeah, see here, This is the femoral canal, and medial most compartment of femoral sheath is called as femoral canal. Upper part of femoral canal is femoral ring. So anteriorly it will have inguinal ligament, posteriorly it will have pecten pubis, medially lacunar ligament, and laterally, as you can see in the diagram also, this is femoral vein. So laterally it will have the femoral vein. Okay, now, so it's important to know about the details of all these structures here also. Okay, so basically first thing is the femoral sheath, which you have to understand. So let's write firstly the details of femoral sheath. Femoral sheath. Femoral sheath. It is funnel shaped fascicle sheath. It is funnel shaped fascicle sheath enclosing 3.75 centimeters or 3 to 4 centimeters of femoral vessels. The base of sheath is directed upward. So basically the anterior wall of femoral sheath, the anterior wall of femoral sheath, the anterior wall of femoral, the anterior wall of femoral sheath is downward prolongation of, fascia transversalis. So basically अगर हम बात करते हैं anterior wall of femoral sheath, if I am talking about anterior wall of femoral sheath, it is formed by fascia transversalis, and posterior wall of femoral sheath, posterior wall of femoral sheath is formed by downward prolongation of fascia iliaca. It is formed by downward prolongation of fascia iliaca. Okay, so this is the overall details of femoral sheath, which is a fascicle sheath which is enclosing upper 3-4 centimeters of the femoral vessel. It is very important for you to note down that the femoral nerve is lying outside the femoral sheath. It is having an anterior wall and it is having a posterior wall. If I am talking about anterior wall, it is formed by fascia transversalis, and posterior wall is formed by fascia iliaca. Got it? Now the next important point is femoral canal, which you have to know. So please write down. Actually, one more thing is important, that femoral sheath is having 3 compartments. If you want to write, you can write down. So here itself you can write down, it is having it is divided into 3 compartments, and you have to know the contents of each of these compartments. So it is having 3 compartments. So write down. Medial compartment contains, so if I talk about medial compartment, it contains deep inguinal lymph node. It contains deep inguinal lymph node. And if I talk about deep inguinal lymph node, it is very important for you to understand that deep inguinal lymph node is also called as lymph node of Rosenmuller or Cloquet. What about the intermediate compartment? Can anybody tell me? Intermediate compartment contains, can anybody tell me intermediate compartment contains which structure? Intermediate compartment. Intermediate compartment of femoral sheath contains which structure? Anyone? Intermediate compartment of femoral sheath is containing which structure? Yes, absolutely right, Abu. Absolutely right, Osama. Yes, it contains. Yes, absolutely right. It contains femoral vein. Absolutely right. Now next thing is, what about the lateral most compartment? Lateral compartment. Lateral compartment. If I talk about lateral compartment, the lateral compartment of femoral sheath contains, the lateral compartment of femoral sheath contains femoral artery and femoral branch of genitofemoral nerve. Femoral, it contains femoral artery and it contains femoral branch of femoral branch of genitofemoral nerve. Okay, it contains femoral branch of genitofemoral nerve. It contains femoral branch of genitofemoral nerve. Got it? Got it, everyone? Now, let's talk about, yes, absolutely right. Now, let's talk about femoral canal. What is femoral canal? So, femoral canal is a short fascicle tube, which is called as the which is the medial compartment, which is the medial compartment of femoral sheath. So if I am talking about femoral canal, it is the medial compartment of femoral sheath. It is the medial compartment of femoral sheath. It is the medial compartment of femoral sheath. And we already know that it contains lymph node of Cloquet. So I'm not writing once again. I'm just writing the, so you can just write down the upper end of the upper end of the upper end of the upper end of femoral canal, the upper end of femoral canal, the upper end of femoral canal is called femoral ring, and the boundaries of femoral ring, So if I talk about boundaries of femoral ring, the boundaries of femoral ring are following. Now, boundaries of femoral ring. If I am talking about boundaries of femoral ring, the boundaries of femoral ring are as following. The boundaries of femoral ring as follows. Anteriorly it is bounded by inguinal ligament. Anteriorly, the femoral ring boundary is inguinal ligament. Medially, it is bounded by sharp edge of lacunar ligament. It's the sharp edge of lacunar ligament. Posteriorly, it is bounded by pecten pubis. And laterally, it is bounded by femoral vein. So this is overall boundaries of femoral ring. So this is actually overall boundaries of femoral ring. This is important for you to know. It is anteriorly bounded by inguinal ligament, medially by lacunar ligament. Actually, lacunar ligament is a medial extension from the deeper aspect of inguinal ligament, posteriorly by pecten pubis, which is a part of hip bone, laterally by femoral vein. And actually, when femoral ring is weakened, there can be a chance of femoral herniation through this. So femoral hernia is a very important topic which I want everybody to understand. So basically, firstly, let me explain about femoral hernia. So the protrusion of the abdominal content which takes place as, for example, loop of intestine can pass through femoral canal weakness through the femoral ring, and this is globular herniation which will be seen below inguinal ligament, as you can see. So it is exactly femoral herniation. If I talk about its location, is femoral hernia location will be below the inguinal ligament. It is actually infralateral to that of pubic tubercle and below the inguinal ligament. Femoral ring is the site of potential weakness of femoral sheath, and that is from where the femoral herniation takes place. Now, actually, here I just wanted to show that fascia transversalis is there, which is forming anterior wall of femoral sheath. Fascia iliaca will be forming the posterior wall of femoral sheath. And here you can see there is femoral artery. Here there is femoral artery. So this is the femoral artery. Okay, so femoral artery, so direction of femoral hernia. So femoral artery will protrude through the femoral sheath medial most content or compartment through femoral canal, and as shown in this diagram. And here I just want you to show this image where, okay, I just want to write few important things here. So actually in this diagram, you can clearly see this is the femoral nerve, this is the femoral artery, and this is the femoral vein. And this is the herniated sac. What is this? This is the herniated sac of femoral hernia. Now this part which you are seeing, this part, so let me use green color for this. So this part is the triangular ligament, is the lacunar ligament. So what you can see in this image, there is lacunar ligament. So this is the lacunar ligament. This is the lacunar ligament. What is it? This is the lacunar ligament. Okay, so triangular, if you will see the femoral ring, it's on a medial aspect, has got a lacunar ligament which is triangular in outline, and it is forming, if we talk about femoral ring. So basically, if you want to, I just want a question from everyone, those who are live. If we want to, good morning, yes, Aroda, Aradhana, Aroda, good morning, ma'am. Okay. So Jagat Boris, yes. So what you can see, there is a lacunar ligament on the medial side. We know that femoral ring is medially bounded by lacunar ligament. Now, once you want to enlarge this femoral ring so that you can operate in the femoral herniation, so you want to enlarge it. So you will cut the which ligament, lacunar ligament or the femoral vein which is lying laterally. So you want to treat the case of strangulated femoral hernia. So you want to push back the femoral sac herniation, and in that case you have to cut the which ligament? Obviously you will cut the lacunar ligament which is lying medially, because there is femoral vessel on the lateral aspect. Now what happens? Sometimes you can see there is a presence of abnormal obturator artery. So sometimes there is a presence of abnormal obturator artery, and this abnormal obturator artery is lying on the lacunar ligament. Okay, abnormal obturator artery is lying on the lacunar ligament. So so invariantly, by mistake, if you don't pay attention to the anatomy, so this is not always present, but sometimes there can be a present of abnormal obturator artery, which is a branch of inferior epigastric. Normal obturator artery is a branch of anterior division of internal iliac artery. Abnormal obturator artery can lie medially or lacunar ligament, and if the surgeon blindly cuts the lacunar ligament, there will be bleeding, anomalous bleeding from the abnormal obturator artery, and huge hemorrhage will be there. So this is very important. So this is very important for you to understand. Is it okay, everyone? Okay. Now, other than that, there is also Schwarz muscle, we know that psoas and iliacus is inserting into lesser trochanters, sometimes the vertebrae or the bone. So sometimes what happens, the vertebrae and the bones can have infection, tuberculosis infection and all. So the infection can pass via abscess can be formed, and that can pass via psoas major iliacus to that of, from the abdominal lower region to that of the lower limb area. So that is how the psoas abscess is formed, and it is dangerous. So let's talk about femoral hernia. Femoral hernia. This is femoral hernia. The protrusion of abdominal content that is loop of intestine through the femoral canal is called femoral hernia. The femoral hernia is, write down, the femoral hernia presents as a globular swelling. The femoral hernia presents as a globular swelling in groin region infralateral to the pubic tubercle below the inguinal ligament. Okay, the femoral ring is a site of potential weakness in the groin region, and that is the site from where the femoral herniation takes place. Now, this is the direction. As you can see, this is going downwards towards the femoral canal, then it will traverse forward and upward. So the direction of femoral herniation is downward, forward and upward. Now, sometimes you can write sometimes on the lacunar ligament abnormal obturator artery is located. Abnormal obturator artery is located and can be accidentally and can be accidentally or by mistake, and can be cut by mistake in repair of strangulated femoral hernia. Femoral hernia. In repair of strangulated femoral hernia. Okay. Now that is so that and also please note down abnormal obturator artery is abnormal obturator artery. Abnormal obturator artery is branch of abnormal obturator artery is a branch of inferior epigastric artery. And in the abdomen and pelvis session, I told you normal obturator artery is, can anybody tell me, normal obturator artery is a branch of? Yes, yes, Bindu. If there is an ovarian tumor or mass, at times the obturator nerve can be compressed. Yes, if it is more towards the obturator foramen, then it can cause compress. Yes, Bindu, it can be happen. So, can anybody tell me normal obturator artery is a branch of which artery? I have told you in the pelvis class, normal obturator artery is a branch of anterior division of internal iliac artery. Yes, Abu is so yes, you are absolutely right. It is Abu who is absolutely right here. So a thumbs up goes for him. Yes, you are absolutely right there. Now, can we solve few MCQs? Everyone, are you ready? Can we solve few MCQs related to this topic? Everyone. So let's solve few MCQs. So let's solve the first. Action of sartorius muscle include all except so action of sartorius muscle includes all except action of sartorius muscle includes all except flexion of thigh, flexion of leg, extension of leg, lateral rotation of thigh. So what is your answer? Anyone? So action of sartorius muscle is all except all except. So sartorius muscle is also called as the palthi muscle or talar muscle. Earlier times, so it is also called as palthi or talar muscle. So that will help you to give the correct answer. Action of sartorius muscle includes all except. So you can give me the right answer here. Lateral rotator of thigh, no, that is not correct. One, please understand, extension of leg, what do you mean by, can you make a palthi or tailors? Can you sit by keeping your knees flexed? No. So I told you sartorius is a muscle which is causing flexion of knee and thigh both. It is can't cause extension of knee. It can't cause extension of knee. So what is the right answer, dear? Extension of knee. So extension of knee is not the action of sartorius muscle. It is causing flexion of thigh and both the flexion of leg. So this is very, very important. So the correct answer will be extension of leg. Extension of leg is not done. Extension of leg is not done by the sartorius muscle. Now, next question is, which is the most medial content of femoral triangle? Which is the most medial content of femoral triangle? Which is the most medial content of femoral triangle? I got an answer from Abu. I got an answer from Saloni. So basically, those who have given me A as the right answer, I told you medial most content is the lymphatic. So those who have given A as the answer, a clapping for them. Yes, absolutely right. The correct answer will be lymphatics. Deep inguinal lymph node is the medial most content. Yes, Rosenmuller, lymph node of Rosenmuller or Cloquet. Absolutely correct. Now, all are the contents of femoral triangle except, all of the following are the contents of femoral triangle except femoral artery, femoral vein, superficial inguinal lymph node, nerve to pectineus. All are the contents of femoral triangle except So I told you separately the contents of roof and the content lying inside. So that is the hint which is given to you. All are telling D. Okay, nerve to pectineus. Nerve to pectineus is a branch of femoral nerve only, dear. I have given you the list. All are the contents of femoral triangle except superficial inguinal lymph node, dear. Superficial inguinal lymph node. Superficial inguinal lymph node is the content of. Yes, now Abu has got the right answer. Yes, now everyone is having the right answer. It's the C. It's the C, dear, because it is the content of roof. It is lying in the roof, so it will be the content of roof, not lying inside. Deep inguinal lymph node lies inside. No, deep inguinal lymph node. Nerve to pectineus is a branch of femoral nerve only, so it is also the content of femoral triangle. And I have shown in the list also. If you will see, you can have the list. See here. See here, nerve to pectineus is the content. So see here, content of femoral triangle, and I have given you 6 branches of femoral artery, femoral vein, deep inguinal lymph node. Nerve to pectineus. Nerve to pectineus is the content of the femoral triangle. So best answer is superficial inguinal lymph node. So the best answer is superficial inguinal lymph node. Okay, now next question. Muscle attached to the arrow mark structure. Yes, yes, Bindu, you are right. Muscle attached to arrow marked bony structure. So in this radiological image, let me slightly enlarge this image. So everyone, can you see this yellow color arrow? The yellow color arrow is on the one of the trochanter of femur. So please identify whether it is lesser trochanter or whether it is greater trochanter. Okay, Saloni is telling it is lesser trochanter. Now tell me that muscle which is attached to the lesser trochanter of the femur. Ahmad has given the answer. Saloni has given the answer. What about others? Abu has given the answer. Yes. And the right answer is iliopsoas. Absolutely correct. The right answer is iliopsoas. Yes, the right answer is iliopsoas. Absolutely correct. Iliacus and psoas major muscle together is inserted into the lesser trochanter of the femur. Now, all are the contents of femoral sheath except which of the following is not the content of femoral sheath? Which of the following is not the content of femoral sheath? Those who have given femoral nerve, they are right because femoral nerve is lying outside the femoral sheath. Yes, femoral nerve is the right answer because femoral nerve is lying outside the femoral sheath. Absolutely correct. Femoral nerve lies outside the femoral sheath. Now the next topic is medial compartment of thigh. The next topic is medial compartment of thigh. So if I am talking on medial compartment of thigh, you have to know about the muscles lying in the medial compartment of thigh and you have to know about the action and the nerve of medial compartment of thigh. So when I am using the word medial compartment of thigh, we have to know all the structures which is residing in the medial compartment of thigh. So medial compartment of thigh is also called as the adductor compartment of thigh, and basically it is having following muscles. It is having pectineus, it is having adductor longus, adductor brevis, adductor magnus, gracilis muscles. So all these muscles are the muscles of medial compartment of thigh. So the nerve of medial compartment of thigh is optic nerve. So medial compartment of thigh is also called as the adductor compartment of thigh and it contains following muscles. It contains following muscle. It contains adductor magnus muscle. It contains adductor longus. It contains adductor brevis. It contains pectineus muscle. It contains gracilis muscle. Okay, so these are most important muscle. Obturator externus is also explained in this sometimes, but most important muscles of this list. So one by one we will talk about these muscles. So let's talk about these muscles. So firstly, in the middle compartment of thigh or adductor region of thigh, I would like to tell you about all the muscles located in this region. Then I would like to tell you about the adductor canal, the Hunter's canal, its boundary and its content. So let's talk one by one. So adductor magnus, adductor magnus. Adductor magnus. So when I am talking about adductor magnus muscle, the origin of adductor magnus is from, if you will see, adductor magnus is the bulkiest muscle. It is the largest and the bulkiest muscle of adductor compartment. If I am talking about this adductor magnus muscle is the largest muscle of the adductor or the medial compartment of thigh. It is having dual nerve supply because it is having dual origin. So it is also originating from the pubis bone. That is, most of the muscle is originating in the middle compartment or adjoining area of the pubis bone, but it is also originating from ischial tuberosity. Now ischial tuberosity, if I am talking about ischial tuberosity is common origin of hamstring muscle. That means adductor magnus muscle is having two origin. One is adductor origin from the pubis and the other is the hamstring origin which takes place from the ischial tuberosity. If I talk about insertion, the insertion is occurring in the linea aspera and adductor tubercle of the femur. Where it is inserting? It is inserting into linea aspera and adductor tubercle of the femur. The nerve supply is from posterior branches of obturator nerve and also from the tibial component of sciatic nerve. So adductor magnus is a hybrid muscle. It's a hybrid muscle which is also called as composite muscle. The other name is composite muscle. So it's a hybrid muscle or a composite muscle. Why? The reason is that it is having two sources of innervation. Its hamstring part is innervated by tibial component of sciatic nerve and its adductor part is innervated by obturator nerve posterior division. The action is, major action will be adduction of the hip. Other than that, it also causes flexion of hip and the hamstring component is causing extension. So if I am talking of adductor magnus muscle, it is having two components. The adductor portion will cause flexion of the hip and the hamstring portion will cause the extension of the hip. The major function will be adduction of the hip. Adductor brevis muscle. So when we are talking about the next muscle, the adductor brevis muscle, the word brevis means small. It is originating from the body of pubis and inferior ramus of pubis. So it is originating from the pubis and inserting into the femur bone linea aspera. Its action is adduction of the hip and its nerve supply is, its action is adduction of hip and its nerve supply is obturator nerve. What is the nerve supply? The nerve supply is obturator nerve. Yes, Saloni, you are absolutely right. It is supplied by obturator nerve. Now, adductor longus, let's talk about adductor longus. So, if I talk about adductor longus muscle, it's another muscle which is originating from the pubis bone below the pubic crest. Insertion is in the middle of linea aspera. The nerve supply is from the anterior branch of obturator nerve and the action is adduction of the hip is the major action along with the flexion of the hip joint. It is causing adduction of hip along with the flexion of hip joint. This is the action of adductor longus muscle. This is the action of adductor longus muscle. Okay, dear, now we will talk about the gracilis muscle. The next muscle which everyone should understand is the gracilis muscle. Now, as I earlier also told you when we were discussing the muscle of anterior compartment of thigh, there I have pointed about sartorius muscle. The other name of sartorius muscle is Taylor's muscle. It is a palthi muscle, the position of palthi, which was the earlier tailors were sitting in the palthi position and was working constantly at that position, is also called as honeymoon muscle. Many names are given to it. So actually, if we will see the insertion of sartorius, which is a muscle of anterior compartment of thigh, if we will see the insertion of gracilis, which is the muscle of medial compartment of thigh, and if we see the insertion of semitendinosus muscle, the semitendinosus muscle is the muscle of posterior compartment of thigh. So they are arising from the different part of the hip bone, but they are having a common insertion. And what is that common insertion called as? The common insertion of these muscle is on the proximal medial aspect of tibia. It's on the proximal medial aspect of which bone? Tibia bone. Which bone is this? This is the tibia bone. So on the proximal medial aspect of tibia bone, these three muscles together insert, and they are called as guy rope muscle. Guy rope muscle means they are like the tent of, they are like the ropes of the tent, and they have got a common insertion at the proximal medial aspect of tibia, which is pex ansurine insertion. The action of these muscles will be adduction. Along with it, it also flexes and medially rotates the hip. So pex ansurine means, what do you mean by pex ansurine? Is common. It's a common insertion of gracilis, sartorius and semitendinosus muscle, and the semitendinosus muscle on the proximal medial aspect of, on the proximal medial aspect of tibia, on the proximal medial aspect of tibia. Got it? Now the next muscle is pectineus muscle. The next muscle is pectineus muscle. So if I am talking about the pectineus muscle again originates from the pecten bone, from the pectineal line of the pubis bone, inserts into the pectineal line of the femur and the nerve supply. Actually, again, I would like to pay attention to this point. Please mark it. It's very important for you to understand that pectineus muscle is it's a composite or hybrid muscle. When I am using the word composite and hybrid muscle, what do you understand by this? Composite or hybrid muscles are those muscles which is having dual nerve supply. So here the pectineus muscle is having innervation from the nerve of anterior compartment of the thigh, that is the femoral nerve, and it is also getting innervation from the nerve of medial compartment of thigh, that is obturator nerve. So it is having a dual nerve supply, and it is an important muscle which is causing adduction, internal rotation and flexion of the thigh. So done with this. So my dear students, yes, you are highly exhausted, I can see, but please don't get exhausted. I will take you slightly, I want to complete the adductor canal, and then is it okay for everyone? Okay, so let me just, it will take another 10 to 15 minutes, just 10 to 15 minutes, and we will be covering this adductor and medial compartment. Then I will give you a 10 minutes of break, and then again I will start with the hamstring compartment and the leg compartments. Is it okay? 10 minutes more. Then I will give you a break. 10 minutes more. Ten minutes more, then break. Then only I will give you a break. Is it okay? Let me complete this topic also. Adductor canal. So the other name of adductor canal is also called as subsartorial canal. It is also called as Hunter's canal. So actually it is very, very important for you to know the concept of adductor canal, why it is termed as the Hunter's canal and why it is termed as subsartorial canal. So the history is that John Hunter was a great anatomist. He was a great anatomist of his time, and he was also a good surgeon. So earlier what happened, those who want to do surgery, they have to also know about anatomy. So they were both anatomist and a surgeon. So John Hunter started an operation for the repair of popliteal aneurysm. What do you mean by the word aneurysm? Dilatation of the walls of the vessel is called as aneurysm. So if there is dilatation, so for example, if I am talking about popliteal artery and it is dilated and there will be thickening of the tunica adventitia layer of the walls, and ultimately it can burst also, it can. So that is the reason. So we have to treat the case, and the management of popliteal aneurysm was done by ligating the femoral artery in the adductor region. Adductor region means which is located in the middle one third of the thigh, and that is why it is named as Hunter Canal in respect to John Hunter, who was a great anatomist and a great surgeon. Now the next important point is to know subsartorial canal. Why it is termed as subsartorial canal? The reason is why it is termed as subsartorial canal. The reason is that the roof of adductor canal is formed by a sartorius muscle, which is the talus muscle. It is forming the roof, and when you go for dissection and you just remove the sartorius muscle, below it you will have the nerve plexus, and that nerve plexus are called as subsartorial nerve plexus. What is it called as? Subsartorial nerve plexus, which is made by the nerve. So basically there are different kinds of nerves which is located there. So basically it is made by the anterior division of obturator nerve, the saphenous nerve, and the medial cutaneous nerve of thigh. So this group of nerve is lying beneath the roof, so it is termed as subsartorial canal. Okay, also you can see exactly if I talk about adductor canal, it's an intermuscular tunnel shaped structure in the medial middle one third of the thigh. It extends from the apex of femoral triangle. So it is extending from the apex of femoral triangle, and it will extend through the adductor magnus muscle. So it will pass till the level of adductor magnus muscle. So it will be traversing through the tendinous opening of adductor magnus muscle, and it forms a passage of femoral vessel traversing through this region. Now I would just like to show you this image. So this is an image which is adductor canal schematic diagram. So this image is of adductor canal schematic diagram. So when I am talking about adductor canal schematic diagram, so this is adductor canal schematic diagram. So when I am talking about adductor canal as a schematic diagram, two images are there. One is showing you the anterior aspect of anterior aspect. One is anterior aspect view, and the other is a transverse section. So what you can see, the boundaries of adductor canal. So the boundaries of adductor canal, medially it is bounded by sartorius muscle. Medially it is bounded by sartorius muscle. Posteriorly it is bounded by adductor longus, adductor magnus, and laterally by vastus medialis. What will be the boundaries of adductor canal? We have got following structures forming the boundaries, and we have got vessel which is traversing through it. Femoral vessels and the nerves like saphenous nerve, not the femoral nerve, saphenous nerve, femoral vessels, anterior and posterior division of obturator nerve is traversing through the adductor canal, and they are important contents of adductor canal. The roof is formed by sartorius muscle. Posteriorly there lies adductor longus, adductor magnus, and medially we have got sartorius muscle is medially, and also the roof anterolaterally is vastus medialis. So let's talk about adductor canal. Write on the heading adductor canal. It is an intermuscular, tunnel. It is an intermuscular tunnel situated on the medial side of the medial side of the middle one third of thigh. It extends from apex of femoral triangle. It extends from apex of femoral triangle above to the tendinous tendinous opening of adductor magnus below, to the tendinous opening of adductor magnus below. Got it? So this is whole of the adductor canal. Now, if I talk about adductor canal, let's see the boundaries of adductor canal. So let's talk about boundaries. So boundaries are anterolateral wall, anterolateral wall of adductor canal is formed by vastus medialis muscle. Vastus medialis muscle. Posterior, if I talk about posterior wall, the posterior wall or the floor is formed by adductor longus. It is formed by adductor longus muscle and that of adductor magnus muscle. Now the medial and the roof, if I talk about the medial wall and the roof, so medial wall and the roof is formed by, so exactly medial wall and the roof is formed by sartorius muscle, and below the sartorius muscle we have got subsartorial nerve plexus. So you can just write about subsartorial nerve plexus. Subsartorial nerve plexus lies on the roof underneath the sartorius muscle, underneath the sartorius muscle. The plexus formed by, the subsartorial plexus formed by, the subsartorial plexus formed by the subsartorial nerve plexus is formed by, so basically three nerves are there which is forming the subsartorial nerve plexus, and these subsartorial nerve plexus is formed by three nerves. These nerves are, so if I talk about these nerves, so we have got three nerves, that is medial cutaneous nerve of thigh, we have got medial cutaneous nerve of thigh, we have got medial cutaneous nerve of thigh, we have got anterior division of obturator nerve, anterior division of obturator nerve, and we have got the saphenous nerve, the saphenous nerve. So exactly these are the three structures, these are the three nerves which is forming the subsartorial nerve plexus. Okay, these are the three nerves. So if I am talking about subsartorial nerve plexus, which is exactly lying on the roof and it is lying underneath the sartorius muscle, you have to know the important nerves which is together forming the subsartorial nerve plexus. The medial cutaneous nerve of thigh, the anterior division of obturator nerve and the saphenous nerve, which is a branch of femoral nerve, but femoral nerve itself is not a content of adductor canal. Now done with this, now I would like to tell you about the contents. So please write on the heading contents, adductor canal contents. Adductor canal contents. So let's talk about the contents of adductor canal. So if I am talking about the contents of adductor canal, we have got following contents. We have got femoral artery as the content. We have got femoral artery as the content. We have got femoral vein as the content. We have got saphenous nerve as the content. We have got nerve to vastus medialis. We have got nerve to vastus medialis as the content. So these are the contents of adductor canal. So we have got femoral artery, femoral vein, saphenous nerve, nerve to vastus medialis. Other than that, we also have got the anterior and posterior division of obturator nerve as the content, and one of the branch of femoral artery, that is descending genicular artery. So we have got anterior and posterior division of anterior and posterior division of obturator nerve. We have got anterior and posterior division of obturator nerve as the content, and other than that we have also got descending genicular artery as the content. Descending genicular artery as the content, and we know that descending genicular artery is a branch of femoral artery. Descending genicular artery is a branch of femoral artery. So all these are the contents of adductor canal. All these are the contents of adductor canal. Now, as I already told you about popliteal aneurysm, when I am talking about popliteal aneurysm, what is popliteal aneurysm? So, the dilatation of the walls of the popliteal artery is called the popliteal aneurysm, and if it is dilated so much that its tunica adventitia layer can also damage and burst out, so there can be enormous bleeding, and this will be affecting all the important neighboring structures. So, basically, for the treatment or the management of the case, we have to ligate the femoral artery in the region of adductor canal. So that is an important thing. Now here there is a cadaveric image. So here you can see the adductor canal region, and in this adductor canal region, what you can see, so here you can see there is sartorius muscle. So there is a sartorius muscle which is forming the roof of adductor canal. So there is a sartorius muscle which is forming the roof of adductor canal, and there is saphenous nerve as the content. There is vastus medialis muscle which is forming. Vastus medialis muscle will form antero. So anterolateral, if I am talking about vastus medialis muscle, is forming anterolateral. Adductor magnus and adductor longus is posterior or the floor. The content is femoral artery, the saphenous nerve. Okay, so everyone, are you ready? Can we solve few MCQs related to the topic? Everyone, can we solve few MCQs related to the topic? Everyone, let's solve few MCQs related to the topic. Okay, let's solve it. Okay, dear, Abu is ready. Abu is ready. So all of the following are true for the adductor canal except, which is the wrong pair. So this is a question of pairing. Okay, match the following. This question is match the following. So you can tell me all of the following pairs regarding adductor canal is true except. Except all of the following pairs regarding adductor canal is true except. So I got an answer from Abu. I got an answer from Bindu, and the right answer is very good. The right answer is content femoral nerve. This is wrong. So this is absolutely wrong. Content is not the femoral nerve. What is the content there? What is the content of adductor canal? Which nerve? Saphenous nerve. The saphenous nerve, which is a branch of femoral nerve, is the content, not the femoral nerve itself is the content. Yes, yes, Abu, everyone is absolutely right, and a thumbs up goes for them. Absolutely right. Yes, dear, absolutely right. Absolutely right. Now, which of the following is a hybrid muscle? Which of the following is a hybrid muscle? Whether it is gracilis, whether it is adductor magnus, whether it is adductor longus, or whether it is adductor brevis. So it's Osama is telling A. Okay, what about others? Bindu is telling B. Let me see the others' answer and then I will give you the right answer. Which of the following is a hybrid muscle here? The following is a hybrid muscle. Which of the following is a hybrid muscle? Which of the following is a hybrid muscle? What is hybrid muscle? Okay, I will tell you. Hybrid means composite muscle. Hybrid means composite muscle having hybrid means composite muscle having dual nerve supply. Dual nerve supply. Dual means two nerve supply. So it is supplied by two nerves. It's having dual nerve supply. Yes, double nerve supply. Absolutely right, Osama. Absolutely right. So now I want an answer having dual nerve supply. Now I want an answer from you. So I got an answer from Bindu as B. I got an answer from Aradhana Arora as B. And I got an answer from Abu as B. So the right answer is yes, Bindu, you are right. It's from obturator nerve and sciatic nerve. Yes, adductor magnus. Adductor part is from obturator nerve, the nerve of medial compartment of thigh. And if I'm talking about the hamstring part of adductor magnus is innervated by tibial component of sciatic nerve. So absolutely the right answer is B, adductor magnus. Adductor magnus. What is the nerve supply of hamstring part of adductor magnus? What is the nerve supply of hamstring part of adductor magnus? Very easy one. What is the nerve supply of hamstring part of adductor magnus? What is the nerve supply of hamstring part of adductor magnus? Bindu is giving the answer. Abu is giving the answer. What about others? Aradhana Arora. Okay, the right answer is we are talking about which part? Hamstring part. That is the part of posterior compartment of thigh. And we have got tibial part of sciatic. Those who have given C is absolutely right. I told you tibial part of sciatic nerve is the nerve of posterior compartment of thigh and it is the nerve of hamstring. It is giving innervation to hamstring part of adductor magnus. So definitely the right answer is tibial part of sciatic nerve. Now going to the next. So we have done with this. After this, the next topic is hamstring muscle and popliteal fossa. The next topic is hamstring muscle and popliteal fossa. So let me just know, you want a break of 10 minutes or is it okay? So you want a break of 10 minutes, 5 to 10 minutes, 10 minutes break, 5 to 10 minutes, and then we will start with this topic. Is it okay, everyone? So anyone till now, anyone has got any doubts? Just to summarize, we have covered the cutaneous distribution, innervation of the nerves of the whole compartment of thigh. I had also given you the details of anterior compartment of thigh muscle, the medial compartment of thigh muscle, the details of femoral triangle, femoral sheath, femoral canal, femoral ring, femoral hernia, adductor hiatus, adductor canal, and the content and the boundaries. Okay. So everyone is okay with this? Till now everything is okay. So the next thing is that I will give you a break of 5 minutes or 10 minutes, maximum 10 minutes, and then we will start with the hamstring part of the muscle and popliteal fossa. All the best and keep studying. Thank you so much. Okay, dear. So yes, take a break of just 5 to 10 minutes. Hello everyone. So am I audible? Let me just check. So am I audible? So let me just check with the students. So those who are live, they can just message me that I am audible or not. So those who are live. Okay, let me just check. Yeah, so I am audible. Okay, great. So let's start with the hamstring and the popliteal fossa. The next topic is hamstring and the popliteal fossa, which is very important. So if I talk about the hamstring group of muscle, what are this hamstring group of muscle? Hamstring group of muscle are the muscles located in the posterior compartment of thigh. These are the muscles of posterior compartment of thigh. So here we can see this image in which so in this image, if you will see, we can see the cutaneous innervation on the back of thigh. What we are seeing? We are seeing the cutaneous innervation on the back of thigh. So on the back of thigh, we have got branches of lateral cutaneous nerve of thigh. We have got cutaneous branches also from the obturator, medial cutaneous thigh, posterior cutaneous nerve of thigh. So all these nerves which has been shown in this image is giving innervation on the back of thigh. Now if I talk about the posterior compartment of thigh, it is also termed as the flexor compartment of thigh. It is termed as flexor compartment of thigh. So I just want to enlarge this image, and when I am enlarging it, you can clearly see this is the anterior compartment which we have already covered up. This is the anterior compartment. Now we have also covered up the medial compartment. No doubt we have covered up the medial compartment also. Now the next topic is to cover up the posterior compartment of thigh. So in the posterior compartment of thigh, we have got four muscles which are called as the hamstring group of muscle, which is semitendinosus, semimembranosus, long head of biceps femoris, and that of hamstring part of adductor magnus muscle. So all these are very important muscles. These are the muscles which is together constituting the muscles of posterior compartment of thigh, which has to be known to you. So you have to know about this common origin insertion of the, you have to know about the origin insertion of these group of muscle. You have to know about the idea of sciatic nerve, which is a very important content line here. So that is also very important for you to understand. So let's talk about this. So hamstring group of muscle, what we can see. So I just want to ask Vinay, Vinki, Osama, Bindu, Aradhana, Adab, Devendra Pratap, everyone. I am audible or not? If everything is clear to you or not? If anything you are not understanding, please let me know. I will just give the details of it. So we have got the hamstring group of muscles. Okay. So if we are talking about hamstring group of muscles, so we have got four muscle in this category. We have got adductor magnus muscle in this category. We have got semimembranosus muscle. We have got semitendinosus muscle, and we have got biceps femoris, long head. So adductor magnus, hamstring part, and long head of biceps femoris, and the long head of so long head of biceps femur. These are the contents. These together is called as hamstring group of muscle. Now, if I talk about hamstring, I just want to introduce with this group of muscle. Actually, hamstring muscle was cutted and it was crippled. The person or any animal was crippled so that they are not able to walk properly, because we know that this group of muscle is having the action just opposite to the muscle of anterior aspect of thigh. So the muscle which is residing in the anterior compartment of thigh is vastus medialis, vastus lateralis, vastus intermedius, and rectus femoris. So they have got a common action of extension of knee and flexion of thigh. So the action of hamstring muscle or the muscle residing in posterior compartment of thigh will be just opposite to the action of the muscle residing in the anterior compartment of thigh. So the action will be, what will be the action? The action is they are causing flexion of knee and extension of hip. What will be the action? Extension of hip and flexion of knee. Now, actually, the person who was who has done a great crime, and in earlier times they want to give punishment to the person who has done the crime, they will cripple that person by cutting the hamstring tendons. So you can just see in this image that if I am talking about the hamstring group of muscle, they have got an action just opposite to quadriceps femoris muscle. Quadriceps femoris muscle are the muscle group which is residing in the anterior compartment of thigh. They have got a common action of flexion of the thigh and extension of the knee. The action of the hamstring group of muscle is just the opposite of quadriceps femoris. The quadriceps femoris group of muscle के action से just opposite होता है hamstring group of muscle का action, and the action is extension of the hip and flexion of the knee. So done. Now, so the certain features are, if I talk about certain features, they are characteristic features of hamstring group of muscle. So they are characteristic features of hamstring group of muscle, and their actions are, all these muscle arises from ischial tuberosity. So the common action of hamstring group of muscles are, all these muscles are arising from ischial tuberosity. All are inserted into one of the bone of the leg, and all are supplied by tibial component of sciatic nerve, and all these group of muscle which is are the common flexors of the knee and extensors of the hip. So these are particularly 4 important points. So exactly these 4 points which I am showing you, these 4 points which I am telling you, these are the property of hamstring muscle which is common to the muscles of posterior compartment of thigh. They are arising from a part of hip bone, that is ischial tuberosity of the hip bone. They are all inserting into one of the bone of the leg. All are supplied by tibial component of sciatic nerve, and all are flexor of knee and extensor of hip. All these muscles are flexor of knee and extensors of hip. Now, I just want everybody to pay attention to this point. Actually, why this is basically very important. So, the characteristic features of hamstring muscle which is common to each other has been already discussed, but exception to this property is one of the muscle, that is adductor magnus. Adductor magnus is a muscle which is having the insertion not into one of the bone of the leg, that is tibia or fibula, but it is inserting into adductor tubercle. Now, what is adductor tubercle? It is a bony tubercle lying in the lower end of the femur bone. That means the ending point of or insertion of adductor magnus muscle, which is a hamstring part of it, is the muscle of posterior compartment of thigh, is inserting in the femur bone. It is not inserting into one of the bone of the leg, that is tibia or fibula, but it is inserting slightly above that level. It is not obeying the law. It is not obeying the law of hamstring muscle. Now, the reason is that actually, after the level of adductor tubercle, it has been formed as a degenerated tendon of the muscle. So, we have got the degenerated tendon of this muscle in the form of tibial collateral ligament of the knee joint. So, tibial collateral ligament of the knee joint is attached to the tibia bone proximal medial aspect, and this tibial collateral ligament of the knee joint is actually degenerated tendon of the adductor magnus muscle hamstring part. So, if I talk about adductor tubercle, the adductor tubercle is a bony prominence in the lower part of or distal most part of femur bone, and tibial collateral ligament is degenerated tendon of, it's a degenerated tendon of tibial collateral ligament is degenerated tendon of adductor magnus muscle. It's a degenerated tendon of adductor magnus muscle. Okay. Now, let's talk about biceps femoris muscle. So, biceps femoris muscle lies posterolaterally in the thigh. If I talk about biceps femoris muscle, so this muscle is biceps femoris. So, let's talk one by one about the muscles of hamstring group. So, I would like to firstly talk about the muscle, that is biceps femoris. So, the first muscle in this category which I want to talk here, I want to tell you is the biceps femoris muscle. So biceps femoris muscle, if I talk about biceps femoris muscle, it is having two heads. It is having long head and short head. Okay, it's having a long head and short head. So long head is arising from, if I talk about the long head, this is the long head and this is the short head. Okay, so long head and short. Long head is arising from, if I talk about long head, it is arising from ischial tuberosity. Actually, long head of bicep femoris is only the part of hamstring group. So long head is only the part of hamstring. It arises from ischial tuberosity. We know all the hamstring group of muscle is arising from ischial tuberosity of the hip bone. Okay, when I'm talking about short head, it is arising from lateral lip of linea aspera, exactly located between adductor magnus and vastus lateralis. Okay, it is also arising from upper two-third of lateral supracondylar line and also from the lateral intermuscular septum. So all these three parts which has been shown to you, it's the origin for the short head, that is upper two-third of the supracondylar line of the femur and lateral intermuscular septum, so and that of the lateral lip of linea aspera. Thereafter it inserts, if I talk about biceps femoris insertion, it is inserting into the head of fibula. It is inserting into which part? It is inserting into head of fibula, and the location of head of fibula is lying in front of stelloid process. So it is inserting into head of fibula, which is located in front of stelloid process. Okay, bicep femoris is having long head and it is having a short head. Now done with this. Now I just want everybody to concentrate on this image. Actually, this image is ischial tuberosity. Okay, this is schematic diagram of ischial tuberosity, and from this ischemic diagram of the ischial tuberosity, so exactly I just want everybody how it is divided into different parts. So exactly what happens, first thing is that by a transverse ridge, so by a transverse ridge, we can use another color. So by a transverse ridge, it is dividing into upper and the lower part, as you can see. So this is a transverse ridge which is dividing into upper and the lower part. Now in the upper part, there is an oblique ridge which will divide into suprolateral and supromedial part. So from the suprolateral part, you can see semimembranosus muscle arises. From the supromedial part, you can see semitendinosus muscle along with the long head of bicep femoris arises. So that means the whole of ischial tuberosity can be divided into upper and the lower part, and the upper part again is divided by an oblique ridge. So the upper part is again divided by an oblique ridge. It is divided by an oblique ridge. So upper part is again divided by an oblique ridge into the outer supralateral and that of supromedial part. From the supralateral part, we have got an origin of from the supralateral part, we have got the origin of semimembranosus muscle, and from the supromedial part, we have got a common origin of semitendinosus and long head of biceps femoris. If we talk about the lower part, if I am talking about the lower part, it is again divided into medial and lateral part by a longitudinal ridge, and from the lateral aspect, adductor magnus hamstring part arises, and from the medial aspect, it is covered by subcutaneous area, fatty tissue. It is not having the arising of any muscle. So this is how the ischial tuberosity is divided into four parts, and we can understand that individually from which part the muscle is arising. Just to recapitulate, from the supralateral part of ischial tuberosity, upper supralateral part, the muscle arising is semimembranosus. From the supromedial part, the muscle arising is semitendinosus and long head of biceps. And from the lower part, if we talk about the lateral aspect, we have got the origin of adductor magnus muscle, and medially it is covered by subcutaneous. Medially, it is covered by subcutaneous areas and tissues. Now we have done with this. Now the next thing is to know about, so we have already discussed about origin insertion of biceps femoris muscle, and let's talk about the another muscle, that is semitendinosus muscle. Now if you remember semitendinosus muscle, now in this diagram I want you to pay attention to semitendinosus muscle. the biceps femoris has also already been done, and we know that biceps femoris is inserting into head of fibula. Semitendinosus muscle, if you will see in this diagram, you can understand this semitendinosus muscle is tibia. So this semitendinosus muscle is tibia. So this is tibia, and on tibia proximal medial aspect it insert, that is called as pex ansurine. So semitendinosus muscle inserts onto the tibia proximal medial aspect. Common insertion of semitendinosus, sartorius and gracilis takes place at this point, that is called as pex ansurine insertion. Now the next muscle of this group of hamstring group is semimembranosus muscle. So in this diagram you can see semimembranosus muscle, which is arising from the lateral part of the quadrant of ischial tuberosity, which we have already discussed, and the insertion is in the horizontal posterior aspect of medial condyle of tibia. So where it is inserting into a groove which is located on the posterior aspect of medial condyle of tibia. So this is about insertion. So very nicely we can appreciate the origin and insertion of semimembranosus muscle also. Now I would like to talk about adductor magnus muscle. The next is adductor magnus muscle. We know that adductor magnus muscle is an example of composite or hybrid muscle. It's an example of composite or hybrid muscle which is having two parts. It is having a adductor component and it is having a hamstring component. Already we have talked about adductor component in the medial compartment of thigh, and now in this part we are talking about the hamstring part. The hamstring part will originate from ischial tuberosity. So basically it originates from the hamstring component from ischial tuberosity and the adductor component from the ischium and the inferior ramus of the pubis. From the inferior ramus of the pubis, adductor magnus is the bulkiest muscle of the adductor region. It's also having a posterior compartment hamstring part. Insertion. If I talk about the insertion, the hamstring part is inserting into adductor tubercle, which we already told you. So its hamstring part is inserting into adductor tubercle. Rest insertion is in the linea aspera medial aspect, medial supracondylar line, and medial aspect of luteal tuberosity. Now this is an image where you can see the hamstring group of muscle. So in this image you can see the common origin of these group of muscle is from ischial tuberosity. So we have got a common origin from these group of muscle, that is from the ischial tuberosity. So here we have got following muscle. We have got this is the long head of biceps. This is the long head of biceps. This is the semitendinosus muscle. This is the semimembranosus muscle. So and one more muscle is adductor magnus ischial component. So here we have got these muscles together. So if you want, you can just write this is the biceps femoris. We have got semimembranosus and semitendinosus. And these are main part of the hamstring group of muscle. Other one which is the adductor magnus hamstring part. Now I would like everybody to understand the nerve supply of hamstring group of muscle. If I am talking about the innervation of hamstring group of muscle, we have got semitendinosus, semimembranosus, biceps femoris, adductor magnus. So all the muscles of the hamstring group of muscle, all the muscles of posterior compartment of thigh is having a common innervation, that is tibial component of sciatic nerve. What is the common innervation? It is via tibial component of sciatic nerve. Semitendinosus is via tibial part of sciatic nerve. Semimembranosus is via tibial part of sciatic nerve. Biceps femoris long head is via tibial part of sciatic nerve, and short head is via common peroneal part. Adductor magnus, if I am talking about adductor magnus, it is having the adductor part and it is having the hamstring part. So the adductor part of adductor magnus muscle is innervated by obturator nerve, but the hamstring part of adductor magnus is innervated by sciatic nerve tibial part. Now, okay, just a minute. Yeah. Now let's talk about the action, the important action of these muscles. So if I am talking about common action which has to be known to you, I have already talked about the common action. The common action of this group of muscle is extension of the hip and flexion of the knee. So common action is flexion of the leg and extension of the hip joint. And other than that, few more actions are allocated to these muscles, like semitendinosus is also causing medial rotation of leg. Same goes with semimembranosus. Biceps is also causing lateral rotation of leg. Adductor magnus is also having another important action, that is adduction of thigh. Now, a very important nerve is residing in the posterior compartment. A very important nerve is lying in the posterior compartment of thigh, and that nerve is sciatic nerve. Which nerve is this? That is the sciatic nerve. So if I am talking about the sciatic nerve, it is the thickest nerve and it's actually made of two components. It is having tibial component and it is having common peroneal component. The root value of sciatic nerve, we know that it is formed by the ventral rami of. So sciatic nerve is formed by the ventral rami of L4, L5, S1, S2 and S3. So sciatic nerve is formed by the ventral rami of L4, L5, S1, S2 and S3, and it's the largest branch of sacral plexus. It is having two components, that is tibial part and common peroneal part. It is having tibial and common peroneal part. Tibial nerve is formed by the ventral division of L4, L5, S1, S2 and S3, and common peroneal component is formed by dorsal division of L4, L5, S1 and S2. Okay. Tibial component of sciatic nerve. So actually tibial component of sciatic nerve is larger terminal branch of sciatic nerve having root value of L4, L5, S1, S2 and S3. The smaller terminal branch of sciatic nerve is common peroneal nerve having the root value L4, L5, S1 and S2. Tibial part is from ventral division and that of the common peroneal nerve is formed from dorsal division. Now this is the sciatic nerve, in which you can see the sciatic nerve having two components. The common peroneal nerve component will give innervation to short head of biceps femoris, and its tibial component will give innervation to all the four. The tibial component will give innervation to all the four muscles of hamstring group, that is semimembranosus, semitendinosus, the hamstring part of adductor magnus and the long head of biceps femoris, long head of biceps femoris. Now, tibial nerve is the thickest nerve. Tibial nerve is the thickest nerve. It's a band like 2 centimeter. It's a band which is of 2 centimeter wide, and it begins in the, if I talk about its initial part, it begins in the pelvis part, and from the pelvis it passes to the gluteal. It begins in the pelvis part, and from the pelvis it will pass into the gluteal region. Thereafter it will traverse in the back of the thigh. It's a very important nerve located in the hamstring component and terminates. It terminates it into its two component, its two terminal branch. It terminates into common peroneal nerve and tibial nerve, which are the terminal division of the sciatic nerve, which takes place at the level of apex or the superior angle of popliteal fossa. So that is the level where this termination takes place. Sciatic nerve course. The entire course of sciatic nerve is divided into following parts. So if we will see the sciatic nerve, sciatic nerve course. So if I am talking about sciatic nerve course, the sciatic nerve course is divided into three regions, that is the pelvis, the gluteal region and the back of thigh. Pelvis, gluteal region and back of thigh. It terminates at the junction of upper 2/3 and lower 1/3 of the back of thigh, that is at the level of superior angle of popliteal fossa, and at that level it divides into two terminal branches, tibial and common peroneal nerve. So exactly this is the sciatic nerve traversing in the gluteal and the pelvis and in the back of thigh, terminating in the tibial nerve and that of the common peroneal nerve. So here this is the tibial nerve and this will be CPN, common peroneal nerve, at the level of apex of. So you can see this is the apex of popliteal fossa. So that happens at the level of apex of popliteal fossa. Now, relations of the pelvis, the important relations in the pelvis, it lies in front of the piriformis. It lies in front of piriformis muscle covered by fascia. It leaves the pelvis at the lower border of piriformis muscle and then enters into greater sciatic foramen. So this is the sciatic nerve traversing in the greater sciatic foramen. You can see this is the greater sciatic foramen in which it traverses. Thereafter, you can see it enters into the gluteal region. So it is located superficial to the, so the relation, if I talk about the relation, what you can appreciate, it is related superficial to the gluteus maximus muscle, deep relation. On deeper aspect of sciatic nerve, we have got the body of ischium. So on deeper aspect, we have got the body of ischium, tendon of obturator internus. We know that obturator internus muscle has got two tendons, one above and one below, gemellus superior and gemellus inferior, and we have got posterior aspect of the capsule of the hip joint. So all these structures, that is the capsule of hip joint, quadriceps femoris muscle, gemellus superior, gemellus inferior, obturator internus, and that of the body of ischium, all these structures are lying in the deeper relation of sciatic nerve. But if I am talking about the superficial relation, it is the gluteus maximus muscle. Thereafter, what happens? It enters into the back of thigh at the lower border of gluteus maximus. It turns vertically down in the, so what you can say, it is running vertically down as here in the tibial nerve and the common peroneal nerve. It divides at the level of apex of the popliteal fossa. So in this traversing, in this area, it runs vertically down. So here it is related superficially to long head of biceps, and on deeper aspect it will have the muscles like adductor magnus, medially semimembranosus and semitendinosus muscle, laterally there will be biceps femoris. So that is important relations. Now let me just check with the students have they are understanding. So are you understanding? Any doubt you can let me know. Yes Puneet, good noon ma'am. Yes dear. Clear everyone? Now, we have just studied about the sciatic nerve and we have seen its course and relation. But after that, I want everybody to understand the branches of sciatic nerve. So, I just want to show you this image. Okay. So, why it is important to know the branches of sciatic nerve? We have to know what all structures and the branches the sciatic nerve is giving in different area. So, it gives following branches. In the pelvis, it is giving no branches. Please note down, in the pelvic region, sciatic nerve is giving no branches. In the pelvic region, sciatic nerve is giving no branches. In the gluteal region, it is giving articular branch to hip joint. In the gluteal region, it is giving articular branch to hip joint. In the back of thigh, it is giving muscular branches. From the tibial component, it is giving innervation to semitendinosus, semimembranosus, long head of biceps femoris and ischial head of adductor magnus. So from tibial component, it is giving innervation to all the muscles of hamstring group, and from the common peroneal component, it is giving innervation to short head of biceps femoris. It is giving innervation to short head of biceps femoris. Please note down, this is very important. You have to know all the branches of sciatic nerve. You have to know sub branches of sciatic nerve and the muscles getting innervation. So one time in 2018 or 19 in the AIMS entrance exam also, they have asked about which of the back muscles, posterior muscles of the thigh is innervated not by tibial component of sciatic nerve. What will be the answer? The muscle is short head of biceps femoris, which is innervated by common peroneal component of sciatic nerve. So this is a sciatic nerve which is giving innervation to all the four muscles of the hamstring group through hamstring muscles, and this is the common peroneal nerve which is giving innervation to short head of biceps femoris. Now, let's talk about the clinical aspect. When I am talking about the clinical aspect or applied aspect, when you sit for long duration of time, if you are sitting for long duration of time, what will happen? If you are sitting for long duration of time, temporary numbness of the lower limb will happen due to compression of sciatic nerve in the gluteal region by prolonged sitting. Okay. So, when we are sitting for long duration of time, numbness of the lower limb will be seen, and the reason will be compression of sciatic nerve which happens in the gluteal region by prolonged sitting. Now, sciatica, irritation or compression. Yes, doctor. Yes, Dr. M. Yashwant. Yes, dear. Yes, dear. Hello. Yeah, hello, Yashwant. Yes, Dr. Yes, Dr. M. Yashwant. Yes, please let me know. Any doubt? Any doubt? Are you not understanding anything? So, for example, I am sitting for long. You must have seen that I have taken a 5 minutes break in between. Why? Because if you will continually sitting and we put pressure on the ischial tuberosity. So, if I am continuously sitting for many long, generally what is advised is every 2 hours or 1.5 and 2 hours, you have to take a break of 5 minutes. But as we have to complete the session also, so the first break was of 3.5 hours. So basically in between 3 hours or something, you should take a break of 5-10 minutes so that you are not able to compress the sciatic nerve. If you are continuously pressing on sciatic nerve on one position, there will be compression of sciatic nerve and there will be numbness in the leg. You must have observed if sometimes you have planned just today to sara anatomy khatam karna. Today I am going to crack the exam with a very good number. So what you will do? You will continuously sit for 4 hours, 5 hours and you will not take a break. And sometimes it has happened with me also. There will be compression of the nerve and there will be numbness of the limbs. Okay. So nerve pain originates in the lower back gluteal region, radiates to the buttock region and back of the thigh, and ultimately to the lateral side of the leg to the dorsum of the foot. So this is the whole course of the sciatic nerve or sciatica. Injury to the sciatic nerve by the penetrating on injury to the sciatic nerve by the penetrating on. So sensory loss on the whole of the leg and the foot except the in the area of so if I talk about saphenous nerve, which is exactly the branch from the femoral nerve, so we know that saphenous nerve is giving innervation to medial aspect of the leg and to the medial aspect till the level of great toe. So except that area, whole of the area will have sensory loss in case of sciatic nerve, because tibial nerve, common peroneal nerve, deep peroneal nerve, superficial peroneal nerve, all have got an origin from sciatic nerve. Motor loss, if I talk about the motor loss will be the loss of the action of hamstring group of muscle. So the hamstring group of muscle will be lost, will lose its action, that is semitendinosus, semimembranosus, long head of biceps and hamstring part of adductor magnus. There will be also loss of dorsiflexors of the foot, that is the muscle residing in the anterior compartment of the leg. There will be loss of the foot the muscles of the plantar flexion. There will be loss of the movements below the knee and there will be foot drop. Done. Now a case study is there. Can you tell me the structure involved for everyone? A patient is presenting with a severe chronic pain of the lower back. Patient presents with severe chronic pain in the lower back in the sacral region with radiation to the back of left leg, producing a strong pain, throbbing, burning pain behind the knee. Pain is aggravated when bending forward and reaching out some structures position. He gave a history of fracture which has got fracture of lumbar vertebra. His MRI was done prior and what has been seen there is degeneration of the disc and protrusion of the disc at the level of S1. What anatomical structure is likely to be involved? What what anatomical structure is likely to be involved here? Yes, dear. Can you tell me the answer? Which structure is involved in this case? So, which structure is involved in this case? Waiting for your answer. I'm just checking your messages. So, what will be the right answer, dear? Okay. What is the right answer, dear? Anyone? Let me just check with the students. Anyone? What will be the structure involved in this case? Which anatomical structure is likely to be involved in this case? Anyone? Sacral Bindu concha, sacral branch. Yes, sacral plexus. Which branch? Which nerve? Which nerve? Just now I told you. Which nerve will be involved in this case? I have explained the nerve also. Which nerve? The nerve being involved in this case will be, yes, it's a branch of sacral plexus. The name of the nerve is sciatic nerve. The name of the nerve is sciatic nerve. Yes, yes, right. Okay. No, overall sciatic nerve is gone, dear. Sciatic nerve is gone. We are not going into details of sub branches. Okay, that we will further see. Okay, okay, sciatic nerve is the right answer. Now, sacral plex is a nerve plex which is providing motor and sensory nerves of the posterior thigh, and it is formed by, already I have told you about sacral plexus. I hope everybody is knowing this. We have already talked about sacral plexus. It is formed by lumbosacral trunk. It is also formed by anterior division of the sacral nerve. It is also formed by anterior division of the second, third sacral nerve and first sacral nerve. That first, second, third sacral nerve and lumbosacral trunk. Now let's talk about few anastomosis which is taking in the posterior aspect of the thigh. So write down. Anastomosis at the back of thigh. Anastomosis at the back of thigh. So if I am talking about the anastomosis which is taking place at the back of thigh is, following anastomosis will take at the back of thigh. We will have trochanteric anastomosis. We will have cruciate anastomosis. We will have the anastomosis in the series of longitudinal anastomosis between the perforating branches. So it's very important that you should know the details of these anastomosis. You should know the details of trochanteric anastomosis, and you should know the details of cruciate anastomosis and all the arteries which is taking part. Okay, so one by one we will talk about this. Anastomosis at the back of thigh. So one by one we will talk about this. If you have got any doubt, you can let me know. Okay, dear. Now let's talk about the anastomosis which is taking place. So we have got cruciate and we have got the cruciate and we have got the trochanteric anastomosis. So which are the important structures which is taking part in formation of these anastomosis has to be known to you. So basically that is very, very important. Okay, so let's talk about that. So in this diagram, you can see series of longitudinal anastomosis which has been taking place, and then we will talk about that. So exactly, if I talk about arterial anastomosis at the back of thigh, so you can just enlarge this, and what you can see here, so here there is this anastomosis. Okay, so what you can see, there is a longitudinal series of anastomosis. So longitudinal arterial anastomosis is the major arterial supply to back of thigh, and it is from the perforating branch. It is the anastomosis which is taking which is between the perforating branches, and this is exactly taking from the perforating branches, as you can see in this diagram. Close to the posterior aspect of insertion of adductor magnus, we have got chain of longitudinal arterial anastomosis, which is formed from ascending and descending branches of perforator artery and superior muscular branches of popliteal artery. So that is one anastomosis. The other is trochanteric and the cruciate. If I am talking about trochanteric and cruciate anastomosis, trochanteric anastomosis is at the level of trochanteric fossa. Cruciate anastomosis is exactly taking play by the branches. So we have got 4 arteries. So in the trochanteric anastomosis, we know that there is a profunda femoris artery which give ascending, descending and transverse branches. So in cruciate anastomosis, the artery which take part is the transverse branch of, so we have got transverse branch of medial and lateral circumflex along with the so we have got transverse branch along with the ascending branch of first perforator and a branch from inferior gluteal artery. So these together is forming cruciate anastomosis. We have got a branch of superior and inferior gluteal artery along with it ascending branch of the ascending branch of the profunda femoris artery. So all these are taking part in the formation of trochanteric anastomosis. So this is trochanteric and this is cruciate anastomosis which is taking part. Okay. So that is very, very important. So please write on this. Firstly, I would like to talk about longitudinal. First thing which is important is write down arterial anastomosis at the back. The heading will be arterial anastomosis at the back of thigh. Back of thigh. At the back of thigh. So at the back of thigh, we will have longitudinal arterial anastomosis. We have longitudinal arterial anastomosis. So we will have longitudinal arterial anastomosis derived from perforating branches of profunda femoris artery. Profunda femoris artery derived from perforating branches of profunda femoris artery. And superior muscular branch of popliteal artery. Okay, superior muscular branch of popliteal artery. Now let's talk about trochanteric and cruciate anastomosis. So trochanteric anastomosis, if I talk about trochanteric anastomosis, the important arteries which is forming, so the arteries forming trochanteric anastomosis are, the name of the arteries must be known to you. So we have got 4 arteries which is forming trochanteric anastomosis, that are ascending branch of lateral circumflex femoral artery, ascending branch of lateral circumflex femoral artery, ascending branch of medial circumflex femoral artery, medial okay. Then we have got descending branch of inferior gluteal artery, descending branch of inferior gluteal artery. and descending branch of superior gluteal artery. Superior gluteal artery. So these are together the trochanteric anastomosis detail, and now we will talk about the cruciate anastomosis. The cruciate anastomosis is formed by following arteries: transverse branch of medial and lateral circumflex femoral artery, transverse branch of medial circumflex femoral artery, transverse branch of lateral circumflex femoral artery, lateral okay. Then we have got ascending branch of first perforator artery, ascending branch of first perforator artery, descending branch of inferior gluteal artery. Okay, so this is all the details of cruciate anastomosis. This is all the details of cruciate anastomosis. Okay, dear. Yes, dear Omar. Yeah, I thought it is going to be 23. Say, okay. Today is 22. So today is lower limb, dear, and upper limb is tomorrow. Okay, Omar Muhammad Ibrahim. So Ibrahim, yes, tomorrow is also the session that is of upper limb. Today lower limb I am going to finish. Okay, tomorrow is also a session. We have already covered the head and neck part. We have already covered the neuroanatomy, abdomen and pelvis. Today is the lower limb session. Tomorrow will be the upper limb session, and then after I will also take two sessions of one session of histology and one of embryology. Okay, dear. Okay, Omar. So done with this. So exactly done with this. Now the next topic is popliteal fossa. But before that, I want to solve few MCQs along with you. So is it okay, everyone? Can we have the MCQs now? Can we go through the details of MCQs now? Everyone, let's start with the MCQs. What is the root value of sciatic nerve? I got an answer from Bindu, Aradhana Arora. What about others? Aradhana Arora, Lily, Chanu, Bindu, yes. B means the ventral rami of L4, L5, S1, S2 and S3. This is the root value of sciatic nerve. Okay. So I got an answer from Aradhana Arora along with the details. Absolutely correct. All of you are absolutely correct. The correct answer is L4, L5, S1 and S2. So absolutely correct. Okay. Let's move on to the next one. The next question is, which of the following is the thickest nerve of the body? Which of the following is the thickest nerve of the body? Which of the following is the thickest nerve of the body? So, sciatic, pudendal, superior gluteal nerve to quadriceps femoris. Okay. Four options are there. Which of the following is thickest nerve of the body? So, yes. Sciatic is absolutely correct answer. Yes, sciatic is absolutely correct answer. It is the thickest nerve of the body. Absolutely correct. A thumbs up goes for Bindu, Lily, Aradhana, Amit Sharma. Biceps femoris inserts into which of the following? What is the insertion of biceps femoris muscle? Whether it inserts into the head of fibula, whether it inserts into the adductor tubercle of the femur, whether it inserts into stelloid process of the fibula, whether it inserts into the medial condyle of tibia. According to you, which is the best answer? Question number 3, please mark the right answer. Bindu has given his answer. What about others? What about others? Yes. Biceps femoris is inserted into I got an answer from Aradhana. I got an answer from Medico. Absolutely correct. Head of fibula is the correct answer. So those who have given head of fibula, they are absolutely right. Yes, head of fibula is the right answer. Yes, dear. Which is not a characteristic feature of hamstring muscle? Which of the following is not a characteristic feature of hamstring muscle? Which is not a characteristic feature of hamstring muscle? Origin of ischial tuberosity, nerve supplied by the deperoneal nerve, the muscle act as a flexors of the knee and extensors of the hip, insertion into one of the bone of the leg. So which is not a characteristic? So one answer I got from Bindu. What about others? Which is not a characteristic of hamstring muscles? Please mark the right answer, which is not a characteristic of hamstring muscle. And the correct answer is nerve supply by deep peroneal nerve. Deep peroneal nerve is the nerve of anterior compartment of the leg. It is not innervation of the yes, Bindu, you are absolutely right. The innervation of hamstring group of muscle is by tibial component of sciatic nerve. Absolutely, a thumbs up goes for you. So basically, these are all the questions from the previous competitive exam, and I am very glad that you are able to solve it. Good one. Absolutely correct. Absolutely correct, my dear students. Absolutely correct. Now we have finished with this. Can we move on to the next topic, the popliteal fossa? The popliteal fossa. The popliteal fossa. So if I am talking of popliteal fossa, it is a diamond shaped depressed area in the back of the knee. So what is popliteal fossa? It is a diamond shaped it's a diamond shaped depressed area on the back of the knee. And what is important for you is to know the boundaries of popliteal fossa, the structures forming the floor, the roof and the contents, the relation of the contents. And also I will talk about arterial anastomosis around the knee joint. So all these are highly important topics for you. Okay. So popliteal fossa is a diamond shaped popliteal fossa is a diamond shaped hollow on the back of knee, on the back of knee, on the back of knee joint. It becomes prominent, it becomes prominent it becomes prominent when the knee is flexed. It becomes prominent when the knee is flexed. And what is important for you to know the boundaries of popliteal fossa, the contents and all. So let's me first explain everything, then I will write down the detail. Boundaries, very nicely you can appreciate in this image. This is the diamond shaped depressed area on the back of the knee joint. This is the popliteal fossa which has been highlighted in this image. And if I talk about the boundaries, it is bounded supromedially by, it is bounded supromedially by, it is bounded supromedially by semimembranosus and semitendinosus. Semimembranosus and semitendinosus. Okay. So this is exactly the semimembranosus part, and this is exactly the semitendinosus part. Suprolaterally, it is bounded by suprolaterally, it is bounded by biceps femoris, and lower down it is bounded by medial head of gastrocnemius and lateral head of gastrocnemius. So exactly you can see all the boundaries. So exactly you can see all the boundaries of popliteal fossa. So you can see its boundaries. So I'm just, you can see the boundaries which is lying on the supromedial aspect and which is lying on the supromedial aspect. So superiorly we have got medially, if I talk about superior medial part, semimembranosus and semitendinosus. Suprolaterally is the biceps femoris muscle, infromedially is the medial head of gastrocnemius, infrolaterally is the plantaris muscle along with the lateral head of gastrocnemius. This is the boundary of this diamond shaped area which I have marked across. That area is the popliteal fossa. So let's write down the boundaries. The boundaries of popliteal fossa are supromedially, it is bounded by semimembranosus and semitendinosus. It is bounded by semitendinosus and semimembranosus. Suprolaterally, it is bounded by biceps femoris, infromedially, it is bounded by medial head of gastrocnemius muscle, medial head of gastrocnemius muscle, and infrolaterally by lateral head of gastrocnemius muscle, lateral head of gastrocnemius muscle. Along with the lateral head of gastrocnemius muscle, it is also having the boundary by plantaris muscle. So it is also bounded by plantaris muscle. So this is overall boundary of popliteal fossa. Supromedially by semimembranosus, semitendinosus, suprolaterally by biceps femoris, infromedially by medial head of gastrocnemius, infrolaterally by lateral head of gastrocnemius along with the plantaris muscle. Okay. Now it's important to know the structures residing in the roof of popliteal fossa. So in the roof of popliteal fossa, we have got, so the roof is the posterior wall of popliteal fossa, which is covered by the popliteal fascia, and the superficial fascia is overlying. The superficial fascia is containing short saphenous vein, sural communicating nerve, posterior cutaneous nerve of thigh, and the posterior division of medial cutaneous nerve of thigh. So actually all these structures are the content of the roof of popliteal fossa. So write down structures in the roof of popliteal fossa. So roof of popliteal fossa is also called as the posterior wall. Is also called as the posterior wall, and it is formed by strong popliteal fascia. It is formed by strong popliteal fascia. It is formed by strong popliteal fascia. The superficial fascia over the roof contain the superficial fascia of roof contains the superficial fascia of roof contains short saphenous vein, three cutaneous nerve, it contains three cutaneous nerves, that is the terminal part of posterior cutaneous nerve of thigh, okay. So we have got, yeah. Other than that, we have also got the posterior division of medial cutaneous nerve of thigh and that of sural communicating nerve. Medial cutaneous nerve of thigh and the sural communicating nerve, sural and the sural communicating nerve. Okay, so these are the structures in the roof of popliteal fossa. Now let's talk about the floor of popliteal fossa. So if you will see this image, you can understand the floor of popliteal fossa. So in the floor part, what you can see, the floor means the anterior wall of popliteal fossa, which is have fascia covering popliteal muscle, oblique popliteal ligament, which is formed from the tendon of semimembranosus muscle. So oblique popliteal ligament is the extension which is taking place from the tendon of semimembranosus muscle. We have got the popliteal surface of femur, the capsule of the knee joint, and the popliteal fascia. So we have got anteroposterior view, posterior anterior you can say view, and also the lateral aspect showing the structures in the floor of popliteal fossa. The floor of popliteal fossa is also called as the anterior wall of popliteal fossa. What is it called as? It is also called as the anterior wall of popliteal fossa. The anterior wall of popliteal fossa. Okay, so in the floor or anterior wall of popliteal fossa, we have got following contents. The contents are popliteal surface of femur, popliteal surface of femur. We have got the popliteal surface of the femur. We have got the contents, that is popliteal surface of the femur. We have got the capsule of the knee joint. Capsule of knee joint and oblique popliteal ligament. And oblique popliteal ligament. We have got the popliteal fascia and we have got oblique popliteal ligament. Okay, oblique popliteal ligament I have already written. So all these structures are the content of the floor of popliteal fossa. Now the contents. Now what lies inside or the content of popliteal fossa? For that I would like to show you an image. So is it okay? Ma'am, I am NEET UG student. I got a rank of 582 marks in NEET UG and can prepare. Okay, okay. So no worries. In between you can have, so students, in between you can have your tea, coffee, because if you we can cut short the session also, but I want that you should be understanding the whole aspect that will be utilized for your examination. So content, it's very important that you should know the details of whole of the upper limb. So many, now if we see the FMG examination, if I am talking about FMG examination, it is not superficial. It is not superficial what is asked in FMG examination. They have asked the details of each and all anatomical structure. So you have to study the structures in detail. So if I am talking about popliteal fossa content, you can see popliteal lymph node is the content. You can see the popliteal pad of fat is the content. You can see the popliteal vein, the popliteal artery, the tibial nerve, common peroneal nerve. All these are the contents. So also the 5 genicular branches of the popliteal artery. So this is the popliteal artery, which is continuation of femoral artery. It is giving 5 genicular branches. The lateral superior genicular, medial superior genicular, medial inferior and lateral inferior genicular, along with the middle genicular artery. So all these are the, along with the middle genicular artery. So all these are the branches of popliteal artery and the content of popliteal fossa. So please write on the content, then I will show you an image of relations of the content of popliteal fossa. So relations of popliteal fossa. So let's talk about the contents of the popliteal fossa. The important contents are, please write on, the important contents are popliteal artery and its branches, popliteal artery and its branches, popliteal vein and its tributaries, popliteal vein and its tributaries. We have got tibial nerve and its branches. We have got common peroneal nerve and its branches. We have got popliteal pad of fat. We have got popliteal lymph nodes. And we have got popliteal pad of fat. Okay. So all these are the contents. All these are the contents of popliteal fossa. Now, arrangement of the main structures of the popliteal fossa. Now, talking about the arrangements of the main structures of the popliteal fossa, which is very, very important for you to understand. So, if we talk about the relations of the structures, you can see, as you can see from the upper aspect. So, in the upper aspect, as you can see, the relations. Okay, so exactly in the upper part, as you can see in the upper part, from so we have got lateral and medial. So in the upper parts, this is the relation of structure in the upper part. That is artery, vein and nerve. This is the relation of the structures from the exactly the relation of structures in the medial part. So structures related from in this is the relation of structure AVN from the upper part. This is NVN. This is the structure related in the middle part from superficial to deep. That is from superficial to deep. And this is again in the lower part, we have got the relation of the structures as you proceed from medial to lateral, that is from medial to lateral. So this is the relation. Upper and lower part we have got the relation from medial to lateral as artery, vein and nerve, and in lower part there is nerve, vein and artery. In the middle part it is from the superficial to deep, that is vein, that is nerve, vein and artery. So this image is directly showing you the relations in the different part of the popliteal fossa which has been shown. Okay. Okay. So relation is already shown. You can, so if we talk about the relation, it's already cleared in this image. So no doubt about that. Okay, write down. In the upper part, structures related from medial to lateral is artery, vein and nerve, is AVN. What is that? Artery, vein and nerve. In the middle part, the relation of structures from superficial to deep, that is again NVA, that is nerve, vein and artery, In the lower part, the relation of structures from medial to lateral, again it will be nerve, vein and artery, So done. This is already shown in the image also, and I have written it also. Now superficial dissection of popliteal fossa. So now it's important to see this superficial okay. So now if we are talking about popliteal fossa, so this is the view of the popliteal fossa. So in the popliteal fossa you can see this is the cadaveric image showing the popliteal fossa. So please enlarge it. So yes, I have enlarged it, and now you can see in this popliteal fossa itself. Okay, so we have got muscles here. We have got the semitendinosus muscle and the semimembranosus muscle. So we have got here semimembranosus, semitendinosus muscle, which is exactly the supromedial. This is the biceps femoris muscle. And lower down we have got these two muscles, that is the medial and lateral head of gastrocnemius muscle. Yes, Bindu, middle plus lower. Yes, middle plus lower is nerve, vein and artery. Yes, Bindu, it's nerve, vein and artery. Nerve, vein and artery. Yes, Bindu, it's nerve, vein. Yes, yes. So it is the medial head of gastrocnemius and lateral head of gastrocnemius. So this is the cadaveric image, and inside you can see the nerve. So there is common peroneal nerve lying here. There is tibial nerve. So there is tibial nerve, common peroneal nerve, and also the popliteal vessels. All these are the contents. Okay, all these are the contents. Now, before proceeding to the MCQ, let's talk briefly about the popliteal artery also. So, if I am talking about popliteal artery, it is a continuation of which artery? Any answer? Popliteal artery is a continuation of which artery? Anyone? Popliteal artery is a continuation of which artery? Popliteal artery. Anyone wants to give the answer? Popliteal artery is a continuation of which artery? Absolutely correct. Yes, femoral artery is absolutely correct. Popliteal artery is a continuation of femoral artery It begins at the adductor hiatus. It begins at the adductor hiatus. What is adductor hiatus? It is an osteoaponeurotic opening in the adductor magnus muscle. What is adductor hiatus? It's an opening in the adductor magnus muscle. So from there, it will be going at the junction of middle 1/3 and lower 1/3 of the thigh, crosses the floor of popliteal fossa and divides into anterior and posterior tibial artery. Divides at the lower border of popliteal muscle. So it begins at adductor hiatus, which is an osteoaponeurotic opening in the adductor magnus muscle, and reaches the lower border of popliteus muscle, where it divides into anterior and posterior popliteal artery, into anterior and posterior tibial artery. Done? Now talking about the branches of popliteal artery. Now write down popliteal artery branches. So basically, if I talk about the branches, it gives cutaneous, muscular and articular branches. So it gives cutaneous branches, it gives muscular branches, and it gives genicular branches. So it gives 5 genicular branches to be noted down. It gives 5 genicular branches. So it gives 5 genicular branches, that is superior medial genicular artery, superior medial genicular artery. It gives superior lateral genicular artery. It gives superior lateral genicular artery. It gives middle genicular artery. It gives inferior medial genicular artery. It gives inferior medial genicular artery, and it gives inferior lateral genicular artery. So these are 5 genicular branches. These are 5 genicular branches of popliteal artery. Yes, cutaneous means giving blood supply. Aradhana, cutaneous means giving blood supply to the skin area. Muscular to the adjoining muscles. Genicular means the 5 genicular branches which is given in the knee joint. So actually the genicular branches of popliteal artery, genicular branches of the popliteal artery. So if I talk about the genicular branches of popliteal artery, they take part in formation of knee anastomosis. They take part in the formation of knee anastomosis. Done? So the knee anastomosis is occurring in the following form. Now I will come to that point. Before that, I will help you to understand firstly that anastomosis. Then we will come to the further details. So here, what you can see, this is the way how the popliteal artery is palpated. So popliteal artery is palpated by deep palpation. So what has been done in this image? You can see the knee has been flexed, and the patient is on the prone position, and then on deep palpation with the examiner and the examining doctor, they are going deep into the popliteal fossa, and then the popliteal artery can be palpated. So this happens on the deep palpation. So basically it's very important that there is anastomosis around the knee joint, because popliteal artery can be this anastomosis help to maintain adequate blood supply around the knee joint, because it can be compressed in the popliteal fossa. So the anastomosis takes place as following. Anastomosis around the knee joint. So see here. Anastomosis around the knee joint. So what we can see, if we are talking about the anastomosis around the knee joint, what we can see in this here, we can see here there is anastomosis which is taking place on the medial side and lateral side. So this is L for lateral side and this is M for medial side. So the anastomosis which is taking place around the knee joint is following. So here the anastomosis is between the descending. So one of the anastomosis is between medial genicular artery, medial inferior genicular artery, and medial superior genicular artery. So you can see these two arteries are anastomosing, medial superior and medial inferior genicular. So you can just enlarge this. So you can see these two arteries, medial superior genicular artery and medial inferior genicular artery is anastomosing. The other anastomosis is the descending genicular artery. So you can see the descending genicular artery here is anastomosing with the medial genicular artery. Other than that, there is one more artery that is called as saphenous artery. What is this artery? This is the saphenous artery. So saphenous artery is again anastomosing, as you can see here, with that of medial inferior genicular artery. So you can see these anastomosis which has been shown here. These are the anastomosis. So three anastomosis occur on the medial side of knee joint. One is between medial inferior and superior genicular artery. One is between descending genicular artery, branch of femoral artery, and superior medial genicular artery. One is between saphenous branch of the descending genicular artery with that of the medial inferior genicular artery. Now on the lateral side, again lateral superior genicular artery and lateral inferior genicular artery. These two is anastomosing. This is the one. The other one is descending lateral circumflex femoral artery. Here we have got descending lateral circumflex femoral artery, which will be anastomosing with that of the lateral inferior genicular artery. You can say it is also anastomosing with the lateral inferior genicular artery. Other than that, we can also see here so other than that, you can see also the branches of anterior tibial so there is anterior tibial artery which is giving anterior tibial recurrent arteries, and there is one more branch that is circumflex fibular artery which is from the anterior tibial. So we have got posterior tibial artery branches and anterior tibial artery which is also anastomosing with the lateral inferior genicular artery. So all these anastomoses are taking place around the knee joint, and this anastomosis is adequate. Why this anastomosis is important? The reason why this anastomosis is important is to maintain the blood supply. So inferior lateral genicular artery will be anastomosing with lateral superior genicular artery and also with the branches of other arteries, that is the recurrent branches of anterior tibial artery and that of circumflex fibular branch of that of the posterior tibial artery. So I will write all this list so that you are not getting confused. Then we will solve the MCQ. Is it okay? So for you to understand, actually this anastomosis is important. So I just want that you should write the details of anastomosis and then we will solve the MCQs related to the topic. So the first is superior medial genicular artery, superior medial genicular artery anastomosis with superior medial genicular artery anastomosis with descending genicular artery, descending genicular branch of femoral artery and inferior medial genicular artery and inferior medial genicular artery. So this is the one anastomosis that is taking place between superior medial and inferior medial genicular artery, which I have shown. The second one is inferior medial genicular artery, inferior medial genicular artery, inferior medial genicular artery anastomosis with the superior medial genicular artery. And saphenous artery and the saphenous artery, this is which is a branch of descending genicular artery, and descending genicular artery is a branch of femoral artery. Descending genicular artery is a branch of femoral artery. Now talking about the third, superior lateral genicular artery, superior lateral genicular artery, superior lateral genicular artery. If I talk about superior lateral genicular artery, it anastomoses with superior lateral genicular artery anastomoses with the descending branch of lateral circumflex femoral artery, with the lateral circumflex femoral artery. And inferior lateral genicular artery and inferior lateral genicular artery. Okay, now talking about the fourth, that is the fourth point, inferior lateral genicular artery, inferior lateral genicular artery, inferior lateral genicular artery anastomoses with inferior lateral genicular artery anastomoses with the superior lateral genicular artery, with the superior lateral genicular artery, anterior and posterior recurrent, and also with the anterior and posterior recurrent branches of the anterior and posterior recurrent branches of anterior tibial artery and fibular circumflex fibular branch of the posterior tibial artery. So it anastomoses with superior lateral genicular artery, anterior and posterior recurrent branches of the anterior tibial artery and circumflex fibular branch of posterior tibial artery. So done. So done with this. So in short, we have finished with all the anastomosis also. So we have finished with the popliteal fossa, hamstring group of muscle. Now can we solve an MCQ related to this topic? Everyone? So via MCQ also I want to complete one or two topics. So let's start with this. The first one is oblique popliteal ligament is an expansion of which muscle? Oblique popliteal ligament is an expansion of the tendon of which muscle? Semimembranosus, I told you, Aradhana, absolutely right. Yes, semimembranosus is absolutely right answer here. Yes, semimembranosus is absolutely correct answer. Absolutely correct answer. Now, most anterior part in the tibial plateau. Actually, for this, I have to show you an image also. But before that, try to solve. If anybody is knowing, otherwise I will show you an image and then you can give me the answer. Most anterior structure on the tibial plateau. Most anterior structure in the tibial plateau. No, tibial plateau. No. Tibial plateau means the intercondylar area of the tibia. Ligamentum patella is lower down. It is in the tibial tuberosity, intercondylar area of tibia. Most anterior structure on tibial plateau, it means intercondylar area of tibia. Okay. Intercondylar area. Most anterior structure on tibial plateau is intercondylar area of tibia. So actually for this, I will like to show you this image and then you can give me the answer. So this is exactly the intercondylar area. Okay, so this is the medial condyle and this is the lateral condyle of tibia. In between, we have got the intercondylar area. So we are seeing the tibia from the superior aspect. So most anterior structure is anterior end of medial malleolus, anterior cruciate ligament, and so we have got anterior end of medial malleolus, anterior cruciate ligament. Then we have got anterior end of lateral meniscus. Then we have got posterior end of lateral meniscus. Then we have got the posterior end of medial meniscus, and lastly we have got the posterior cruciate ligament. So you can see there is a mnemonic also, Medical College Lucknow, Lucknow Medical College. So 3 structures are anterior and 3 structures are posterior. So 3 anterior structure means Medical College Lucknow, that means medial meniscus, cruciate ligament and lateral meniscus. 3 posterior structure is Medical College Lucknow is anterior structure. Lucknow Medical College is posterior structure. So Lucknow L for L for the lateral meniscus, posterior end of lateral meniscus, and C for cruciate ligament. So we will have Lucknow medical meniscus, and lastly we will have the cruciate ligament. So that means together we will have 3 anterior and 3 posterior structure. The mnemonic will be Medical College Lucknow Medical College. That means cruciate ligament. Posterior cruciate ligament is posterior most structure and anterior most structure is the anterior end of medial meniscus. So can you tell me now the right answer? Most anterior structure on tibial plateau. Most anterior structure. Now tell me the right answer. Most anterior structure on tibial plateau. Yes, now you got the right answer. Absolutely correct, Harit. Yes, absolutely correct, Harit. Yes, that is the anterior end of medial meniscus. Now, infromedial boundary of popliteal fossa is, which structure is forming infromedial boundary of popliteal fossa? Which structure is forming infromedial boundary of popliteal fossa? Which structure is forming infromedial boundary of popliteal fossa? Infromedial boundary of popliteal fossa is formed by anyone? Infromedial boundary of popliteal fossa is formed by absolutely correct. All of you are absolutely correct. It's the medial head of gastrocnemius. Absolutely correct. Yes, it is the medial head of gastrocnemius. Absolutely correct. It's the medial head of gastrocnemius. Which is not the content of popliteal fossa? Which of the following is not the content of popliteal fossa? Which of the following is not the content of popliteal fossa? Tibial nerve, popliteal vein, popliteal artery, long saphenous vein. Which of the following is not the content of popliteal fossa? Long saphenous vein is absolutely correct answer. Yes, dear, long saphenous vein or great saphenous vein is absolutely correct answer. Yes, it's absolutely correct answer. Yes, it is the content in the roof of femoral triangle, not in the popliteal fossa. We have got short saphenous vein or small saphenous vein as the content. Now, blood pressure in the lower limb can be recorded by which of the following artery? Blood pressure in lower limb can be recorded by which of the following artery? I have shown the palpation also. Blood pressure can be recorded by which of the following? So yes, Aradhana, Osama, absolutely everyone is giving the right answer and the correct answer is popliteal. Yes, absolutely correct. Next is gluteal region. Next topic is gluteal region. Now is the gluteal region. So gluteal region muscles. So if I talk about gluteal region, we have got many muscles in this category. So actually gluteal region contains few of the bulkiest muscle like gluteus maximus and all. It contains gluteus maximus, gluteus medius, minimus. Other than that, it contains many other muscle covered by gluteus maximus, that is we have got we have got gemellus superior, inferior, obturator internus. We have got quadratus femoris, piriformis muscle, tensor fascia lata on the lateral aspect, which I have already described in the session of anterior aspect of thigh. So gluteal region contains following muscle. Right on. Gluteus maximus muscle. Then we have got gluteus medius muscle. Then we have got gluteus minimus muscle. Then we have got also in this tensor fascia lata, but we have already discussed that. We have got piriformis muscle. Completing the list, we will have gemellus superior muscle. We will have gemellus inferior muscle. Obturator internus muscle. We will have quadratus femoris muscle. So all these muscles which has been shown you, all these muscles are the muscles of gluteal region. All these are the muscles of gluteal region. Obturator externus also functionally will be described here. So obturator externus also you can rise. So all these muscles are the muscles of gluteal region. Now let me show you an images for the gluteal group of muscle. So here you are seeing gluteus maximus muscle. This is the gluteus maximus muscle. This is the gluteus maximus muscle. Then we have got the gluteus medius muscle. And we have got the next one, that is gluteus minimus muscle. Now we will have okay. The other is we have got piriformis muscle. Piriformis muscle. We have got the piriformis muscle here. We have got the gemellus superior, gemellus inferior, and that of obturator internus. So here we have got, yeah, we have got gemellus superior, gemellus inferior. We have got obturator internus muscle, and lower down we have got quadratus femoris muscle. We have got quadratus femoris muscle. We have got quadratus femoris muscle. Okay, dear, we will finish few more topic and then I will give you a break. Please don't get exhausted. Everyone is exhausted. So actually, I could have skipped all the muscles of lower limb, but what I felt that if you are knowing the muscles also, it becomes easy for you. So I could have skipped the muscles, but I thought that muscles is also very important. So that is the thing which has to be known. Okay, dear. Okay, now, so it is gluteal region muscle. The other is, you can see the Other gluteus maximus, medius and minimus. Actually, outer quadrant of the gluteal region is covered by gluteus medius muscle. It is not overlapped. And when you remove the gluteus maximus and it is just cut it out, you can see many of the muscles are lying inside. Deepak Pranam, okay, yes, welcome dear, welcome. So we will have the piriformis, we will have the two gemellus, we have the obturator internus and quadratus femoris. Now, if I talk about the gluteal region muscle, it is composed of large number of muscle. We have got many of gluteal muscles. We will have gluteus maximus, we will have gluteus medius, minimus, and we will have also the other muscles, which is together forming three muscle originating from the ilium and the sacrum and inserting into the femur. Now here we can see the three gluteal muscle. So this is gluteus maximus muscle. This is gluteus medius and this is gluteus minimus. This is P for piriformis. Piriformis, this is the three muscles. These are the three muscles. Gemellus superior, obturator internal, gemellus inferior. And this muscle which you are seeing is the quadratus femoris. Quadratus femoris. Yes dear, मैडम 224 बैच के लिए कब से पढ़ाएंगे? मैडम 2024 बैच. Very soon, Deepak, I will let you know. Very soon, Deepak, this is the ma'am, your efforts. Thank you so much. Thanks, dear. So yes, thanks, dear. Actually, these are not only important for FMG exam, but it is also important for the NEET exam. I am giving you a detailed description. You can go through these videos. Also, I give the details of the notes to the group, and it's shared with you, so that is highly important for you. So that all things will make you clear all your doubts, and nothing is going to come out of this. 90% questions are from these notes and from these session only. I can understand that the session can be shortened also, but I think this is a rapid revision only. One will be the most elaborate, where we will go with chapter wise, but this is important for your competitive exam. Okay. Now here let's talk about, so here we can see the gluteus maximus muscle. So one by one I will elaborate about individual muscle. So if I am talking about gluteus maximus muscle, we can see gluteus maximus muscle is originating from the gluteal surface of ilium. It is originating from the lumbar fascia. It is also originating from the sacrum and sacrotuberous ligament. Insertion is, it is inserting into the gluteal tuberosity of femur, and the nerve supply is inferior gluteal nerve. So the nerve supply is inferior gluteal nerve, L5, S1, L5, S1 and S2. So when I am talking about this is very important. So this is about the gluteus maximus muscle. So gluteus maximus muscle, which has got a huge origin from gluteal surface of ilium, lumbar fascia, sacrum, sacrotuberous ligament, and the insertion is onto the iliotibial tract and gluteal tuberosity of the femur. Gluteal tuberosity of the femur. Now, action. If I talk about action of these muscles, gluteus maximus muscle is causing extension of hip joint. So gluteus maximus muscle causes extension of the hip joint. It is an external rotator. It is supporting the extended knee through iliotibial tract. The other important function of gluteus maximus muscle is it is supporting the extended knee through iliotibial tract, and antagonist of this muscle is psoas major minor iliacus. So the major flexors of the hip are antagonist of gluteus maximus muscle. When I am talking about, so I would like to give brief details about so exactly I would like to tell about the brief details which will be highly important for you. So let's talk about that. Okay. So here I just want that you should have an idea of when I'm talking about gluteal medius muscle. It is also actually greater trochanter is a very important bony structure in which many muscles are inserting. So on the greater trochanter lateral aspect, we have got an insertion of gluteus medius muscle. So if the next muscle is gluteus medius muscle, gluteus medius muscle. So the origin will be gluteal surface of ilium, which is lying under the cover of gluteus maximus muscle, and insertion is into the greater trochanter of femur. The nerve supply is via superior gluteal nerve, that is L4 L5 S1 nerve root. So what is the nerve supply? The nerve supply is L4 L5 S1 nerve roots, and its origin is from the posterior aspect of the gluteal surface, and insertion is gluteus medius is inserting into the lateral condyle. So if I am talking about gluteus medius, it is inserting onto the lateral aspect of greater trochanter. So actually that is also very, very important for you to understand, that it inserts onto the lateral aspect of greater trochanter. So greater trochanter, which aspect? Lateral aspect, because greater trochanter is a very important landmark where many muscle inserts. Gluteus medius inserts onto lateral aspect of the greater trochanter. Now gluteus medius, if I talk about its action, it is causing abduction of the hip. So anterior fibers of both gluteus medius and minimus muscle is also causing medial rotation, but overall action will be, it is causing abduction of the hip. So both gluteus medius and minimus is causing abduction of the hip, a very important action which must be known to you. Both of these muscle are causing abduction of the hip, and its anterior fibers are causing internal rotation. The nerve supply of both gluteus medius and minimus will be via superior gluteal nerve. Gluteus maximus will be innervated by inferior gluteal nerve. So gluteus minimus is maximus is inferior gluteal nerve, gluteus medius and minimus is from superior gluteal nerve. If I talk about minimus, it is also originating from gluteal surface of the hip bone and inserting into greater trochanter. Now which aspect of greater trochanter, that is important. So if I talk about if I talk about its insertion, it is inserting onto the anterior aspect. So exactly it is inserting on which aspect of greater trochanter? It is inserting onto the anterior aspect of greater trochanter. Nerve supply is superior gluteal nerve. So superior gluteal nerve is supplying both gluteus medius and minimus, and the action nerve supply is same for gluteus medius and minimus. They are abductors of the hip, and their anterior fibers are causing internal rotation of the hip. Tensor fascia lata we have also discussed in the anterior aspect of thigh. It is a muscle which is inserting into iliotibial tract, and its attachment is, it is originating from the iliac crest. So please note down, it is originating from the iliac crest and it is inserting, it is also originating from iliac and it inserts into iliotibial tract. So you can see this is the tensor fascia lata originating from posterior aspect of ASIS and iliac crest inserting into iliotibial band. The tensor fascia lata is also having the similar nerve supply as gluteus medius and minimus. Gluteus medius and minimus nerve supply is superior gluteal nerve, and insertion is and its action will be similar, that is abduction of the hip along with the important abduction and medial rotation. Innervation is superior gluteal nerve. Now the next muscle is piriformis muscle. So piriformis muscle is regarded as the key muscle of gluteal region because many structure passes above piriformis and many structures passes beneath piriformis, below piriformis. So its origin is from the sacrum bone. Which bone? It's originating from the sacrum bone and it is inserting into the greater trochanter. It is also inserting into greater trochanter. When I'm talking about piriformis muscle, why it is important to know about piriformis muscle? Because it is inserting onto the apex of greater trochanter. It is inserting on which aspect of greater trochanter? It is inserting onto the apex of greater trochanter. Nerve supplies nerve to piriformis and action is external rotators of the thigh. Actually, all that small muscle, piriformis, obturator internus, obturator externus, gemellus superior, gemellus inferior, all these are highly important. Why? Because they are lateral rotators of the hip. Why? Because they are lateral rotators of the hip, so they are important. So this is the piriformis muscle, the key muscle, and this is quadratus femoris, and this is gemellus superior, this is obturator internus, and this is gemellus inferior. So it is inserting into the greater trochanter apex and originating from sacrum. The next is obturator internus muscle, which is originating from ischiopubic ramus and obturator membrane, inserting onto the medial aspect of greater trochanter. Actually, on the medial aspect of greater trochanter, not only obturator internus, but along with it, gemellus superior and inferior is also there. So gemellus superior, gemellus inferior, and obturator internus, these three muscles together inserts onto the medial aspect of the greater trochanter, and action is lateral rotation of the hip. Nerve supply will be nerve to obturator internus, root value is L5, S1 and S2. So here we can see the action is lateral rotation of the hip, and innervation is nerve to obturator internus, L5, S1 and S2. Now coming to obturator externus, from the outer aspect of obturator foramen and membrane, and insertion will be in the trochanteric fossa of the femur, and it is also the lateral rotators of the hip, and it's importantly nerve supplied directly by third and fourth lumbar nerve. So obturator externus is also getting innervation from obturator nerve, and that posterior branch of the obturator nerve, which is having the root value L3 and L4. Now here we can see the important muscles of gluteal region. We have got gemellus superior, gemellus inferior, gluteus minimus, obturator externus, internus, quadratus femoris. Now, gemellus superior and inferior. What I told you about gemellus superior and inferior. Gemellus superior and inferior along with obturator internus are the three muscles that conjointly insert onto the greater trochanter medial aspect. So, here I just want you to tell. So, we have got superior gemelli, we have got superior gemelli, and we have got inferior gemelli. So, if I am talking about superior gemelli, it is originating from the outer aspect of ischial spine. It blends with the tendon of obturator internus and inserts onto the medial aspect of greater trochanter. The nerve supply of superior gemelli is similar to obturator internus. Both of these muscle has got similar innervation. Both are lateral rotators and both has got similar nerve supply, that is nerve to obturator internus. Nerve to OI means obturator internus, root value is L5, S1 and S2. Now inferior gemelli is from the ischial tuberosity below the groove. It blends with the lower part of obturator internus, inserts conjointly on the medial aspect of greater trochanter. The nerve supply of gemellus inferior and that of quadratus femoris is similar. Quadratus femoris is similar. And what is its nerve supply? The nerve supply is called as nerve to quadratus femoris. The name is nerve to quadratus femoris. Root value is L4, L5 and S1. So both of it has got similar nerve supply. Next muscle is quadratus femoris. Why it is called as quadratus femoris? Because its shape, as you can see in this image, the shape is quadrangular. Why it is called as quadratus femoris? Because its shape is quadrangular. Origin is from ischial tuberosity. The origin is from ischial tuberosity. Insertion is into the intertrochanteric crest. Action is lateral rotation of the hip. Nerve supply is nerve to quadratus femoris. Now, it's very, very important that you should know all the structures which is located beneath gluteus maximus muscle. So the brown color outline which you are seeing, is the outline of gluteus maximus muscle. So that is the outline of gluteus maximus muscle, and many structures are lying beneath it. So I just want everybody to understand the structures lying beneath it will be the part of gluteus medius muscle. So this is the part of gluteus medius muscle. So a part of gluteus medius muscle is lying superiorly also, which is not covered. So please note down, this gluteus medius muscle part is not covered by the gluteus maximus. A small part of gluteus medius is covered, but not the entire part of gluteus medius is covered. So that is also very, very important for you to note down. Yes, Dr. SK, you are right. Yes, Dr. SK, both are same. Both are, yes, both are same. Yes, both are same. External rotation and lateral rotation both are same. Yes, dear. Dr. SK, you are right. Both are same. Now, the key muscle will be piriformis muscle. So, this is the piriformis muscle. Gemellus superior, inferior, obturator, internus, quadratus, femoris. So, origin of the hamstring group of muscle, all these muscles, also the nerves. So, yes, we will have the superior gluteal nerve, the inferior gluteal nerve, we will have the sciatic nerve, the posterior cutaneous nerve of thigh, the perforating cutaneous nerve of thigh, we will have the pin structures. So, all these structures are covered and sacrotuberous ligaments. Structure under the gluteus maximus are a group of muscles. So, we have got many muscles like gluteus medius, part of gluteus minimus, obturator internus, gemellus superior, gemellus inferior, piriformis muscle, quadratus femoris, and origin of hamstring muscle, origin of hamstring group of muscle. Other than that, it is also important that nerves and vessels will be lying there. The important nerves and vessels, nerves are, important nerves and vessels are, we will have pin structure. Nerves are nerve to obturator internus will be lying there. Nerve to quadratus femoris will be also covered. We will have sciatic nerve covered by the gluteus maximus. We will have the perforating nerves and posterior cutaneous nerve of thigh. Other than that, we will have vessels. We will have superior gluteal vessels, superior and inferior gluteal vessels. We will have sacrotuberous ligament. Actually, we will have sacrotuberous ligament. So, also we will have sacrotuberous ligament. We will have certain bursas which is lying under the cover. So, basically, what is most important, I will target that. You can see that there is two foramens, greater sciatic foramen and lesser sciatic foramen. And piriformis muscle is regarded as the key muscle of gluteal reason. Why? Because some structures are passing above it, some structures are passing below it. So, when you go for dissection, you get an idea of location of these structures. For example, you can see superior gluteal nerves and vessels are lying above piriformis muscle, and inferior gluteal nerves and vessel along with sciatic nerve, nerve to obturator internus, posterior cutaneous nerve, all these structures, also the pin nerve, pudendal nerve, internal pudendal vessels, and nerve to obturator internus, PI, and pin nerve, all these structures are traversing below piriformis muscle. So, I just want everybody, for your examination, it is highly important that you should know the list of structure which is passing through greater sciatic foramen and the list of structure which is passing through lesser sciatic foramen. So, the structures passing through greater sciatic foramen and the structures passing through lesser sciatic foramen. So, this is the structure passing through greater sciatic foramen. These are the structures passing through lesser sciatic foramen. So, here we can see the structures passing are above. So, structures passing above piriformis is superior gluteal nerves and vessels. Below it is inferior gluteal nerves and vessels, sciatic nerve, perforating cutaneous nerve, posterior cutaneous nerve, nerve to obturator internus, internal pudendal vessel, and pudendal nerve. Now, below, so four structures are passing through lesser sciatic foramen, which is traversing through greater sciatic and then traversing the lesser sciatic. We have got that as a pin structure, but four structure passing through lesser sciatic foramen will be PI and pin structure along with the tendon of obturator internus. Here P stands for pudendal nerve, I for internal pudendal vessel, and N for nerve to obturator internus, along with it the tendon of obturator internus. These are the four structure which is passing through lesser sciatic foramen. Actually, this list of structure is highly important for you to know. So, only I have given all this list. So, this is highly important that you should know this list of structures traversing. Now, gluteal gate. Now, exactly why I am explaining you gluteal gate is exactly if there is an injury of superior gluteal nerve. Which nerve? Superior gluteal nerve. Superior gluteal nerve is innervating two muscles. Superior gluteal nerve is innervating gluteus medius and minimus, and these two muscles are abductors of the hip. So actually when you stand on one leg, the other side of hip is supported by gluteus medius and minimus of other side. So if there is an injury of superior gluteal nerve, what will happen? The muscle which is paralyzed is the gluteus medius and minimus and tensor fascia lata. So the other side of hip will sag down if you stand on one leg. So the gait, the walking, this is called as Trendelenburg sign positive, and the patient will have waddling or shuffling gait. So for this, I just want you to show this. In case of superior gluteal nerve injury, gluteus medius and minimus is paralyzed. Which are abductors of the hip. So the other side of hip is not so. So you can see normal case, the other side, when gluteus medius and minimus are not paralyzed, the other side of hip is slightly raised. But when you see gluteus medius and minimus are paralyzed, the other side of the hip sag down. So this is, and the person will have waddling gait. For when he walks, he will sag on either side, and the unsupported side of hip will sag down. So the unsupported side of hip sagging down, and this is due to superior gluteal nerve injury. This is due to gluteus medius and minimus being paralyzed. And what is the reason of these muscles being paralyzed? The injury of superior gluteal nerve, and these are abductors of the hip. So my dear students, can we have the MCQs related to the topic? Is it okay? Can we discuss few MCQs related to the topic? So let's start. Gluteus maximus inserts on which of the following structure? Gluteus maximus muscle inserts on lesser trochanter, greater trochanter, spiral line, or iliotibial tract. Thanks, dear. Gluteus maximus inserts into Aradhya. Okay, Aradhya Aurora has given the right answer. So Aradhya, this is the right answer, iliotibial tract. So Aradhya has given the right answer. Yes, Aradhya. Dr. Aradhya has given the right answer. So this thumbs up goes for Aradhya. Absolutely correct, Aradhya. It is the iliotibial tract in which the gluteus maximus muscle inserts. Got it? Now the next is true statement regarding origin and insertion of piriformis muscle. Which of the following is true statement regarding origin and insertion of piriformis muscle? True statement regarding origin and insertion of piriformis muscle. The origin is from sacrum and ilium, and the insertion is LT. Here LT means lesser trochanter, GT means greater trochanter. So I got a great answer from one of the students. He is absolutely right, and that is Dr. SK. It is originating from sacrum, ilium, and inserting onto greater trochanter. On which part of greater trochanter? If you remember, yes, Aradhya and Dr. SK absolutely right. They are originating from sacrum, ilium, and inserting onto the greater trochanter of femur. Absolutely correct answer. Dear. Gluteus muscle. So which of these following muscle is inserting into lateral aspect of greater trochanter? Which of the following muscle inserts onto the lateral aspect of greater trochanter? Gluteus maximus, gluteus medius, gluteus minimus, or piriformis? According to you, which is the right answer? Which of the following muscle inserts onto the lateral aspect of greater trochanter? I think the greatest showman. So I am getting a right answer from the greatest showman, from Dr. SK, and from Aradhya Arora, and all of you are perfectly correct. Perfectly correct. The right answer is gluteus medius. Gluteus medius muscle is B. Those who have given B as the right answer, I mean to tell those who have given B is the right answer. Gluteus medius is the muscle which is inserting onto lateral aspect of greater trochanter. Here, maximus is not inserting to greater trochanter, it is inserting in gluteal tuberosity and iliotibial track or band. Gluteus medius on the lateral aspect of greater trochanter. Gluteus medius on the anterior aspect of greater trochanter, and piriformis onto the apex of greater trochanter, onto the apex of greater trochanter. Got it, everyone? Now, gluteus medius is supplied by which of the following nerve? Gluteus medius is supplied by which of the following nerves? Gluteus medius is supplied by which of the following nerve? Okay, gluteus medius is supplied by. So, though Jayashree Rathore has given a right answer. Jayashree, you have given the right answer, that is superior gluteal nerve. Superior gluteal nerve is the right answer. Yes, superior gluteal nerve is the right answer. Gluteus medius is supplied by superior gluteal nerve. It's supplied by the superior gluteal nerve. Absolutely correct. Absolutely correct. Oh, so sorry. Absolutely correct. That is the superior gluteal nerve. I will just, yeah. That is the superior gluteal nerve. Absolutely correct. Now, positive Trendelenburg sign is associated with the injury of quadriceps femoris, adductor group of muscle, abductors of the thigh, hamstring, and piriformis muscle. Jayashree SK, the greatest showman, Aradhya Arora. So everyone is giving a right answer. Everyone here is giving the right answer. Absolutely correct. And the right answer is abductors of the thigh. So the right answer is abductors of the thigh. Absolutely correct. Abductors of the thigh, gluteus medius minimus tensor fascia lata, supplied by superior gluteal nerve, is the reason of positive Trendelenburg sign. Absolutely correct. Now, identify the marked muscle of the gluteal. This is an image-based question. My dear students, this is an image-based question. So, I will just tell you about, firstly, this is an image-based question. So, 4 muscles are there: obturator externus, obturator internus, quadratus femoris, and piriformis. Now, I am going to enlarge this. So, see here. This is the arrow marked muscle which you have to identify. So, this is one muscle. This is another muscle. This is also one muscle. This is other muscle. These are the other muscles. Now, the arrow marked muscle you have to identify. So, arrow marked muscle, you have to identify the arrow marked muscle and tell me the right answer. So, I will rub this once again. So, you can get confused. I will just mark an arrow here. This is the muscle which I am asking. This is the muscle. This muscle, dear, this muscle I am asking. Which muscle is this? I am asking about this muscle. Which muscle is this? Mohammed Soeb, piriformis D. So now tell me the right answer. So actually one of the student has given me the right answer, and that is Mohammed Soeb. Mohammed Soheb has given the right answer. Mohammed Soheb, this is an image based question. Very good answer given by you. Such kind of image only you will get. You will not get a very clear picture. So hazy. Yes, the right answer is quadratus. So my dear, piriformis is this muscle. This is P for piriformis. See here. This is P for piriformis. This is quadratus femoris. And here we will have three muscles here. Here we will have three muscles. What are these three muscles? That is, the three muscles will be gemellus superior, obturator internus, and gemellus inferior. Got it? So the correct answer is quadratus femoris. The muscle marked in the gluteal region will be the quadratus femoris muscle. So the correct answer is quadratus femoris muscle. The correct answer will be quadratus femoris muscle. Absolutely a thumbs up goes for Mohammed Shoaib. Mohammed Shoaib. Action of the muscle at the hip to the marked area. So that means firstly you have to identify this area of the femur. Which bone is this? This bone is femur bone. So this is the femur bone. This is the greater trochanter. This is the lesser trochanter of the femur bone. This is the head of the femur bone. This is the neck of the femur bone. So here, and you have to know which structure is this. So that is a hint which structure. Firstly, identify what is that arrow marked line and the area. So you have to identify which part of the femur bone is that, and then you have to give me the right answer, the action of the muscle attached. Firstly, so actually this one MCQ is having 2-3 MCQs attached to it. So this is having 2-3 MCQs attached to it. So firstly, identify this area of the bone. Then you have to tell me the muscle attached to it, and then you have to tell me the action of the muscle attached to it. No, firstly tell me which bony structure is this. Can you tell me arrow marked area of the femur? Which in the femur bone, this arrow marked area is which structure? Anybody? This arrow marked structure is which, this arrow marked area is which structure? This arrow marked structure is gluteal tuberosity, which is gluteal tuberosity. Now you have to tell me on the gluteal tuberosity, there is one muscle which is inserted. So on gluteal tuberosity, there is one gluteal muscle which is inserted. And the name of that gluteal muscle is? Also, there is a gluteus maximus muscle. There is a gluteus maximus muscle which inserts on. Yes, great showman has again given the right answer. Great showman is again given the right answer. Yes, dear, that is the gluteus maximum inserts here, inserts on gluteal tuberosity and iliotibial band or tract. So we have to know the action of gluteus maximus muscle, and we know that gluteus maximus muscle is an important extensor of hip. So we know that gluteus maximus muscle is an important extensor of hip, and along with extension it can also cause slight lateral rotation. So the right answer will be extension and lateral rotation. So this is A, this is B, this is C and D. So the right answer will be B. Who has given B? No one has given B, but they have identified the muscle attached on it. So a thumbs up for that. Absolutely correct. No, B answer is given by Mohammed Soeb. Absolutely correct. Yes, dear. So that is absolutely correct, dear. Yes, you are absolutely right. That gluteus maximus muscle is the muscle which is attached on gluteal tuberosity and iliotibial band, and it is one of an important extensor of the hip, and slight lateral rotation is also done. Gluteus maximus muscle, major part inserts into iliotibial tract. Major part of it inserts into iliotibial tract, and small part of it inserts into gluteal tuberosity. The arrow marked area of the femur bone is gluteal tuberosity, and the muscle attached or inserted on this point is the gluteus maximus muscle. Absolutely correct. Now, one more question. Patient with positive Trendelenburg sign, what is the action of muscle being involved? Okay. Ma'am, you are teaching in a particular application how to see all your lectures. Dev Tripti, so many lecture are yet to come. Dev Tripathi, many lecture is yet to come. Okay, all lecture has not been in on this platform. I have started few days back only on giving my lectures on Sir's platform, Dr. Bhanu platform. So basically, in meanwhile, I will be giving other lectures. Few lectures I have taken, 2-3 lectures only I have taken previously. 3 lectures, I think 3 lectures has been taken. So you can go through that 3-4 lectures. No, 4 lecture has been covered up. This is the 5th one. So 2-3 lectures more I will take, and then after completion of this, we will also have the topic wise sessions. We will have most important MCQs. We will have image. Many sessions will be upcoming. So don't worry. All the links will be soon provided to you. Okay, Dev Tripathi, is it okay? So yes, the right answer will be the position with a positive Trendelenburg side. So the right answer will be actually the muscle paralyzed is gluteus minimus and gluteus medius, and we know that gluteus medius and minimus is abductors of hip. They are abductors of hip, but anterior fibers of these muscle are causing anterior fibers of gluteus medius and gluteus minimus muscle is also causing internal rotation of the hip. It is also causing internal rotation of hip. Internal rotation of the hip. So, patient with a positive Trendelenburg sign and the muscle involved, the right answer will be abduction and internal rotation. So, the right answer is C. Internal rotation, dear. Lateral rotation is the action done by piriformis, obturator internus, obturator externus, quadriceps femoris, gemellus superior, gemellus inferior. So, basically abduction and internal rotation will be the right answer. I think Mohammad Sohaib has given the right answer. Now, absolutely correct. Mohammad Sohaib, you are absolutely right. Anterior fibers of gluteus medius and minimus are causing internal rotation of the hip, but the major part is causing abduction of the hip. So, we know Trendelenburg sign will be positive when there is injury of which nerve, dear? Superior gluteal nerve, and we know that superior gluteal nerve is innervating 3 muscles: gluteus medius, gluteus minimus and tensor fascia lata. So, the reason of positive Trendelenburg sign is due to injury of superior gluteal nerve, due to paralysis of gluteus medius minimus, and the action involved will be abduction and internal rotation. So, done with this. So, exactly we have covered the first part of lower limb. So, by this we have finished the first part of lower limb, but I have got many more topics. Legs and joints are remaining. So, we have got many more topics in the lower limb. So, I will give you a brief and then I will give you a break of 20 minutes, 25 minutes, and then again I will start the session. So, actually, yes, all of you can have your lunch. I will start after lunch. So, how much time you want break? How much time break you want, dear, for lunch? How much time break you want? Lower limb part 2. Part 1 is covered up, but I want to start with the part 2, lower limb part 2. So, how much time you want? SK is 30, 20. Okay, in between 20 and 30. Yes, yes, we will have a slight lunch break. Yes, it will take at least 20 minutes to chahiye. 20 to 25 minutes. Okay, okay, 30 minutes. Okay, 30 minutes, 25 to 30 minutes I will give. Have your lunch and then again come do your namaz also. Yes, it's that is important. And then we will connect with the lower part. Legs are very important. Very simply we can understand the legs. Then I will cover up all the joints of the lower limb. Then we will have the session of all the nerves, medial longitudinal arch, the venous drainage and the lymphatic drainage, and we will finish with the topic of lower limb. All the best and keep studying. Next lecture after 25 minutes. After 25 minutes. After 25 minutes, I will start. After 25 minutes, I will start. Okay, dear. So, basically, after 25 minutes, I will start and then Yes, Dr. SK, thank you. So I will just give you 25 minutes. You will have your lunch in 15 minutes. You can have your namaz, puja in 5 minutes, 5 to 7, 8 minutes. And that will be okay because we have to cover, still I have to teach more of 3 4 hours. 3 hours minimum I require, 3 to 4 hours for completing the entire lower limb. Okay, tomorrow will be the lecture of the upper limb, that will exactly start in the morning 9 a.m. Okay, so that all things has to be covered up. Is it okay? Any doubt till now? Any doubt till now? My dear students is having any doubt, they can let me know. All the best and keep studying. Any doubt? Yes, yes, yes. Neuroanatomy already covered. Yes, dear, neuroanatomy already covered. One of the student is asking about neuroanatomy. I have already covered in the previous session. The link is there. Go just search Dr. Monalisa neuroanatomy series on this platform. You will get the neuroanatomy part also. Okay. Thank you. Okay, neuroanatomy, just search for previous session. So you can just search for previous session. You will get the neuroanatomy part also. Now, okay, can I go for lunch? You all also can have your lunch. Okay, dear. We'll meet after 25 minutes. Okay, great. Thank you. We will again meet after 25 minutes. Thank you. Hello everyone. So I'm right back. Okay. So everyone, can you, yes, am I audible? Just checking. Am I audible? Okay, okay. Yes, I am audible. Yes, Aradhana Arora. Okay, now we will start with the type 2 part 2 of the lower limb. Part 1 we have finished. Here what is important is to know about the important muscles we have to know. So of the legs. So we will talk about the muscles of the leg. So let's start with that. So in this we have to understand the compartments. So let's start with the compartments of the leg. So in this you can see a transverse section. So here you can see the transverse section. Okay, so here you can see the transverse section of the leg. Intermuscular septas has been seen, and you can see three compartments are there in the leg. There is anterior. So there is an anterior extensor compartment, there is a lateral compartment, and there is a posterior compartment. The posterior compartment is divided into superficial and deep part. So individually you have to know about the details of individual compartments of the leg. You have to know all the muscles residing there. You have to know the important nerves and arteries residing in each compartment of leg. That is very, very important for you to know. That is highly important. You can't leave this important topic. So that is highly important for you to know down. So basically, so firstly, I would like to start here. The three compartments has been shown. You can see we have got the peroneal compartment. So here we have got the lateral or the peroneal compartment. This is the lateral or the peroneal compartment. Okay. So this is the lateral or the peroneal compartment. Then we have got the anterior extensor compartment, and we have got posterior compartment. So firstly, I would like to start with the muscles of anterior compartment. So when I'm talking about the anterior compartment, what do you mean? We have to study about all the muscles lying in the anterior compartment. So if I'm talking about anterior compartment of the leg, it is consist of following muscle. It is consist of tibialis anterior. It is consist of extensor hallucis longus, extensor digitorum longus, and peroneus tertius. So basically all these muscles are the muscles of anterior compartment of the leg. So please write down the name of the muscle. The muscles are tibialis anterior, tibialis anterior, extensor hallucis longus. The muscle is extensor hallucis longus muscle. The muscle is extensor digitorum longus. Digitorum longus muscle, and the muscle are peroneus tertius. So all these muscles you have to study. You have to study all these muscles of anterior compartment of the leg. You have to know about the attachment. So tibialis anterior, if I am talking about tibialis anterior, it's a spindle shaped muscle, and which will have some important muscles. Circumpinate fibers consist of multiple muscle fibers, multipinate muscle fibers, and exactly one by one we will come with the details of this. So the first muscle which I want everybody to understand is tibialis anterior muscle. This is the tibialis anterior. So we will briefly talk about individual muscle, and then we will cover up the joints and then the nerves. Okay. So that is highly important for you to understand. Tibialis anterior. So let's talk with the tibialis anterior. So when I am talking about tibialis anterior, it is originating from upper so it is originating from upper half and upper two-third of the lateral aspect of tibia and adjacent part of interosseous membrane. If I talk about insertion, so it is inserting onto the medial cuneiform and the base of first metatarsal. So basically the insertion of tibialis anterior muscle will be in the base of the first metatarsal and the insertion will be in the medial cuneiform. So it is inserting into medial cuneiform and the base of first metatarsal and the base of first metatarsal. So this is about the insertion point. This is about the insertion point of tibialis anterior. Exactly one of the important point I want to tell about all the muscles of anterior compartment of the leg. All the muscles of anterior compartment of leg has got a common action and a common nerve supply. All the muscles of anterior compartment of the leg has got innervation by deep peroneal nerve and their action is dorsiflexion of the foot. So dorsiflexion of the foot. Other than dorsiflexion, it is also causing inversion of the foot. So when I am talking of tibialis anterior muscle, its nerve supply is by deep peroneal nerve L5 and its action is dorsiflexion of the foot and the inversion of the foot. The action is dorsiflexion of the foot and inversion of the foot. Okay. So this is about the action of tibialis anterior muscle. Now coming to the next muscle, that is the so we'll talk about the next muscle, that is extensor hallucis longus muscle. So extensor hallucis longus muscle. Let's talk about that. So extensor, firstly we will talk about extensor digitorum longus and then we will talk about extensor hallucis longus muscle. So by the word digitorum longus, when I am using the word digitorum longus, what do you mean by the word digitorum longus? The word digitorum longus means it is going into the digits, it is going into the lateral four toes. So if its insertion is onto the lateral four toes of the digit, so it is going into lateral four toes. And if I talk about its origin, it is originating from anterior lateral condyle of tibia, anterior shaft of fibula and superior aspect of superior 3/4 of the interosseous membrane. The nerve supply is deep peroneal nerve. The nerve supply is deep peroneal nerve and the action is extension of toes and dorsiflexion of the ankles. Okay. Now extensor digitorum longus muscle. Extensor digitorum longus muscle. So let's talk about extensor digitorum longus muscle. So extensor digitorum longus muscle, the nerve supply will be deep peroneal nerve and its origin will be from the anterior shaft of the fibula and anterior aspect of the 3/4 of interosseous membrane. So it is originating from the anterior condyle of tibia and also the anterior shaft of fibula and also from the interosseous membrane. If it is talking about digitorum, so it will be inserting into lateral four toes. Nerve supply will be same, deep peroneal nerve, and the action will be extension of toes and dorsiflexion of ankles. Extensor hallucis longus. The word hallucis means great toe. So if we are talking about hallucis, it means the great toe. So the extensor hallucis longus, if I am talking about hallucis muscle, it is arising from the interosseous membrane and middle portion of the fibula. So it is arising from the part of the portion of the fibula and interosseous membrane. The word hallucis means it is inserting into great toe. So insertion is onto the distal aspect, distal phalanx of the big toe, great toe. Nerve supply with deep peroneal nerve, and as I told you, all the muscles of anterior compartment are dorsiflexor of foot. Along with it, the word extensor hallucis means extension of great toe, extensor digitorum means extension of the other toes. The next muscle is peroneus tertius. Peroneus tertius. The if I am talking about peroneus tertius muscle, so if I am talking about the peroneus tertius muscle, it originates from the anterior aspect of fibula and also it is originating from the fibula and also the interosseous membrane. Its nerve supply is again deep peroneal nerve and its action will be that of dorsiflexion of the foot and also the eversion of the foot. So peroneus tertius along with the dorsiflexion, it is also causing eversion of the foot. The insertion is on the dorsal aspect of fifth toe. It is inserting onto the fifth toe and arising from the interosseous membrane and dorsal distal anterior surface of the fibula. So done with this. So we have done with all the muscles, and it's very important for you to know about briefly about these muscles location and its important location. So by the name only it is clear, the action is very easy. When I am talking about all the muscle has got a common action, that is dorsiflexion of ankle joint. Other than that, tibialis anterior is also causing inversion of the foot. Extensor hallucis longus and extensor digitorum is causing extension of all the toes and great toe, and peroneus tertius is also causing the eversion of the foot. Other than that, for attachment, we have already seen the images. For digitorum, it is going into lateral four toes. For hallucis, it is going into the big toe. Now, coming to next, anterior tibial artery. So I would like to talk about anterior tibial artery. Actually, anterior tibial artery. So why not nerves? Nerves as a separate topic. So after completing this compartments of the leg, we will complete the joints and then we will come with the nerves. So nerves, I will talk about all important nerves together. Anterior tibial artery. If I am talking about anterior tibial artery, it is the main artery of the leg. The blood supply of all, so it's the main artery of anterior compartment. Anterior tibial artery is the main artery of anterior compartment of leg. Anterior compartment of leg. Okay. Now, anterior tibial artery. So if I am talking about anterior tibial, you can see here, this is the anterior tibial artery, which is the main artery of anterior compartment of the leg, which on the dorsum of foot becomes dorsalis pedis artery. So which on the dorsum of foot becomes so actually popliteal artery. If I am talking about the anterior tibial artery, is the smaller terminal branch of popliteal artery. It's a smaller terminal branch of popliteal artery, and it will be giving blood supply to anterior aspect of the leg, and it will continue on the dorsum of foot, forming the dorsalis pedis artery of the foot. So let's talk about important cores and the branches of anterior tibial artery. So please write down details about anterior tibial artery. The anterior tibial artery anterior tibial artery the anterior tibial artery the anterior tibial artery is the smaller terminal branch of the popliteal artery. It begins in the back of leg. It begins in the back of leg at lower border of popliteus muscle, at lower border of so it begins at the back of the leg at the lower border of popliteus muscle, at the lower border of popliteus muscle. It enters the anterior compartment of leg. It enters the anterior compartment of leg. It enters the anterior compartment of leg by passing forward close to the fibula through opening into through opening in the upper part of intraosseous membrane. Upper part of intraosseous membrane. Now in the end it runs thereafter it runs vertically downwards. 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 Thereafter it runs vertically downwards to the point midway between the two malleolus, where it changed its name as anterior as dorsalis pedis. So this is how the anterior tibial artery becomes dorsalis pedis. So this is how the anterior tibial artery becomes dorsalis pedis. Now the next important point about anterior tibial artery is that you should know the branches, and then we will talk about dorsalis pedis. So it is important that you should know the branches of anterior tibial artery, and then we will talk about the dorsalis pedis artery. Then we will come to the lateral compartment. So just write on the heading: branches of anterior tibial artery. Branches of anterior tibial artery. Branches of anterior tibial artery. The important branches of anterior tibial artery is following. So what are the important branches? It gives muscular branches. So it gives muscular branches to the neighboring muscles of the anterior compartment. It gives anastomotic branch. It gives anastomotic branches to knee and ankle joint. It gives anastomotic branches to knee and ankle joint. So the anastomotic branch of knee joint are, so it gives anterior and posterior tibial. It gives anterior and posterior tibial recurrent arteries as the branch, anterior and posterior tibial recurrent arteries as the branch, and it gives anterior medial malleolar. It gives anterior medial malleolar and anterior lateral malleolar and anterior lateral malleolar branches. Okay. Now, other than that, so exactly these are the important branches of anterior tibial artery I have written, and it continues as dorsalis pedis artery. So let's talk about dorsalis pedis artery. So if I am talking about dorsalis pedis artery, it is also called as dorsal artery of foot. What is the name? It is also called as dorsal artery of foot, and is the chief palpable artery on the dorsum of the foot. So on the dorsum of foot, it is the chief palpable artery. So please note that. It is the chief palpable artery of the dorsum of the foot, of the dorsum of foot. It is commonly palpated in the patient of vasculo-occlusive disease. So it's an important point about this artery is it is the artery which is palpated. It is the commonly palpated artery. It is the commonly palpated artery. It is a commonly palpated artery. It is a commonly palpated artery in vasculo-occlusive disease of lower, in vasculo-occlusive disease of lower limb. In vasculo-occlusive disease of lower limb. Now the artery, if I talk about the artery, so let's talk. So you can see here, this is the dorsal pedis artery, which is exactly seen to pass between the two malleoli. And it is firstly passing between the two malleolus, as here it is passing between the two malleolus, the lateral and medial malleolus. Thereafter, what will happen? It will be passing forward along the medial side of the dorsum of the foot, along the medial side, as you can see, and thereafter it will pass to the proximal end of the first intermetatarsal space. So intermetatarsal space, and ultimately it will pass between two heads of the first dorsal intermetatarsal space, and it will be ending in the sole by forming the plantar arterial arch. So in the sole, it will go into the sole and will form plantar arterial arch. So write down about dorsalis pedis artery. The artery, if I talk about dorsalis pedis artery, the artery begins in front of the ankle. It begins in the front of ankle between the two malleoli. Between the two malleoli, it passes forwards along the medial side of it passes forward along the medial side of the dorsum of foot, to reach the posterior end of So exactly it passes forward along the medial side of the dorsum of the foot to reach the proximal end of first intermuscular space. To the first intermuscular space. Got it? Now thereafter, here it dips downwards. So here it dips downwards. Between the two heads of first dorsal introosseous muscle, and ends in the sole by completing the plantar arterial arch. Okay, so this is the whole details of the dorsalis pedis artery. Now here you can see exactly. If I talk about dorsalis pedis artery, it's we have to know its branches also, and you can see it is exactly palpated between the two malleoli. So exactly dorsalis pedis artery is palpated between the two malleoli, and it is palpated close to the tendon of extensor hallucis longus. So before that, I just want, please write on the list, that is the branches of dorsalis pedis artery. Write on branches of dorsalis pedis artery. Branches of dorsalis pedis artery. Branches of dorsalis pedis artery. The branches of dorsalis pedis artery is following. Branches are, it gives lateral tarsal artery, it gives lateral tarsal artery. It gives medial tarsal artery. It gives arcuate artery. It gives arcuate artery. It gives first dorsal metatarsal. It gives first dorsal metatarsal artery. Dorsal metatarsal artery. Okay, so basically these are the important branches of dorsalis pedis artery. Now we have completed this, and now the next topic is the muscles of lateral compartment. So let me just tell the students. No, medico. DPM is means dorsalis pedis artery is an important artery to be palpated. So exactly dorsalis pedis artery. For example, other arteries are not easily accessible. So medico, if we are talking about Mohammed Shoaib, next class, ma'am, hip joint. Hip joint is coming up. It is exactly world nature here. So many are. So I have to use English because many of the students are from South also. So they want me to speak in English only. So when I am talking about vasculo-occlusive disease, it is a commonly palpated artery. It's very easily in between the two malleoli on the dorsum of the foot, close to the extensor hallucis longus tendon. The dorsalis pedis artery can be palpated. So easily accessible. So that is easily accessible. Okay. So that is easily accessible. So only we go with the dorsalis pedis artery palpation in vasculo-occlusive disease. Okay, medico. Now, if I am talking about muscles of lateral compartment, we have got two muscles in the lateral compartment. One is peroneus longus and the other is peroneus brevis. So how many muscles in the lateral compartment of the leg? The lateral compartment of the leg is also called as peroneal compartment. So we have got two muscles. So write down, there are two muscles in the lateral compartment of the leg, and these muscles are peroneus longus and peroneus brevis. And the nerve, so exactly common feature about these two muscles are everters of the foot, and these if I talk about the nerve supply of peroneal or lateral compartment of the leg, the nerve supply of peroneal or lateral compartment of leg is via superficial peroneal nerve, So the first muscle in this group is peroneus longus. Is peroneus longus. Is peroneus longus. Is the peroneus longus muscle. So when I am talking about peroneus longus muscle, it's the muscle which is originating from the fibula bone. So exactly it is originating from the head of fibula and the lateral aspect of the shaft of fibula. So basically it is originating from the shaft of fibula and head of fibula, and it is inserting. If you will see, the insertion is into the peroneus longus muscle is inserting into cuneiform and base of first metatarsal. So you can see it is traversing all the way from lateral side and it is inserting onto the medial aspect. So if you will see peroneus longus muscle, it is traversing all the way from the lateral aspect of the fibula, and insertion point, if you can appreciate, it is inserting onto the base of first metatarsal and the medial cuneiform. So it is inserting into medial cuneiform and base of first metatarsal. Okay, now coming to the peroneus brevis muscle. The next is peroneus brevis muscle. So if I am talking about peroneus brevis muscle, the peroneus brevis muscle is arising from the lateral two-third of the lateral aspect. So it is arising from the lateral aspect of fibula. It is arising from the lateral aspect or lateral two-third of the fibula. Insertion is onto the fifth metatarsal. Insertion is on the fifth metatarsal. Nerve supply is superficial peroneal nerve, and the action is eversion of the foot. Both peroneus longus and peroneus brevis muscles are everters of the foot. Common nerve supply is superficial peroneal nerve, originates from the lower part of the fibula, and insertion is onto the fifth metatarsal, and insertion of peroneus longus is on the first metatarsal and medial cuneiform. Now, muscles of back of leg. Now, the next is to know muscles of the back of leg. So, we have done the anterior compartment, we have done the lateral compartment, and next we have to know the muscles of the back of the leg. The muscles of the back of leg are following. In this list, we have got following muscles. So actually in the back of leg also we have got many muscles. Few are in the superficial group and few are in the deeper group. Few is in the superficial group. So muscles of the superficial group, we have got gastrocnemius muscle, we have got soleus muscle, and we have got plantaris muscle. Together they insert in tendocalcaneus. Okay, so these are the three superficial group of muscle. Then we have got more deeper muscles. So deeper muscles of the back of leg are popliteus, flexor digitorum longus, flexor hallucis longus, tibialis posterior. So all these are the muscles of back of leg. These three muscles will be in the superficial group, and these are the muscles of deeper group. Now it is important to know the attachment of these muscles. So muscles of back of leg, all the muscles of back of leg, all the muscles of back of leg is innervated by tibial nerve. It is innervated by tibial nerve and all are plantar flexor of the foot, and all the muscles are plantar flexor of the foot, and all muscles are plantar flexors of the foot. Now let's start with the first muscle, that is gastrocnemius muscle. Gastrocnemius muscles. When I am talking about gastrocnemius muscle, it is having two heads of origin. It is having medial and lateral head of origin. As you can see, it is originating from the medial epicondyle of femur and lateral epicondyle of femur. So it is having two heads of origin, the lateral and medial epicondyles of the femur, and inserting into tendocalcaneus. So common insertion of soleus, gastrocnemius and plantaris muscle is in the heel bone by tendocalcaneus. So exactly the nerve supply will be from the tibial nerve, and action will be flexion or plantar flexion of the foot and also slight flexion of the knee. So basically it is causing plantar flexion of the foot. These are the gastrocnemius muscle. Now the next is the soleus muscle. Now if I talk about soleus muscle is also originating from the head of fibula and soleal line. So it will be originating, if I am talking about the soleus muscle, the soleus muscle is actually arising from the fibula head. Soleal line, that is exactly the soleal line is in the middle one-third of the medial border of the shaft. You can see the soleal line. So exactly tendinous soleal arch is stretching between tibia and fibula. So it is the soleus muscle which is attached to the soleal line. From the tibia and fibula it is originating, and it also inserts into the tendocalcaneus. It is also inserting into tendocalcaneus. Plantar flexion and tibial nerve is a nerve supply. The next is plantaris muscle. The plantaris muscle is a degenerating muscle as shown by an arrow. As you can see, it is a degenerating muscle, and it is originating from the lateral supracondylar ridge of the femur. It is inserting So if I talk about the origin, it is originating from lateral supracondylar ridge of the femur, inserting into the calcaneal tendon, and action is it is weakly assisting gastrocnemius muscle in plantar flexion and flexing the knee. So the nerve supply of plantaris muscle is from the tibial nerve via anterior rami of S1 and S2. So it is also getting innervation from tibial nerve. The next muscle is flexor digitorum longus. So when I am using the word flexor digitorum longus, what does that mean? Flexor digitorum longus means if we are talking about flexor digitorum longus, it is also originating from the posterior surface of the body of tibia. So it is attached to the posterior aspect of the body of tibia, inserts onto the base of distal phalanx of the foretoes. So where it is inserting? So as you can see here, it is inserting into the distal phalanx of foretoes. Distal phalanx of the foretoes. So it is inserting onto the distal phalanx of foretoes. It is inserting into the distal phalanx of foretoes. This is about the attachment of flexor digitorum longus, which is exactly originating from the posterior surface of body of tibia and inserting into the lateral foretoes. Action will be flexion of smaller digit and plantar flexion of foot. Now talking about the flexor hallucis longus. So by the word hallucis, it means it will be attached to the great toe. What will be the attachment? It will be attached to the great toe. Originates from the fibula posterior surface, and insertion is into the distal phalanx of great toe. So where it is inserting? Into the distal phalanx of the great toe. Into the distal phalanx of the great toe. Action is it flexes all the joints of the big toe, plantar flexion of the ankle joint. Tibialis posterior. So when I am talking about tibialis posterior muscle, the tibialis posterior muscle originates from tibia and fibula, and it inserts into navicular. Where does it insert? It inserts into navicular and the medial cuneiform. It inserts into navicular medial cuneiform bone. So major part is inserting into the navicular medial cuneiform bone. It is also causing the plantar flexion of the foot and also inversion of the foot. That means tibialis anterior and posterior both are causing plantar flexion and inversion of the foot. Next is popliteus muscle. Popliteus is a small muscle lying and forming a popliteal fascia is forming the floor of popliteal fossa. And if I talk about this small popliteus muscle, this small popliteus muscle, this is lying on the posterior aspect of the it is lying on the so it is originating from, as you can see in this diagram, it is originating from the lateral aspect of lateral condyle of femur. Its origin is intracapsular. So its origin is intracapsular, and if we talk about insertion, it is inserting into the shaft of tibia. It is inserting into the shaft of tibia above the soleal line. Above the soleal line. So please write down about popliteal muscle. Origin. It originates from lateral. So it originates from lateral surface of. It originates from lateral surface of lateral condyle of femur. Lateral condyle of femur. Origin is intracapsular. Origin is intracapsular. Insertion is on the posterior surface of sapto. Posterior surface of insertion is on the posterior surface of shaft of tibia. Shaft of tibia above the soleal line. Above the soleal line. Above the soleal line. Okay. So, and action, as we already know, its nerve supply is tibial nerve. So tibial nerve is the innervation, and action is unlocking the knee joint. Nerve supply is tibial nerve and action is unlocking the knee joint. It unlocks the knee joint. It unlocks the knee joint. Okay, so done with this. Now, so we have done with all the muscles, all the important muscles list we have done. Now, in this compartment, okay, if I am talking about this compartment, I just want briefly for you to know about the posterior tibial artery. What is posterior tibial artery? Is the larger terminal branch of the popliteal artery, and it again divides into another branch, that is the so if we talk about one of an important branch is the fibular artery, which is also very important for you to know, because it is giving, fibular artery is also giving blood supply to lateral compartment of the leg. So posterior tibial artery begins at the lower border of popliteus muscle. Begins at the lower border of it begins at the lower border of popliteus muscle. It begins at the lower border of popliteus muscle between tibia and fibula, deep to gastrocnemius muscle, Okay, now talking about its branches. So it's important to know the branches. So exactly, one of an important branch is the peroneal artery. So I just want everybody to know about the branches, and then we will talk about the peroneal artery. So please write down here the branches of posterior tibial artery. So posterior tibial artery is giving one of the important artery, that is the peroneal artery. Now the peroneal artery is the largest branch of posterior. Why it is important to know about peroneal artery? Because peroneal artery is the largest branch of posterior. Okay. Now you can write peroneal artery. Peroneal artery is the largest. Peroneal artery is the largest branch of posterior tibial artery. Posterior tibial artery. It's the largest branch of posterior tibial artery. Okay. Now other branches. So let's talk about the other branch. It gives several muscular branches. So it gives muscular branches. It gives nutrient artery to tibia. It gives nutrient artery to tibia. It gives nutrient artery to tibia. It gives nutrient artery to tibia bone. It gives anastomotic branches. It gives anastomotic branches. It gives anastomotic branches like circumflex fibular artery, Actually, circumflex fibular artery take part in the formation of anastomosis around the knee joint. It gives communicating branch. It gives a communicating branch. It gives a communicating branch. It gives mallular anastomotic branch. It gives mallular anastomotic branch. It gives calcaneal branch. It gives calcaneal branch. It gives calcaneal branch. Now talking about the term, so done with this. Now talking about the terminal branch. The terminal branches are medial and lateral plantar artery. The terminal branches are, if I talk about terminal branches, the terminal branches are medial and lateral plantar artery. Is medial and lateral plantar artery. The terminal branches are medial and lateral plantar arteries. Is the medial and lateral plantar arteries. The terminal arteries are medial and lateral plantar arteries. Now talking about the next artery, that is peroneal artery. So let's talk about peroneal artery. So if I talk about the peroneal artery, it's is the largest branch of posterior tibial artery, and it is actually it's an important artery as it is giving important branches in the lateral compartment of the leg. And the peroneal artery is regarded as the artery which is supplying posterior. So peroneal artery supplies blood supplies it is supplying both posterior and lateral compartment of leg. It is giving blood supply to both posterior and lateral compartment of leg. Now important branches. So let's talk about the branches. So branches of peroneal artery. So if I talk about the branches of peroneal artery, the important peroneal branches are, it gives muscular branches. It is giving the muscular branch. It is giving nutrient artery to fibula. It also gives nutrient artery to fibula. And it gives anastomotic branches. It gives anastomotic branch to branches. It gives anastomotic branches. Okay, that is enough. Now it's important. So we have done with this. Now I just want everybody to go through few MCQs related to the topic. It's okay. Structures of living things. Okay, Medico. Okay, so let's talk about few MCQs related to the topic. So let's start. Which of the following is an artery of anterior compartment of the leg? Aradhana Arora, absolutely right. Yes, the artery of anterior compartment of leg is anterior tibial artery. Absolutely correct. Which of the following? Absolutely great, Aradhana, you're right. Now, which of the following is not an action of tibialis anterior muscle? Which of the following is not an action of tibialis anterior muscle? Which is the right answer, dear? Which of the following is not the action, or which is not the, okay, I got an answer from Aradhana Arora, and C is absolutely right. Yes, it is absolutely right. It is not maintaining lateral longitudinal arch. So when I talk about lateral longitudinal arch, the important is the peroneus longus muscle which is maintaining lateral longitudinal arch. Peroneus longus is supplied by which nerve? Peroneus longus muscle is supplied by which nerve? I told you the lateral compartment of the leg is supplied by which nerve? So peroneus longus is supplied by which nerve? Superficial peroneal nerve, deep peroneal nerve, tibial or femoral? Peroneus longus is supplied by, dear, it is by superficial peroneal nerve. Deep peroneal nerve is the nerve of anterior compartment of leg. The right answer will be superficial peroneal nerve. Superficial peroneal nerve. I just told you the muscles of lateral compartment of the leg is getting innervation from superficial peroneal nerve. Deep peroneal nerve is the nerve of anterior compartment of the leg. Tibialis posteriorly inserts into. Tibialis posterior inserts into. So tibialis posterior inserts into. Tibialis posterior muscle inserts. I have told you. I will give you few seconds to give the answer. Tibialis posterior inserts into which of the following structure? So if you remember, I told you tibialis posterior, I told you it is inserting into medial cuneiform and navicular bone. So the right answer will be tuberosity of navicular bone. So the right answer will be tuberosity of navicular bone. Medial cuneiform is not given, so tuberosity of navicular bone. Okay, tuberosity of navicular bone. So deep muscle of posterior compartment is supplied. So muscles, innervation of the muscles of posterior compartment of leg is by which nerve? Innervation of the muscles of posterior compartment of leg is by which nerve? Tibial, deep peroneal, obturator or femoral? Deep muscles of posterior compartment of leg is supplied by which nerve? Question number 5. Deep muscles of posterior compartment of leg is supplied by which nerve? So Aradhana Arora has given the right answer. Yes, dear, you are right. It is by tibial nerve. The right answer is it is by tibial nerve. It is by tibial nerve. Absolutely correct. Paralysis of the muscle of anterior compartment of the leg leads to the loss of paralysis of the muscles of anterior compartment of leg will lead to the loss of which action? Which action is the prime action of the muscles of anterior compartment of the leg? What is the prime action of the muscles of anterior compartment of the leg? Dorsiflexion of foot is absolutely right. Yes, dorsiflexion of foot is absolutely right, dear. Yes, right answer is A. Now I would like to tell, so we have finished with the topic of compartments of the leg. Now I would like to talk about the retinaculums. Actually, retinaculums are very important topic. So exactly, if I am talking about retinaculum, you have to understand there are two. So abhi kal, when I will take a session tomorrow, I will talk about the flexor and extensor retinaculum of the hand. Okay. So here we are having, this is the flexor retinaculum. So what you can see, the flexor retinaculum of the foot, which is a modification of deep fascia. So very nicely you can appreciate the flexor retinaculum of the foot, which is a modification of deep fascia, is attached to medial malleolus and to the medial tubercle of the calcaneum. So what is the attachment? It is attached to the medial malleolus and medial tubercle of the calcaneum bone. And the structures passing deep to flexor retinaculum are tibialis posterior. So the structures passing deep to flexor retinaculum of the foot is tibialis posterior, flexor digitorum longus tendon, posterior tibial artery and vein and the nerves, and we have got the flexor hallucis longus tendon. So the doctors are not here. So what is the mnemonic of the structures passing below flexor retinaculum from medial to lateral is the doctors are not here. The doctors are not here. Now flexor retinaculum is modification of deep fascia. Flexor retinaculum is modification of deep fascia. Attachment. This is clear, no? See, this is clear. Maybe your net is not working. See here, this is absolutely clear. Now see. Now see the images. Okay. So you just check for your network. Actually, we can all others. Can you see the image? You can see clearly the image. So you can see its attachment is from medial malleolus. It is attached to the medial malleolus. As you can see, it is attached to the medial malleolus to the medial tubercle of the calcaneum. And the green color structure which you are seeing is the flexor retinaculum. The green color structure which you are seeing is the flexor retinaculum of the foot. The green color structure which you are seeing is the flexor retinaculum of the foot, which is attaching from the medial malleolus to the medial tubercle of the calcaneum, which is attaching from the medial malleolus to the medial tubercle of the calcaneum bone. Okay. So here also you can see, if you will see this diagram, Aradhana, see this diagram. So this is the green color area, which is the flexor retinaculum. So you can see this green color area is the flexor retinaculum. and this is attaching from the medial malleolus to the medial tubercle of calcaneum. So it is attached from the medial malleolus to the medial calcaneum bone, and you can see the structures passing beneath it is. So there is certain mnemonics from here. The mnemonic is Tom, Dick, Bloody, Nervous, Harry. What is the mnemonic? Tom for tibialis posterior, Dick for flexor digitorum longus, Bloody for posterior tibial artery, Nervous for tibial nerve, and Harry for flexor hallucis longus. Harry for flexor hallucis longus. So exactly this can be a mnemonic for the structures passing beneath flexor retinaculum. So exactly you can just write down. So please write down the attachment of flexor retinaculum. So if you will see the attachment, it is attached to medial malleolus. It is attached to the medial malleolus to the it is attached to the medial malleolus to the medial tubercle of calcaneum, to the medial tubercle of calcaneum bone. Okay, now let's talk about the structures passing beneath flexor retinaculum. So you can write down structures passing beneath flexor retinaculum from medial to lateral. From medial to lateral. The mnemonic is the doctors are not here. What is the mnemonic? The mnemonic is the doctors are not here. The doctors are not here. TDAH. So here T for tibialis anterior, D for flexor digitorum longus muscle, A for artery, A for artery, that is posterior tibial artery, posterior tibial artery, N for nerve, that is tibial nerve, and H for flexor hallucis longus. So here T for tibialis posterior, D for flexor digitorum longus, A for artery, N for nerve, tibial nerve, and H for flexor hallucis longus. Is it okay, everyone? Go through this mnemonic. So what we can see, we can clearly see the flexor retinaculum. We can clearly see the flexor retinaculum. That is the flexor retinaculum. The doctors are not here. Is the mnemonic for structures passing beneath flexor retinaculum. Tibialis anterior, flexor digitorum longus, posterior tibial artery, tibial nerve, and flexor hallucis longus. And flexor hallucis longus. Is it okay, everyone? Aradhya, Medico, everyone. Can we go to extensor retinaculum? So here again. So here again you can see this image, and in this image also you can see the posterior tibial artery and flexor digitorum. So here also you can see the image where you can see flexor digitorum longus, posterior tibial artery, and the nerves. So this is a cadaveric image where you can see the muscle tendons. You can see the tibialis posterior muscle tendon, you can see the digitorum muscle tendon, and you can see also the flexor hallucis tendon. So these are the muscle tendons which has been shown in this image. These are the muscle tendons which has been shown in this cadaveric image. So exactly this is the three muscle tendon. These are the three muscle tendons which is passing beneath the flexor retinaculum. Now the next topic is extensor retinaculum. So this is, so see here, when I am talking about extensor retinaculum, I am just enlarging this image. So this is the superior extensor retinaculum. This is the superior extensor retinaculum. This is the inferior extensor retinaculum. This is the superior and this is the inferior extensor retinaculum. So write down, this is the superior extensor retinaculum and this is the inferior extensor retinaculum. So this is the superior and this is the inferior extensor retinaculum. Got it? Now superior extensor retinaculum, if we talk about superior extensor retinaculum, if we talk about superior extensor retinaculum, it is lying on the anterior aspect of the lower end of the anterior lower aspect of the lower aspect, as you can see, connecting the lower anterior aspect of tibia and fibula. And I will show you one more image for it. Let me show you. Yeah, so this is basically so all of you just see this image which will help you to understand. So when you see this image, you can see that this band is the superior extensor retinaculum, and this Y-shaped band is inferior extensor retinaculum. What is it? It is inferior extensor retinaculum. So if you will see superior extensor retinaculum, it is connected to anterior surface of fibula to the anterior border of tibia. So it is connected to which two structures? So all of you see the attachment. Which two structure it is connecting? It is connecting anterior aspect of anterior surface of fibula with the anterior border of tibia. So it is connecting anterior aspect of fibula to anterior aspect of tibia, anterior border of tibia, and this is inferior extensor retinaculum. Inferior extensor retinaculum is attached to the calcaneum bone. It is attached to the calcaneum bone, and from the calcaneum bone it is diverging. Upper band is attached to the medial malleolus and the lower band is fusing with the sole of the deep fascia of the sole. So what you can see, there is superior and there is inferior extensor retinaculum. So we can see superior and we can see the inferior extensor retinaculum. The superior extensor retinaculum, if I talk about superior extensor retinaculum, it is connecting the anterior lower aspect of the tibia and fibula. Inferior extensor retinaculum is Y-shaped. It is connecting the calcaneum heel bone. Upper band will go to medial malleolus. The upper band will go to medial malleolus and the lower band will fuse with the deep fascia of the sole. So you can write down superior extensor retinaculum. There are two extensor retinaculums. There are two extensor retinaculum. One is superior extensor retinaculum. One is superior extensor retinaculum and the other is inferior extensor retinaculum. So one is superior extensor retinaculum and the other is inferior extensor retinaculum. So you can see the superior and inferior extensor retinaculum. Superior is attached to the anterior aspect of fibula, lower anterior aspect of fibula to anterior lower border of tibia. Inferior is Y-shaped. It is having superior and inferior band. So the stem is attached to the calcaneum bone, and from that stem of the calcaneum bone, it is having upper band attached to medial malleolus and the lower band attached to the fascia of the sole. So write down about that. One is superior extensor retinaculum. Superior extensor retinaculum. Superior extensor retinaculum attachment. Superior extensor retinaculum attachment. Superior extensor retinaculum attachment. It is attached to the anterior distal aspect of, it is attached to anterior distal aspect of fibula to anterior distal border of tibia. Okay, this is about superior extensor retinaculum. Now inferior extensor retinaculum, now talking about inferior extensor retinaculum. inferior extensor retinaculum. So when we are talking about inferior extensor retinaculum, it is Y shape. It is Y shape. Stem of Y shaped inferior extensor retinaculum is attached to calcaneum bone, is attached to the calcaneum bone. Upper band merges with medial malleolus. If I talk about the upper band of the inferior extensor retinaculum, it merges with medial malleolus, and the lower band fuses with the sole of foot. Fuses with sole of foot. Lower band fuses with the sole of foot. Okay. Lower band fuses with the sole of foot. Got it, everyone? Now it's also important to know the structures passing So I would like to show you an structures passing below extensor. Good morning. Yes, Hamraz Ali, good morning. So we have got, so here you can see this is the superior extensor retinaculum. This is the superior extensor retinaculum. This Y shape is the inferior extensor retinaculum. So here we have got the superior and inferior extensor retinaculum. Now the structures passing from medial to lateral is, we have got tibialis anterior, extensor hallucis longus, anterior tibial artery and nerves and vessels between extensor hallucis longus and extensor digitorum longus. That means neurovascular bundle is passing between extensor hallucis longus and extensor digitorum longus and peroneus tertius. So the tall husbands are never dear person. So what is the mnemonic of structures passing beneath extensor retinaculum? So please write down extensor retinaculum, structures passing beneath extensor retinaculum from medial to lateral, So the structures passing from medial to lateral are, the mnemonic is tall husbands are never dear person. Tall husbands are never dear person. So here you have to know what is T, what is H, what is A, what is N, D and T. And the structures are T for tibialis anterior muscle, H for extensor hallucis longus, A for anterior tibial artery, N for deep peroneal nerve, D for extensor digitorum longus and P for peroneus tertius. So you can see all these structures which has been written are passing beneath extensor retinaculum. Now tall doctors are aware right now. Okay. So yes, Medico, you can form any of this mnemonic. Tall husbands are never dear person. Tibialis anterior, extensor hallucis longus, anterior tibial artery, deep peroneal nerve, extensor digitorum longus and peroneus tertius. That means neurovascular bundle is lying between extensor hallucis longus and extensor digitorum longus tendon. Same thing, the structures has been shown. Now you can see this is the tendon. So we can see the tendon of tibialis anterior muscle. We can see the tendon of digitorum longus. We can see extensor hallucis longus tendon also. We can see extensor hallucis longus tendon also. Okay. So all these tendons has been shown to you. So I just want to remove this. All these tendons has been highlighted in this image. This cadaveric image is showing you all the important tendons of the extensor retinaculum. Peroneal retinaculum, we have got this peroneal retinaculum, and beneath the peroneal retinaculum we have again got inferior and superior peroneal retinaculum. We have got just two muscles which is passing below peroneal retinaculum, peroneus longus and peroneus brevis. So which two muscle passes beneath peroneal retinaculum? That is peroneus longus and peroneus brevis muscle. Okay, okay dear. Now let's solve few MCQs related to this. If tibial nerve is injured, so the question is, if tibial nerve is injured, question is, if tibial nerve is injured under flexor retinaculum, the condition is called as, if tibial nerve is injured under flexor retinaculum, the condition is called as tarsal tunnel syndrome, foot drop, motor neuroma, Morton's neuroma, or pex calcaneus. So please mark the right answer, dear. Tibial nerve is injured. That is tarsal tunnel syndrome. Tarsal tunnel syndrome. The condition is tarsal tunnel syndrome. Condition is tarsal tunnel syndrome. Now, neurovascular bundle. Actually, I will go with the nerves. So, is it okay? No worries. Next question you solve. Neurovascular bundles of anterior compartment of the leg is passing between which tendon? Which muscle tendon? Tibialis anterior, extensor hallucis longus, extensor digitorum longus, hallucis longus. So, mark the right answer. Neurovascular bundles of anterior compartment of leg is passing between the tendons of, I have just shown you in the image also, is passing between the tendons of, if you will see, the correct answer will be extensor hallucis longus and extensor digitorum longus. So it is between extensor hallucis longus and extensor digitorum longus. Tall husbands are never dear persons. So here neurovascular artery and nerve is passing between H and D, that is extensor hallucis longus and extensor digitorum longus. So we have got B as the right answer. Understood? Structure pass deep to flexor retinaculum. Which of the following structure is passing deep to flexor retinaculum? Which of the following structure pass deep to flexor retinaculum? Flexor retinaculum, dear. Flexor retinaculum. Flexor retinaculum. The question is about flexor retinaculum. Long saphenous vein doesn't passes tibialis and anterior and peroneus tarsus passes beneath extensor retinaculum, not flexor retinaculum. The correct answer is posterior tibial artery. Posterior tibial artery passes beneath flexor retinaculum of the foot. Okay. Now, all of the following structures passes beneath flexor retinaculum except so more than one correct answer. Are you get exhausted? Exhausted? Are you all exhausted? So not yet exhausted. So more than one can be correct. More than one answers can be correct. More than one answers can be correct. So yes, all of the following structure passes. Yet deep peroneal nerve is right. Yes, deep peroneal nerve is right. Posterior tibial artery passes. Deep peroneal nerve is the most right. Anterior tibial nerve तो nerve ही नहीं होता. The best answer is deep peroneal nerve. The best answer is deep peroneal nerve. Now, not true about inferior extensor retinaculum. Which of the following statement is not true about inferior extensor retinaculum? It is Y-shaped. Superior slip attached to lower end of fibula. Inferior slip deep fascia obtuse lateral aspect to the calcaneum. Which is the wrong statement about inferior extensor retinaculum? Which is the wrong statement about inferior extensor retinaculum? Which is the wrong statement about inferior extensor retinaculum? So, my dear students, superior slip attached to the lower end of fibula is wrong. It is attached to medial malleolus. It is attached to medial malleolus. Superior slip is attached to medial malleolus. It is not attached to the lower end of fibula. Lower end of fibula is the a superior extensor retinaculum attached. It is talking about which extensor retinaculum? Inferior extensor retinaculum. So B is the right answer. So B is the right answer. Superior slip attached to the lower end of fibula. Okay. Now coming to hip joint. So joints and nerves are few things which is remaining here, and few important things are also there which is remaining. So now we will talk about joints. So the first joint is the hip joint, which I want everybody to understand. So can anybody tell me which type of joint is hip joint? So which type of joint is hip joint? It's a ball and socket type of synovial. It's ball and socket type of synovial joint. It's ball and socket type of synovial joint. What is important point about hip joint? It is ball and socket type of synovial joint. Ligaments, important ligaments which you have to know about the hip joint. The important ligaments are, please note down. One is fibrous capsule. The other is iliofemoral ligament. The other is pubofemoral ligament. The other is pubofemoral ligament. Ischiofemoral ligament. Also other accessory ligaments, transverse acetabular ligament, transverse acetabular ligament, transverse acetabular ligament, acetabular labrum, ligament of head of femur, ligament of head of femur, ligament of head of femur. So these are the ligaments of the hip joint: ligament of head of femur, fibrous capsule, iliofemoral ligament, pubofemoral, ischiofemoral, transverse acetabular ligament, and acetabular labrum. Now ligament. So done. So one by one important ligaments. The first is the fibrous capsule. So first is the fibrous capsule. In this diagram you can see the fibrous capsule is actually showing here. We can see the fibrous capsule attachment on the anterior aspect. So this diagram is showing the attachment on the anterior aspect. It is showing the attachment of fibrous capsule from the anterior aspect. So when you see the fibrous capsule from the anterior attachment, its upper attachment is the acetabular margin, lower is the intertrochanteric line. Lower attachment is intertrochanteric line. So this is fibrous capsule posterior aspect. This is the attachment of fibrous capsule from posterior aspect. When you see the attachment from the posterior aspect, superiorly it is attached to acetabular margin and inferiorly it is attached to the neck of femur. To be more specific, it is lying above 1 centimeter above the intertrochanteric crest. It is enclosing above intertrochanteric crest. Okay. Now this ligaments. If I talk about fibrous capsule attachment already shown. Fibrous capsule is lined by synovial membrane. It is lined by synovial membrane inner side. It is lined by synovial membrane. So then so that we have already written fibrous capsule. It's a strong support for hip joint. It's a very strong support of hip joint. Now let's talk about other ligaments. So I just want firstly to show you the ligaments. So can you see this image? In this image you can appreciate the other ligaments of the hip joint. So here we have got the Y-shaped iliofemoral ligament. This is the Y-shaped iliofemoral ligament and this is the posterior view of ischiofemoral ligament. This is the posterior view of ischiofemoral ligament and this is the anterior view of iliofemoral pubofemoral ligament. Now one by one we will talk about this ligament. So the first ligament is iliofemoral. In this diagram you can see iliofemoral ligament is Y-shaped ligament. It is having attachment to anterior inferior iliac spine and to intertrochanteric line. It is blended on anterior aspect by pubofemoral ligament. One of the strongest ligament of hip joint is iliofemoral ligament, which is preventing from falling backwards. It is preventing the body when we are standing erect from falling backwards. Ischiofemoral will give a support from the posterior aspect of the hip joint and pubofemoral will merge with the fibrous capsule and iliofemoral ligament and give more support to the anterior aspect of the hip joint. It check excessive adduction of the hip joint. So write down iliofemoral ligament. So this was the first ligament. Now write down iliofemoral ligament. Iliofemoral ligament is also called as ligament of Bigelow. It is also called as ligament of Bigelow. It is also called as ligament of Bigelow. So iliofemoral ligament, it is inverted Y-shaped. It is inverted Y-shaped ligament. It is inverted Y-shaped ligament It prevents the trunk. It prevents the trunk. It prevents the trunk from falling backwards. From falling backwards in standing position. In standing position. Pubofemoral. The next ligament is pubofemoral ligament is triangular ligament. It is a triangular ligament with base above and apex down. So it is actually, sorry, if I talk about femofemoral ligament, it is checking excessive abduction of the hip joint. For example, अगर हम iliofemoral ligament की बात करते हैं तो iliofemoral ligament or ligament of Bigelow is checking excessive hyperextension or falling. It is preventing us from falling backward. Pubofemoral ligament will be checking excessive abduction of hip joint. Checks excessive abduction of hip joint. It checks excessive abduction of hip joint. Now the ischiofemoral ligament. The next is ischiofemoral ligament. So if we are talking about ischiofemoral ligament, it is relatively weak. It supports the fibrous capsule posteriorly. It supports the fibrous capsule of hip joint posteriorly. It checked excessive internal rotation of the hip joint. What is the function? It checked excessive internal rotation of the hip joint. The important function of ischiofemoral ligament is it is checking excessive internal rotation of hip joint. It checks excessive internal rotation of hip joint. Internal it checks excessive internal rotation of hip joint. Other is acetabular labrum, made of fibrocartilage. It is made of fibrocartilage and it deepens the acetabular cavity. It deepens the acetabular cavity. Round ligament of head of femur. Round ligament of head of femur. If I talk about round ligament of head of femur, it is not giving any kind of support to the hip joint, but through this artery, through this arteries traverses through to the head of femur. So it is giving a pathway for the arteries to pass. And transverse acetabular ligament bridges the acetabular notch. Bridges the acetabular notch. Bridges the acetabular notch. Now you can see this ligament. Here you can see this is ligament of head of femur. This is ligament of head of femur. and this outside we have got the acetabular labrum. Outside we have got the acetabular labrum. So all these we have done, transverse acetabular ligament also. Now the next is to show you this image. So when I am showing you this image, you can see ligament of head of femur. You can also see the transverse acetabular ligament bridging the acetabular notch. You can see the acetabular labrum. So basically you can see the transverse ligament, acetabular labrum on the periphery, and you can see the round ligament of head of femur. Ligament of head of femur. You can see the ligament of head of femur. So ligament of head of femur, acetabular labrum, and transverse so ligament of head of femur, acetabular labrum, and that of transverse acetabular ligament. All these are bridging. They are giving secondary support to the hip joint. They are giving secondary support to the hip joint. Now, what is very, very important for you is to know the muscles responsible for the movements of the hip joint. So we have got many important muscles which is responsible. So if I talk about hip joint, it's a multi-axial joint. It's a multi-axial joint. So hip joint is ball and socket type of synovial joint. That means the movement is occurring in 3 planes. So that means the movement is occurring in 3 planes: flexion, extension, medial rotation, lateral rotation, abduction, adduction. All these movements takes place, and you have to know about the important muscles performing this movement. So let's write it. Flexion. The first is flexion. The first action is flexion. So flexion is done by, if I talk about flexion, flexion is done by psoas major muscle and iliacus muscle, which is the chief flexor, as other muscles are sartorius muscle, rectus femoris muscle, pectineus muscle. Extension. Extension of hip is done by, if I talk about extension, extension of hip is done by gluteus maximus muscle and that of hamstring muscle, and that of hamstring muscles or hamstring group of muscles. Now coming to the third point, that is the abduction and adduction. Abduction of hip joint, if I talk about the abduction of hip joint, this abduction movement of hip joint is done by gluteus medius and minimus. And that of tensor fascia lata. Now talking about adduction. So if I talk about, so we have done with abduction. If I talk about adduction of the hip joint, adduction is done by adductor longus. Adduction is done by adductor longus, adductor brevis, adductor magnus, so it is done by adductor longus, adductor brevis, adductor magnus, pectineus and gracilis. Now talking about medial and lateral rotation. So let's talk about medial. So done with this. Let's talk about medial rotation and lateral rotation. Medial rotation of the hip joint. If I am talking about the medial rotation of the hip joint, which is also called as internal rotation, basically it is done by anterior fibers of, it is done by anterior fibers of gluteus minimus and gluteus medius, and it is also done by, medial rotation is also done by tensor fascia lata. Lateral rotation is done by all the small muscles. If I talk about lateral rotation, please note down, lateral rotation is done by all the small muscle which is covered by gluteus maximus muscle. So we have got a list of small muscle. What are they? The muscles are piriformis, the muscles are piriformis muscle, the muscles are obturator, externus and internus. Obturator externus is there, the muscle. Then we have got obturator internus. We have got gemellus superior and inferior. Gemellus superior muscle is there. Then we have got gemellus inferior. Then also the quadratus femoris muscle. So all these muscles are lateral rotators of the hip joint. So we have got all movements of the joints are very important. Next is in this diagram you can see the relations. Okay, so you can appreciate the structure lying superiorly, posteriorly, anteriorly lies the iliopsoas muscle and all. Inferiorly is the adductor magnus hamstring muscle. Femoral nerves and vessels are lying on anterior aspect. Posteriorly we have got the piriformis muscle, and the gluteal region structures are lying superiorly on the posterior aspect, superior posterior aspect. Now what is remaining is to know the blood supply. So when I am talking about blood supply of hip joint, the major arteries are, so the major arterial supply for the hip joint, if I am talking about the major arterial supply of the hip joint, it is from medial and lateral circumflex femoral artery. So basically circumflex femoral artery is giving its arterial supply. Also branch from obturator artery is there. So what is the major artery which is giving blood supply? Most important source of blood supply will be the medial circumflex femoral artery. Most source is medial circumflex femoral artery. So the arteries are medial circumflex femoral artery. The arteries are medial circumflex femoral artery. We have got lateral circumflex femoral artery, lateral circumflex femoral artery. We have got superior gluteal artery. We have got inferior gluteal artery and obturator artery. Okay, so these are the source of blood supply: inferior gluteal, superior gluteal, medial circumflex femoral, lateral circumflex femoral and obturator artery. So these are basically the source of blood supply or arterial supply to the hip joint. Now nerve supply. Nerve supply, important nerves are femoral nerve is the femoral nerve via it's also a branch of obturator nerve, anterior division basically. Also it's get innervation from accessory obturator nerve, accessory obturator nerve. Also it gets innervation from nerve to quadratus femoris, nerve to quadratus femoris, and sometimes a quick from sciatic nerve, quick from sciatic nerve. This is the nerve supply. Done. Now let's talk about important bursas, and then we'll solve the MCQs. After this I will give you a break, don't worry. Important bursas. So important bursas is very important. So bursas, what do you mean by the word burse? What do you mean by the word burse? Any idea? Students, any idea what do you mean by the bursas? Okay. No, for that is important that you should know. Fluid filled synovial pouch. It is synovial pouch. It is synovial pouch, fluid filled. Okay. Yes, yes. Synovial pouch, fluid filled. Yes. Now, important bursas. So important bursas are, if I talk about important bursas around the hip joint, we have got many important bursas around the hip joint. So I just want you to write down the name. So write down important bursas we have got trochanteric bursas. We have got the trochanteric bursa. We have got the trochanteric bursa. That is the bursa between gluteus maximus and greater trochanter. So this is the bursa between gluteus maximus and greater trochanter. Now ischial bursa. Ischial bursa. If I talk about ischial bursa, the ischial bursa is between gluteus maximus. It is lying between. So this bursa is lying between. This bursa is lying between gluteus maximus and ischial tuberosity. Maximus and ischial tuberosity. Gluteofemoral bursa. Gluteofemoral bursa. If I talk about gluteofemoral bursa, the gluteofemoral bursa is lying between gluteus maximus and vastus lateralis. It is located between gluteus maximus and vastus lateralis. This is called as gluteofemoral bursas. We have got subpsoas bursas. These are some important bursas which you have to know. Okay, many bursas are there, but these are some important bursas: trochanteric, ischials, gluteofemoral, and subpsoas bursa. Gluteofemoral bursa is the bursa between vastus lateralis and gluteus maximus. Now, clinical anatomy. If you want to know clinical anatomy, you can just have a look on this coxa vara and coxa vulga. So exactly the normal neck shaft angle, if I talk about normal neck shaft angle, it is 120 degrees in adults and 160 degree in children. So basically, if for example, if the neck shaft angle is reduced, this is coxa vara, and if the neck shaft angle is increased, it is coxa vulga. So what do you mean by the term coxa vara and coxa vulga? Please note that coxa vara means neck shaft angle is so neck shaft angle, if it is increased, it is coxa vulga, and if the neck shaft angle is decreased, so exactly what happens, if the neck shaft angle is reduced, fracture of neck and all, it is called coxa vara, and if it is increases, coxa vulga. Now, other than that, osteoarthritis is a quite common condition, which is quite common in case of hip joint, and the treatment of osteoarthritis is hip replacement. Total hip replacement is quite beneficial these days. Now, I would like to show you the fracture of neck and trochanteric fascia. So, exactly if I talk about the fracture, it is very important for you to understand one important thing is that if the fracture is above, so subcapital angle, then we have got transcervical, intertrochanteric and subtrochanteric. So, the most chance of avascular necrosis. So, if it is above, there is more chance of avascular necrosis. So, it is important that more closer to the hip joint and more above or proximal, if it is, there is most chance of avascular necrosis. So, this is showing you neck shaft angle. Now, here you can see in a normal condition, when you see the neck shaft angle and that of obturator foramen upper border, it is like a plane. It is not, it is exactly like this in a line. But if it is distorted, if it is distorted, the neck shaft angle and obturator foramen margin is not in a connected line. It is seen in the case of fracture of hip joint or dislocation of hip joint. So that is important. So let's move on with the MCQs. That is important. So everyone, let's solve an MCQ related to this topic. Everyone, let's solve an MCQ. Yes, Medico. Vulgus means increase. Is neck shaft angle head of shaft angle? Neck, it's the neck, and we know neck shaft angle is as the area where the neck of the femur is continuing with the whole shaft, whole shaft means the body of the femur. So that is neck shaft angle. So this will be the neck shaft angle. This angle is neck shaft angle here. So exactly you can see this is the neck shaft angle between the neck and so exactly you can see the angulation start at the shaft. So this is the neck shaft angle. So if it is less, it is if it is decrease, it is coxa vara, and if it is increase, it is the coxa vulga. Okay. Now, can you solve MCQs related to this? All of the following muscle extend the hip joint except. All of the following muscle extend the hip joint except. Yes, you are right. Vulga means increase and varus means decrease. Yes. Now, all of the following muscle extend the hip joint except. All of the following muscles extend, all of the following muscle extend the thigh at the hip joint except, which is not the extensor. Which is not the extensor. Yes, Bindu, absolutely right. Absolutely right, Bindu. It is gluteus medius is the right answer. Absolutely correct. Absolutely correct. The strongest ligament over the strongest ligament around the hip joint which prevents overextension, during standing is. The strongest ligament around the hip joint which prevent overextension during standing is. The strongest ligament. Which is the strongest ligament? Strongest ligament, dear. Easy one I have told you, strongest ligament of the hip joint. The name is, which is preventing backward fall while standing, which is supporting the hip joint when standing. The correct answer is iliofemoral ligament, ligament of Bigelow, iliofemoral ligament. Gluteofemoral bursa is between gluteus maximus and, I have written this, gluteofemoral bursa is between gluteus maximus and which muscle? Between greater trochanter, ischial fibrosity, vastus lateralis. Gluteofemoral bursa is lying between gluteus maximus and which structure? Please mark the right answer. Vastus lateralis. Absolutely correct. Absolutely correct, Medico. Yes, you are absolutely right. It is the vastus lateralis. It is the vastus lateralis. Yes, it is vastus lateralis. Abduction of thigh is limited by which is the structure which is limiting the abduction of thigh? Abduction of thigh is limited by abduction of thighs are limited by tension in adductors, and iliofemoral ligament, tension in adductors and pubofemoral ligament, tension in adductors and ischiofemoral ligament. So, which of the following structure is limiting the abduction of thigh? Tension of adductors and which structure? Abduction of thigh is limited by tension in adductors and pubofemoral ligament. Pubofemoral ligament, dear. Pubofemoral. C is the right answer. I have given the notes. Hip flexion is done by all except. All of the following is causing hip flexion except. Hip flexion is done by all except. Iliopsoas, pectineus, sartorius, semitendinosus. So hip flexion is done by all except semitendinosus. Those who have given D, many of the students has given the right answer, that is hamstring muscle, semitendinosus. Regarding hip joint, which of the following is true statement? Regarding hip joint, which of the following is the most correct answer? Most correct. Regarding hip joint, which is the most correct answer? Most correct. So yeah, I have to choose the most correct answer. I will go with C. That is, the fibrous capsule is attached to intertrochanteric line anteriorly. We know that fibrous capsule of hip joint, as shown in the image, is attached to intertrochanteric line. So we will go with C as the best answer. Inferior gluteal nerve is giving innervation to gluteus maximus. Iliopsoas is flexor of the hip joint, not abduction. And retinaculum is attaching the hip bone and extending in the, so it is attaching from femur towards the hip joint. So it is also partially correct only. So the most correct answer is fibrous capsule is attached to intertrochanteric line. Done. The next topic is knee joint. So I would like to give you a break of few seconds. No, break of few minutes, sorry, 10 minutes. Is it okay? 10 minutes break, 10 to 15 minutes you can take. 10 to 15 minutes break, and then we will start with joints and nerves and arches of foot. And so we will, after this I will cover up the entire lower limb. Actually, I have covered in more detail. So tomorrow will be the upper limb. So we will slightly brief the upper limb because lower limb we have extended so much. So few more joints and all the nerves are remaining and arches of the foot. And also I will tell you about venous drainage and lymphatic drainage. Okay, dear. So take a break. So I would like to give you a break of 10-15 minutes. Is it okay, everyone? 10-15 minutes break, and again we will meet and we will start with the topic of knee joint. Okay, dear. Hello everyone, am I audible? Let me just check. Hello everyone, am I audible? So let's start with the knee joint. So for the joints part and the nerves, that is an important point which is still remaining in the lower limb. So we have to cover up all these points. Okay, dear Venki 888, let's start. So if I talk about the knee joint, it is the most complex joint in our body. It is a composite and a complex joint. So what is the important point about knee joint? It's a compound joint. So when anybody has an idea, when we use the word compound and when we tell that this is a complex joint, actually why compound? Mainly the joints which is formed if we are talking about the joints which is formed, it is formed between the articulation of two bones. But if I take the example of knee joint, there is an articulation between femur. The articulation is between the femur, the tibia and the patella. So what you can say, there are three bones which is taking part. So here this is the femur bone, this is the femur bone, and this is the tibia bone, and this is the patella bone. So these three bones are articulating to form the knee joints. Okay, these three bones are, so it is called as the compound. It is called as the compound and complex joint. Okay. Now, if I talk about the knee joint, it is the most complex joint in our body. The reason is that why it is called as a complex joint. The reason is that the reason which is behind this is that there is articulation of more than two bones. So there is articulation of more than two bones, and that is the reason it is called as a so that is the reason it is called as the compound, and that is the reason it is called as the compound joint. Okay, that is exactly why it is called as the compound joint. Okay. Okay. Now knee joint, it's a synovial joint of so if I talk about the type, it is modified hinge variety of, it is modified hinge variety of synovial joint. It is modified hinge variety of synovial joint. So it's a modified hinge variety of synovial joint. So it is called as the knee joint. It's a modified hinge variety of synovial joint. And actually it is having menisci inside. So what happens, it will divide the joint cavity. Agar hum knee joint ki baat karte hain, so because of the presence of knee menisci, as you can see in the diagram, there is, this is the lateral meniscus and these are the medial meniscus. So here we have got the medial and lateral meniscus. So because of the presence of these two meniscus, the lateral meniscus and that of medial meniscus, the whole of the knee joint cavity is divided into two compartments. The upper is called as femoromeniscal compartment and the lower is called as meniscotibial compartment. So in the femoromeniscal compartment, extension and flexion of knee takes place. In the lower compartment, conjointly, the medial and lateral rotation takes place. Now, when we are talking about the ligaments of the knee joint, we have got many important ligaments. Firstly, please write down the name of all the ligaments. We have got fibrous capsule. We have got fibrous capsule. We have got the fibrous capsule. We have also got the other ligaments, the medial and lateral collateral ligaments. We have got medial and lateral collateral ligaments. We have got medial and lateral collateral ligaments. We have got ligamentum patellae, and we have got cruciate ligament, anterior and posterior cruciate ligaments. We have got anterior and posterior cruciate ligaments. So we have got anterior cruciate ligament and we have got PCL, means posterior cruciate ligaments. So we have got anterior and posterior cruciate ligaments and we have got The other ligaments are oblique popliteal ligament, and we have got menisci. So we have got lateral and medial menisci. We have got lateral and we have got the medial menisci. So we have got lateral and medial menisci here. So basically other ligament like arcuate ligament is there, coronary ligament is there. So basically these are some secondary ligaments which is also giving support to the knee joint. So actually here in this diagram I would like to show you the fibrous capsule. So when you see the fibrous capsule, you can see that inside the fibrous capsule there is a joint cavity and there is actually synovial fluid. Together the synovial membrane and fibrous capsule is called as articular capsule. So that is an important. Capsular ligament is quite important, and it is actually, if we talk about capsular ligament, it is attached to the articular margin. So it is attached to the articular margins of the knee. It is attached to the articular margins of the knee joint. And exactly, I just want you to show the ligament. So it is attached to the articular margins of the knee joint, and it is this is the ligamentum patellae. So I just want you to understand, this is the tendon of quadriceps femoris, which is forming ligamentum patellae. So ligamentum patellae is formed by the tendon of quadriceps femoris muscle. Now in this diagram I want you to show the coronary. So when you move inside, actually there is two collateral ligaments. There is medial and lateral collateral ligament. So here you can see this is the medial collateral ligament and this is the lateral collateral ligament. So medial collateral ligament is attached from the exactly, you can see it is attached to the medial side aspect. So exactly, if you see, it is attached to the medial epicondyle and it is attached to lateral epicondyle. So it is attached to the medial epicondyle of the femur. Lower down, what you can see, the medial collateral ligament. In this diagram itself, you can see there is a medial collateral ligament which has got two parts. It is having superficial part and it is having the deep part. On lateral side, we have got lateral collateral ligament which is attached to the head of fibula. Superiorly, it is attached to lateral epicondyle. So exactly this collateral ligament is important for side to side stability of the knee joint. And other important point about medial collateral ligament is it is degenerated tendon of hamstring part of the adductor magnus muscle, and the lateral collateral ligament is degenerating part of, if I talk about lateral collateral ligament, it is the degenerating part of the peroneus longus muscle. So you should just write this. Medial collateral ligament is degenerated tendon of, medial collateral ligament is degenerated tendon of, medial collateral ligament is degenerated tendon of medial collateral ligament is degenerated tendon of hamstring part of adductor magnus muscle, adductor magnus muscle. And lateral collateral ligament is degenerated tendon of, lateral collateral ligament is degenerated tendon of, it is the degenerated tendon of peroneus longus muscle, peroneus longus muscle, peroneus longus muscle. It is the degenerated tendon of peroneus longus muscle. Now collateral ligament is responsible for, it is responsible for side to side stability, side to side stability of knee joint, side to side stability of knee joint. It is responsible for side to side stability of knee joint. Cruciate ligament, if I talk about cruciate ligament, we have got posterior cruciate ligament and we have got anterior cruciate ligament. So here this is the anterior cruciate ligament and this is the posterior cruciate ligament. So actually you can see the cruciate ligament are crisscrossing each other. If we talk about cruciate ligament, they are crisscrossing each other. This is the posterior cruciate ligament and this is the anterior cruciate ligament. So these are crisscrossing each other, and this is important for the stability of knee joint, anteroposterior stability of the knee joint. Actually, it is important that you should also note down that the cruciate ligaments, the medial and lateral meniscus, are intracapsular structures of knee joint. So here, other important point is, in collateral ligament, you have seen medial collateral ligament is it's attached to medial meniscus. So only medial meniscus is more injured than the lateral meniscus. So cruciate ligament. So write down, in cruciate ligament, write down, anterior cruciate ligament and posterior cruciate ligaments are intracapsular structure. They are important for antero-posterior stability of knee joint. For antero-posterior stability of knee joint, they are important for antero-posterior stability of knee joint. So actually the name anterior, so it's also important for you to know why they are named as anterior and posterior cruciate ligament. That name is depending on the tibial attachment of cruciate ligament. If anterior cruciate ligament is attached to the anterior part of tibia, so it is called as anterior cruciate ligament. Posterior cruciate ligament is called as posterior cruciate ligament because it is attached to the posterior aspect of tibia. It is attached to the posterior aspect of tibia. Yes, you are right, crisscrossed here. Yes, you are right. So basically, one of the important point is that anterior cruciate ligament is taut during extension of the knee. It is taut during extension of knee and prevents the posterior dislocation of femur on tibia and anterior dislocation of tibia on femur. Now, posterior cruciate ligament is attached to posterior part of intercondylar area of tibia. So I'm not talking about its extension and all because it's already known. One of the important point which has to be known, posterior cruciate ligament is taut during flexion of knee and prevents anterior dislocation of femur on tibia and posterior dislocation of tibia on femur okay, and posterior dislocation of tibia on femur. Now talking about semilunar cartilage, done. Semilunar cartilage, if I talk about semilunar cartilage, the other name is, we have got medial meniscus and lateral meniscus, which is also called as semilunar cartilage, which is also intracapsular structure, and they are made of fibrocartilages. So semilunar cartilages, we have got two. We have got medial meniscus and we have got lateral meniscus. So semilunar cartilage, they are made of fibrocartilage. So they are made of fibrocartilage and they are intracapsular structures. They are intracapsular capsular structures. They are intracapsular structures. They are intracapsular structures. Now here I just want to write one more thing. Medial meniscus is more prone to injury. Medial meniscus is more prone to injury because it is attached to medial collateral ligament. Medial collateral or tibial collateral ligament. It is attached to medial collateral or tibial collateral ligament. It is attached to medial or tibial collateral, so it's more prone to injury. Lateral meniscus is attached to, is less prone to injury because it is attached to popliteus muscle. It is attached to popliteus muscle. So that is the reason it is more mobile. Now here we can see the tendon of semimembranosus muscle is forming oblique popliteal ligament, also arcuate ligament you can see. So basically here you can see also the coronary ligaments, which is, this is the transverse ligament connecting anterior end of the medial and lateral meniscus, and you can see the coronary ligament which is giving support to the fibrous capsule of the knee joint. So done with this, actually this diagram is showing you the relation. So we have got all the structures we have got this is A for anterior and this is P for posterior. Anteriorly there is ligamentum patellae and posteriorly there is tibial nerves and vessels which is lying there. Now I would like to also tell you about some important bursas around the knee joint. So the important bursas which is lying around the knee joint is, so you can see the bursas. We can see the suprapatellar bursa which is surrounding the knee joint has been shown. There is prepatellar bursa, there is infrapatellar bursa, and this is pec sunsrine bursa. So actually what are bursas? Bursas are synovial fluid pouch which is surrounding the knee joint, and they are important for the lubrication of the knee joint. They are important for the lubrication of the knee joint. Now arterial supply of knee joint is from the genicular branches of, so this is mainly from the genicular branches of popliteal artery. This is mainly from the genicular branches of popliteal artery and also from the knee arterial anastomosis. Knee arterial anastomosis. So actually we have already talked about knee arterial anastomosis. So all these gives blood supply to the knee joint. Nerve supply की बात करें, if we are talking about the nerve supply, the important nerves in relation to knee joints which is giving innervation to knee joint is the femoral nerve, is the tibial and common peroneal nerve, CPN, common peroneal nerve, is the obturator nerve, and it is also the, so these are the important nerves. Now locking and unlocking of knee joint is a very important thing which you have to know. You should basically know the difference between locking and knee unlocking also. So when the knee joint is locked, it's all ligaments are it is all more pro. So if we talk about medial, if we talk about locked knee, what you can understand from locked knee, that all the important structures are taut. So exactly all ligaments are taut in locked knee, and locking of knee is medial rotation of femur on fixed tibia during the terminal phase of extension. If I define unlocking of the knee, unlocking of knee is, so unlocking of knee is lateral rotation of femur during initial phase of flexion, and it is done by popliteus muscle. Locking of knee is done by quadriceps femoris muscle. So you can write locking of knee is done by quadriceps femoris muscle, and in this stage all the ligaments are taut. Unlocking of knee is done by unlocking of knee. If I talk about unlocking of knee is done by popliteus muscle, and exactly here the ligaments are in relaxed state. So once again, I would like to define the locking and unlocking so that you can understand. You can see this image and you can understand. In locked knee, the knee is extended. In unlocked knee, the knee is in the initial phase of flexion. So medial rotation of the femur when the foot is on the ground during terminal medial rotation of femur on tibia during terminal stage of extension when the foot is on the ground. Unlocking means lateral rotation of femur during on tibia during initial phase of flexion. Now, other than that, it's also important to know the muscles forming important movements in the knee joint. So, please write down. As we know, knee joint is a modified hinge joint. So, the important actions of the muscles will be. So, it is having flexion, extension, medial and lateral. So, flexion is basically done by the chief muscle causing flexion of knee is membranosus muscle, semitendinosus muscle, biceps femoris muscle. Now, if I talk about extension of knee is done by, so basically other than that also popliteus muscle causes flexion. Other than that, extension is done by hamstring muscle. Extension of knee is done by quadriceps femoris muscle. Quadriceps femoris muscle. Flexion is done by hamstring group of muscle. Done. Medial rotation is done by semitendinosus, semimembranosus and popliteus muscle. Lateral rotation is done by biceps femoris. Now, actually, I would like to define the, I would also like to tell you about, good evening, yes, good evening, Krishna, K. Kishore, yes, dear. So, for in lower limb part, only I am going to, the last few topics are remaining. I am just away to, I am just covering the knee joint, then I will cover few more important joints, just the type and nerves, and that will be whole for today's session, okay. So, a terrible triad is also called as unhappy triad, and when the word terrible triad or unhappy triad is used, this word is used when three important ligaments are injured. So, this is seen in footballers or rugby players, a direct injury in the lateral aspect of the knee or direct hit is there. Then three ligaments if torn together. Three ligaments are torn together, that is ACL. ACL is torn along with medial meniscus, along with medial collateral or tibial collateral ligament. So, tibial collateral ligament is also called as medial collateral ligament. Thank you, Janab. Thank you. Yeah. So, I wanted to teach more, but actually it will become very long session. So, I will just complete it covering the joints and nerves. That will be enough for today. Okay. Otherwise, it will become too lengthy. So, so when anterior cruciate ligament is injured, along with medial meniscus, along with medial collateral ligament, these three ligaments are injured together. This condition is called as unhappy triad of knee joint, and full integrity of joint recovery is less in this case. So, here three ligaments are injured. ACL is injured along with medial meniscus, along with medial collateral ligament. Okay. Now, if I talk about housemaid knee, the other name of housemaid knee is, it is also called as subcutaneous prepatellar bursitis. It is called as subcutaneous prepatellar bursitis. It is called a subcutaneous prepatellar bursitis. So, bursas are involving subcutaneous prepatellar bursa. Clergyman knee is inflammation of, so here there is inflammation of Hallus vulgus and varus. Yes. I will, yes, Janab, I will tell you about Hallus vulgus and varus. Yes, I will tell you about that. Okay, okay, dear. Okay. So, inflammation of subcutaneous inflammation of subcutaneous infrapatellar bursa. Infrapatellar bursa. Subcutaneous infrapatellar bursa is called as Clergy-Manley. Is called as Clergy-Manley. Pens anserine bursitis is the bursa being involved. Bursa inflammation is there in relation to insertion of three muscle. In relation to insertion of inflammation in relation to insertion of semitendinosus, sartorius muscle and gracilis muscle, and that of gracilis muscle. So, if these three are together involved, then this condition is called as Pecks anserine bursitis. So, basically, yeah. So, deformity so exactly if I talk about the deformity, we have also got in the knee joint the deformities, which is the genu valgum and varum, which you have to know. So, this condition is showing you genu valgum and varum. So, if I talk about genu varum, what happens? A condition in which knee, so basically there is two conditions. One is genu varum, when the legs curve outward, then when the legs is curving outward, so basically this is the case of varum. This is genu varum, and this is the case of genu valgus. So, when I am telling about genu varum condition, you can see legs curve outward at the knee. So, the legs are curving outward at the knee, and when the legs are curving inward at the knee, that is called as genu valgus. Okay. So, that is so always the toddlers and that of infants has got bow legs, and so that is seen in this condition. So, if I talk about genu varum, it is seen in the case of rickets and all. Now, so I would also like to tell that there is actually two tests are there so there are two tests. Anterior drawer test is there, and there is Lachman test for the targeting the injury of ACL. ACL, there is two tests. So I would like to tell just about that two condition. Anterior drawer test, actually these all things will be detailed in orthopedic session, so I'm just not I'm just telling you a few points about it. Detailed discussion will be done in orthopedic session. Anterior drawer test is showing you forward, is a test in which there is forward sliding of tibia on femur due to rupture of ACL. Where are posterior drawer test or posterior drawer sign is a backward sliding of, it's a condition of backward sliding of tibia on femur due to rupture of PCL, So this is important for you to understand, due to rupture of PCL. So these are the two tests which is positive in ACL and PCL injuries. Now, Lachman test is carried on. So, basically Lachman test is a condition which is carried on 20 to 30 degree of knee flexion, and it is less painful. So, basically, so if I talk about its Lachman test is modified. So, Lachman test is modified. Lachman test is done when knees are flexed just 20 to 30 degrees, So that is, Lachman test is less painful. So it is less painful. Okay. Now, the important questions which we can solve here related to this topic. Okay. Pecks anserine includes three muscles. What are these? Pecks anserine includes three muscles. What are they? All of the following is included as a pecks anserine. Pecks anserine include three muscles, except in the previous session I have told you. Pecs uncerine includes 3 muscle except. Pecs uncerine includes 3 muscle except. So please mark the right answer here, which is not included in the pecs uncerine. Except semimembranous is absolutely correct. Absolutely correct. Janam, you are absolutely correct. Yes, Janam, you are correct. Now, Clergyman knee is inflammation of which bursa? 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 Clergyman knee is inflammation of which bursas? Anyone? Clergyman knee is inflammation of subcutaneous infrapatellar bursa. Subcutaneous infrapatellar. ACL prevents infrapatellar bursa. Subcutaneous infrapatellar bursa. Prepatellar is housemaid knee. Okay, Abdullah. Prepatellar bursa is housemaid knee. ACL prevent which of the following? ACL prevent, one of the best answer among the option will be taking in respect to tibia. So ACL, anterior cruciate ligament, prevent which dislocation of? Yes, Janab, you are right. Yes, Janab is right. ACL prevents anterior dislocation. Which is the most correct answer? Question number 3. Question number 3, most correct answer, ACL prevents. Most correct answer, ACL prevents anterior dislocation of tibia. Anterior dislocation of tibia. Now, a boy is playing football, a blow on the lateral aspect of the knee, twisting fall, his medial meniscus is damaged. Which other structure will be injured if the medial meniscus is damaged? Medial meniscus is damaged, which other structure will be involved? Which 3 ligaments are injured together? That is the hint which is given to you. Which other structure will be injured? Anterior cruciate ligament, absolutely correct, Bindu. Absolutely correct. Yes, the correct answer will be anterior cruciate ligament. Anterior cruciate ligament. O'Donoghue tried compromises of. O'Donoghue tried compromises of which of the following? So tell me, more than one is correct. More than one is correct. More than one is correct. O'Donoghue tried compromises of which of the following ligament or tear? So we have got more than one correct. Yes, medial meniscus is right. Any other? Yes, Abdullah, medial is right. More than one is correct. More than one is correct. Yes, medial meniscus. Yes, anterior cruciate ligament, medial meniscus, and medial collateral ligament. So ACE, more than one. O'Donoghue triad is causing dangerous, or you can say terrible triad, or unhappy triad of knee joint is causing 3 ligaments. Now, which of the following marked structures are affected? Okay, okay. So, which of the following structure is affected in terrible triad? Is affected in unhappy triad? Unhappy triad of knee joint. So, unhappy triad of knee joint. Which of the following structure is involved in unhappy triad of knee joint? So, this is anterior view. So, this is A. This will be E. This will be C. And this will be B. So, can you tell me which is involved in unhappy triad? So, which is involved? So, this structure is A, This posterior structure is E, and this is B. This will be this is one menisci, and this is the ligament connected to it. So, which is the ligament involved? Good evening, Aurora. Yes, so we will have, so actually the correct answer is A, B, C. You can take your time and give me the right answer. Yes, Bindu has given the right answer A, B, C. Why? A is ACL. Okay. C is medial collateral ligament and B is medial meniscus and E is PCL. PCL is not injured. So the correct answer will be A, B and C. So the correct answer will be A, B and C. So absolutely correct. Absolutely correct answer dear. A, B and C. Absolutely correct. Unhappy triad of knee joint involves A, B and C. Ankle joint, in brief, I will tell you about ankle joint. So when we are talking about ankle joint, you have to know that ankle joint is a hinge variety of sign. So which type of joint is an ankle joint? Ankle joint is hinge variety of synovial joint. It's a hinge variety of synovial joint. Now for ankle joint, you can just see this image and you can understand the articulation seen in the ankle joint. So here what you can appreciate, the lower end of the fibula, the lower end of the tibia. The lower end of tibia is medial malleolus. The lower end of fibula is lateral malleolus. It articulates with the talus superior aspect. This articulates with the talus superior aspect, and the joint which is formed is ankle joint. So this will lead to the formation of ankle joint, which is a quite stable joint, and it's a hinge variety of synovial joint. Now, important ligaments of ankle joint. So basically there is a, so if I talk about important ligaments of ankle joint, there are three important ligaments in respect to ankle joint. One is fibrous capsule. One is fibrous capsule. The other is fibrous capsule. The other is medial ankle ligament. The medial ankle ligament is also called as deltoid ligament. Medial ankle ligament is also called as deltoid ligament. And we have got lateral ankle ligament. And we have got lateral ankle ligament. Now, I just want you to understand the attachment of medial and lateral ankle ligament. So, see here. So, in this diagram, you can see the medial ankle ligament, which is also called as deltoid ligament. So, firstly, let's talk about medial ankle ligament, which is also called as deltoid ligament. So, here you can see the medial ankle ligament has got following parts, that is tibiocalcaneal part. It is having tibiocalcaneal part. It is having posterior tibiotalar and it is having anterior tibiotalar part. It is having anterior tibiotalar, it is having posterior tibiotalar, it is having tibionavicular part, which is attached to the tuberosity of the navicular bone, and the calcaneal part, if I am talking, this is the tibionavicular part. If I am talking about the calcaneal part is attached to the sustentaculum tali, and inferiorly if you will see, and on the inferior aspect what you can see, it is also merging with the plantar calcaneo-navicular ligament. The other name of plantar calcaneo-navicular ligament is spring ligament. It is also called as spring ligament. Okay, so that means the deltoid ligament, that means if I am talking about deltoid ligament, that means if I am talking about deltoid ligament, okay, so basically we have, that means if we are talking about deltoid ligament, so I just want to rub all these things. Why? Because all the parts you can practice in this image once the notes will be given to you. The other name of plantar calcaneal ligament is spring ligament. So what you can see in the ankle ligament medial aspect, it is the deltoid strong ligament, which is having following parts. Upper part is attached to the lower end. If I am talking about upper part, it is attached to the lower end. If I am talking about the upper part, it is attached to the lower end of tibia. So this is medial malleolus. It is attached to the lower end of, and lower down it is attached to the talus bone anteriorly and posteriorly, to the navicular bone, to the sustentaculum tali of the calcaneum bone, and also merges with spring ligament. The ankle ligament, the lateral ankle ligament, is having the three parts. So upper attachment is to the lateral malleolus, and it is Ma'am, can we save this video? Okay. So when we are talking about ankle ligament, we have got following three parts. It is having posterior talofibular ligament, anterior talofibular ligament, and calcaneofibular ligament. Okay, you can see this video on the platform provided. Yes, it will be there in the platform provided, so you can see the video afterwards also for revision. Yes, Janav, you can see. So we have got posterior talofibular, we have got anterior talofibular, and we have got the lower end of fibula attached to the calcaneum bone, that is called as calcaneofibular ligament. So these are the two these are the two ligaments, and these are the parts of these two ligaments. Ankle ligaments lateral side is more involved in the sprain condition, and anterior talofibular ligament is more commonly involved. So this is showing you the relation. So we have already talked about the relation, and we know anteriorly there is tendons of the structures passing beneath extensor retinaculum, and posteriorly the structures passing beneath flexor retinaculum. What is important for you is, most important thing which I want everybody to know is Pott's fracture and the clinical aspect. So if I am talking about clinical aspect, you have to know about this. So first clinical anatomy which I want everybody to understand is ankle sprain. So if I talk about the condition of ankle sprain, lateral ankle ligament is involved. Lateral ankle ligament is commonly involved. Why not the medial side? Because medial is very strong. And lateral ankle ligament, which part? The answer will be the most commonly involved is anterior talofibular ligament. Anterior talofibular ligament. So if I talk about this, the most commonly involved part of lateral ankle ligament is anterior talofibular ligament. Which is involved in the condition of ankle sprain. Now, other than that, if we talk about Pott's fracture, in this condition of Pott's fracture, that is fracture dislocation of ankle. This is a condition of fracture dislocation of ankle. And it is actually it is a condition which is seen in the forceful eversion. So this is a condition when the ankle joint is forcefully everted. So when the ankle is forcefully everted, highly everted position. The ligaments which is involved. So basically it's a bimallular condition. So most of the time it will be bimallular condition, but sometimes it will be trimallular condition. So in Pott's fracture, so you can write stages of Pott's fracture. So basically the first stage is oblique fracture of lateral malleolus. So oblique fracture of lateral malleolus, this is medial malleolus, and this is lateral malleolus. This is lateral malleolus. Oblique fracture. The second stage is, the second stage is transverse fracture of medial malleolus due to the pull of strong deltoid ligament, and the third stage is that of fracture of posterior margin of lower end of tibia, posterior margin of lower end of tibia. That is called as third malleolus. This is called as third malleolus. So bimalleolus, that means bimallular fracture has become. So that means bimallular fracture is now transferred into trimallular fracture. So now it has become a trimallular fracture. In this condition, you can see this is a case of trimallular fractures. Trimallular fracture. The Pott's fracture has now become trimallular. So here you can see lateral malleolus fractured, medial malleolus fracture, and the posterior tubercle of so posterior margin or posterior aspect of the lower part of tibia is also involved. Posterior tubercular margin of tibia is involved. So done with this. Now other joints, if I talk about other joints, so just in brief you have to know about other joints. For example, in this condition, talocalcaneonavicular joint is, so basically you have to understand Which type of joint is talocalcaneonavicular joint? So this is talocalcaneal. It is roughly ball and socket type of sign. It is roughly ball and socket type of synovial joint. It is roughly ball and socket type of synovial joint. Other than that, the subtalar joint, if I talk about subtalar joint, so subtalar joint is plain type of synovial joint. Subtalar joint is plain type of synovial joint. Subtalar joint is plain type of synovial joint. Other than that, calcaneocuboid is saddle type of synovial joint. Is saddle type of synovial joint. Other joints में अगर हम बात करें तो metatarsophalangeal joint, proximal interphalangeal joints and distal interphalangeal joints are hinge variety. Metatarsophalangeal joint is ellipsoid variety of synovial joint. So metatarsophalangeal joint is ellipsoid variety of synovial joint. Interphalangeal joints are hinge variety of synovial joint. And proximal, here proximal tibiofibular joint is plain type of synovial joint. It's plain type of synovial joint. Middle tibiofibular joint, middle tibiofibular joint is fibrous joint, and distal tibiofibular joint is syndesmosis. It's which variety of joint? It's a variety of syndesmosis. Okay, now one of an important point is eversion and inversion of foot. Eversion and inversion of foot takes place at subtalar joint. It takes place at the subtalar joint. It is taking place at the subtalar joint. This is showing you the axis, the center of curvature of talocalcaneonavicular joint. It is passing through the center of curvature of subtalar joint and to the neck of the talus it is passing. So now let's I would also like to talk about Lis-Fark ligament. Actually, Lis-Fark ligament is a ligament which is connecting medial cuneiform to second metatarsal. So this ligament is connecting. So it is very important for you. Bindu lumbar plexus I have completed. Shin, calf, talus, meeting point in ankle. So dear, FMG only dear, FMG only, FMG dear, FMG only, don't worry. So Lis-Frank ligament, actually few MCQs overlap in NEET PG, INI, CT and FMC. So it has been explained in this part, okay. Lis-Frank ligament is connecting medial cuneiform to second metatarsal. What is the connection? It is connecting medial cuneiform to second metatarsal. Lis-Frank ligament is the ligament. Yes, Sarvesh Krishna, hello. It is connecting medial cuneiform and that of base of second metatarsal ligament. Okay. So Lis-Fark ligament is connecting tarsal and metatarsal bones. It is mainly connecting to second metatarsal. Hello to everyone. Yeah, hello. So you should also know the bifort ligament is also called as the Chopart ligament and is the key stabilizer of the subtalar joint. So parts of bifurcate ligament. Now let me ask few MCQs. Can you tell me which muscle is causing dorsiflexion of foot at the ankle joint? Which muscle is causing dorsiflexion of the foot? Hello to everyone. Hello. Now can you tell me which muscle is concerned with dorsiflexion of the foot at the ankle joint? Extensor digitorum, extensor hallucis, tibialis anterior. Which is the most important dorsiflexor of the ankle joint? Most important dorsiflexor. So more than one muscle is dorsiflexor, but which is the most important dorsiflexor? So one muscle is only the most important dorsiflexor in the group. Can you tell me the answer? Tibialis anterior, Aradhana, tibialis anterior. All of the following muscle is causing dorsiflexion of ankle joint except all of the following are concerned with dorsiflexion of the foot except so what is the function of peroneus longus? Yes, what is the function of peroneus longus? Peroneus longus is causing dorsiflexion or eversion of the foot. Yes, yes, Dev is now right. Dev is now right. Now I have given the hint and he is telling the right answer, peroneus longus, which is not true about ankle joint, which is not a true statement about ankle joint. It is synovial joint. Deltoid ligament is contributing stability. It is true. It is a hinge variety of joint. That is also true. It is formed by distal end of tibia fibula with the body of talus, which is not most correct here. So the right answer is, which is not most correct here. In this case, the right answer will be, it is most stable in the plantar flexed position. Actually, it is more stable in the dorsiflexed position. Ankle joint is more stable in the dorsiflexed position, not in the plantar flexed position. So D is the right answer. So D is the right answer. Deltoid ligament is having all the following components except, deltoid ligament is having all the following components except, yes, right dear. Deltoid ligament is having all the following component except, yes, calcaneonavicular. D is right. Yes dear, calcaneonavicular is right. Calcaneonavicular. Adduction and abduction is an additional movement which is taking place at subtalar joint. So please note down, adduction and abduction of the forefoot that takes place on which of the following. So please note down, eversion and inversion of foot along with abduction and adduction of foot at the forefoot is taking place at the subtalar joint. So please mark this also as an important point. Abduction and adduction is taking place at the subtalar joint. Ligament connecting medial, I have already told you, ligament connecting medial cuneiform and second metatarsal is, which ligament contains medial cuneiform and second metatarsal? Which ligament connects medial cuneiform and second metatarsal? Which ligament connects medial cuneiform and second metatarsal? I have told you now. Which ligament connect medial cuneiform and second? This is the Lisfranc ligament. This is Lisfranc's ligament. This ligament, Lisfranc's ligament, connects the medial cuneiform and the second metatarsal. D is the right answer. D is the right answer. Now I just want you to give the details of one of the student was asking about hallus valgus, no, hallus valgus. So I just want to explain him. Can you see hallus valgus condition? So one of the student was asking about hallus valgus. So please see this image, hallus valgus. So if I talk about hallus valgus, in this condition, the big toe is, you can see here in this condition. So this is the condition of hallus valgus in which big toe is, here you can see the big toe is deviated laterally. It's deviated laterally. The big toe is deviated laterally, and if it is deviated medially, then hallus varus is the condition. Big toe is deviated laterally. So great toe deviated laterally at metatarsophalangeal joint of metatarsophalangeal joint. So the reason of hallus valgus is wearing constantly high heels. The reason of hallus valgus is wearing constantly high heel, and just reverse of this, if it is deviated medially, then it is the condition of hallus varus. Hallus varus. Hallus varus. Done? No, actually, medico, it is forming an adventitious bursa. Actually, in this constant friction is there on the big toe. So, it will lead to the formation of adventitious bursa on this location. Adventitious bursa on this location. Okay, dear? Now, nerves. I will just finish last topic for today, that is nerves. These are more important for INICT. I am concentrating on the, I will concentrate on the nerves part. Which is that? Okay, nerves part I have not included. Okay, just a minute. I will just give you about the nerves. I will give you a few important points. We have done this. So in the nerves part, you can just have an idea. I will just help you to elaborate. Nerves of the lower limb. So basically nerves in brief I have also talked in the first part. So here I just want everybody, nerves of the lower limb. Nerves of lower limb. So to understand the nerves of lower limb, I would like to tell important nerves, like there is femoral nerve, there is obturator nerve, there is sciatic nerve. So few students actually asked me to explain nerves. Actually I have explained in brief previously also, but I have promised that at the end of the session I will explain common peroneal nerve. Okay, now let me explain. When I am talking about femur, the root value I should write. Root value is L2, L3, L4, L2, L3, L4. Sciatic nerve root value is L4, L5, S1, S2, S3. Common peroneal root value is L4, L5, S1, S2. Tibial nerve root value is L4, L5, S1, S2 and S3, and common peroneal nerve again divides into deep peroneal nerve and superficial peroneal nerve. Now, very easy to understand this. If I am talking about the nerves, you understand femoral nerve. If I am talking about femoral nerve, it is the nerve of anterior compartment of thigh. All of you, in brief, I am talking about this nerve. So, basically, you have to just understand. When I am talking about femoral nerve is the nerve of anterior compartment. So, basically, done with this. Now, here you can write femoral nerve is the nerve of anterior compartment of thigh. Is the nerve of anterior compartment of thigh. So that means femoral nerve will give innervation to which all muscles? Anybody? That means femoral nerve will give innervation to which muscles, dear? Femoral nerve will give innervation to all the muscles of anterior compartment of thigh. That means it will give innervation to quadriceps femoris muscle and sartorius muscle. That means it will give innervation to vastus medialis, vastus intermedius, vastus lateralis and rectus femoris. It gives two cutaneous nerve. It gives cutaneous nerves also. So these are it gives cutaneous nerves. And the cutaneous branches are, it is giving saphenous nerve, which will innervate medial aspect of leg to the great toe. It will give anterior cutaneous nerves. Okay, it's very important for you to understand this. So basically, if we talk about this nerve, so basically it is giving innervation to great area. So basically it gives intermediate, it is giving mainly two branches. It is giving intermediate cutaneous nerve and also medial cutaneous nerve of thigh. So basically anterior se acha hai word intermediate cutaneous nerve. So write down intermediate cutaneous nerve and it is giving medial cutaneous nerve. Got it? That means all the muscle of anterior compartment of thigh will be paralyzed. What does that mean? That means all the muscle of anterior compartment of thigh will be paralyzed. So this is about this. Now the coming to the second is obturator nerve. Obturator nerve is the nerve of medial compartment of the thigh. It is the nerve of medial compartment of thigh. It is the nerve of medial compartment of thigh. So when I am using the word medial compartment of thigh, it means it is giving innervation to adductor longus, adductor magnus, adductor brevis, pectineus muscle, and also obturator externus muscle, and also gracilis muscle. So here also from the trunk. Yes, you are right, Dev. Okay. Okay. Okay, just okay. So just 5 minutes more, medico. Just 5 minutes more, 10 minutes more, 10 minutes more, 10 minutes more. Okay, 10 minutes more. Is it okay? So here from the trunk, the femoral nerve gives innervation to pectineus muscle and also iliacus muscle. Here, if I talk about obturator nerve, it also gives innervation to hip joint and that of knee joint. Now sciatic nerve is already done, no? Sciatic nerve is the nerve of posterior compartment of thigh, is the nerve of posterior compartment of thigh. It gives innervation to all the muscles of posterior compartment of thigh and it gives innervation to hamstring muscle. It gives innervation to hamstring muscle. Hamstring muscle. Tibial nerve give innervation to posterior compartment of leg. It gives innervation to posterior compartment of leg, and here common peroneal nerve divides into superficial peroneal nerve. This superficial peroneal nerve give innervation to muscles of lateral compartment, of leg. And what are the muscles of lateral compartment of, so what are the muscles of lateral compartment of leg? Anyone? Which muscles are the muscles of lateral compartment of leg? Deep peroneal nerve is innervating the muscles of anterior compartment of leg. So when I am telling anterior compartment of leg, it means it is giving innervation to extensor digitorum longus, extensor hallucis longus, tibialis, anterior peroneus tertius. If I am talking about common peroneal nerve, it is having two parts, superficial and deep peroneus. Superficial peroneal nerve is giving innervation to peroneus brevis and peroneus longus muscle. Peroneus brevis and peroneus longus muscle. So lateral compartment of leg is just having two muscle, peroneus longus and peroneus brevis. Deep peroneal nerve is the nerve of anterior compartment of leg which innervate extensor digitorum longus, extensor hallucis longus, tibialis anterior and peroneus tertius. If I talk about tibial nerve, it is giving innervation to the muscles of posterior compartment of leg. And which muscle lies in the posterior compartment of the leg? Gastrocnemius muscle, soleus muscle, plantaris muscle, tibialis posterior muscle, flexor hallucis longus and flexor digitorum longus. Absolutely correct, Dev. Plantaris, yes, you are right, plantaris also. So absolutely correct, Dev. So you have to just understand this. Now one of an important clinical aspect is common peroneal nerve. Actually what happens, sciatic nerve is the nerve which is lying on the back of the thigh. So when it reaches at the superior angle of or the superior aspect of popliteal fossa, it divides into its terminal branch. Tibial nerve will go right down in the posterior compartment of the leg and will give innervation to all the muscles of posterior compartment of the leg. Common peroneal nerve. If I am talking about common peroneal nerve, it winds around the neck of fibula bone, and at the level of neck of fibula bone, if there is a direct hit or injury, the common peroneal nerve is injured, and that means deep peroneal nerve and superficial peroneal nerve both injured, and the muscle of lateral compartment and that of anterior compartment muscles are paralyzed, and the patient will have foot drop, So I just want to write this important one. Write on. Okay, ma'am, the point where sciatic nerve divides into tibial and common peroneal nerve. Yes, Dev Tripathi, I will tell you. That is the point at superior angle of popliteal fossa. At superior angle of popliteal fossa. At superior angle of popliteal fossa. Common peroneal nerve winds around, neck of fibula. If injured, so it is a common site of injury. If injured at this level, both deep peroneal nerve and superficial peroneal nerve is injured, and the patient will have foot drop, and this will lead to condition of foot drop. So why foot drop? What is the reason of foot drop? The reason of foot drop is why the patient will have foot drop. So the patient will have foot drop. Why? Because all the muscles of lateral compartment and that of anterior compartment is paralyzed. So when the common peroneal nerve is injured, which is winding around the lateral aspect of the neck of fibula, it will lead to the injury of these two nerves, and all the muscles of anterior compartment which are causing dorsiflexion of the foot is paralyzed. All the muscles of the everter group, that is peroneus longus and peroneus brevis, is paralyzed, and the patient will have foot drop. Plantar flex foot, the patient will have foot drop. No dorsiflexion of foot. Absolutely correct. Yes, dear, no dorsiflexion of the foot. And if tibial nerve is compressed, it will cause tarsal tunnel syndrome. If an important nerve, digital branch is involved, it will cause Morton neuroma. What will be the condition? That is called as Morton neuroma. Okay. So, for example, I will just explain you. For example, if the obturator nerve is injured, which muscle will be paralyzed? Obturator nerve is injured, which muscle will be paralyzed? The muscle of adductor or medial compartment. What are the muscles of adductor and medial compartment? The muscle of adductor and medial compartment. What is the name of that muscle? Can anybody? The muscle of adductor or medial compartment. Yes, pectineus. Yes, dear. Pectineus, adductor, longus, adductor, brevis. All the adductors group of muscle is gone. So, adduction will be gone. Now, same way, if femoral nerve is injured, all the muscle of anterior compartment of the, yes, you are right. All the muscle of anterior compartment of the thigh will be gone. That means muscles of, can you name muscles of anterior compartment? Sartorius muscle gone, vastus medialis muscle gone, vastus lateralis muscle gone, rectus femoris muscle gone. So I hope you have understood this concept. I am not going into cutaneous distribution, which we have already covered in the previous session. Now, other than that, if tibial nerve is injured, that means all the muscles of posterior compartment of leg is gone. So plantar flexion is lost. Which action is lost? Plantar flexion is lost. Which action is gone, my dear students? The plantar flexion is gone. So to end this session, I just want to end the session. Before that, I just want to give you recapitulation of lower limb, which will be asked. Actually, why the session was too lengthy today? Because I tried to cover up, and I think 90% of all the muscles I have covered up. I have covered up the muscles of anterior compartment, the medial and the lateral and the posterior compartment of thigh, the muscles of anterior, lateral and posterior compartment of the leg. So all the muscles we have completed, also the gluteal region. Now can you tell me, I have told you superior gluteal nerve is injured. Which muscle is injured? I have already explained you. Superior gluteal nerve is injured. Which muscle is injured? And what is sign positive? Which sign is positive? Which sign is positive, dear? I told you Trendelenburg sign is positive in the condition of superior gluteal nerve injury, which is giving innervation to which, yes, you are right, gluteus medius and minimus. It innervates gluteus medius, minimus and tensor fascia lata. If it is injured, we are not able to balance our body weight and there is tilting of the pelvis, the sagging of the pelvis on the one side, that is contralateral side, and this will lead to Waldling gait, and this condition is called as Trendelenburg sign positive condition. So we have already explained this. So you have to know all the joints. I have talked about all the joints of the lower limb. I have talked about femoral triangle. I have talked about femoral sheath. I have talked about adductor region. I have talked about hamstring group of muscle. I have talked about knee joint, hip joint, ankle joint, other joints. I have talked about femoral nerve, sciatic nerve, obturator nerve, tibial nerve, common peroneal nerve, superficial peroneal nerve, deep peroneal nerve, and we have talked about cutaneous innervation of the lower limb. So these all things are highly important, and all the muscles we have covered up, and the important attachment of this muscle, I want you to pay attention to that, because this is highly important that you should be knowing the muscle location, because if the image based question comes, it is very important that you should know the identification of the muscle. Okay, actually, I have already taken a long session, so I few more topics I wanted to teach, but it is okay. And also, you have to know the content also in the superficial fascia and also the content inside. You should know about why adductor canal is called as Hunter's canal. What is subsartorial nerve plexus? What is the content inside the femoral triangle? What do you mean by femoral sheath? What is femoral canal? What is femoral ring? What is femoral herniation? What is abnormal obturator artery? So what I just want everybody to go through the entire list of the topics which I have done. So it is okay. I just want everybody to go through this, and this will be highly useful for you. So we will, exactly, tomorrow is also the session. Tomorrow also we have got the session, and I hope the session is useful for you. Tomorrow will be the session of upper limb. All of you please come at time so that we can cover up the upper limb entire. I want to cover up the entire upper limb and all the important MCQs, and upper limb has got few most important topics, the nerves, the brachial plexus, that are highly important, which should be covered up, and also the small anatomical reasons of the upper limb. So, okay, take rest and revise the whole contents which I have already covered up. And this will be highly beneficial for you. Any student is having any doubt, please let me know. If you have not understood anything, please let me know. Or is it okay? Can I end the session now? You have got any doubt? So already you are very much okay. Welcome, dear ma'am. Time for tomorrow's session. Tomorrow's session is at tomorrow's session at 9 a.m. So I will start at 9 a.m. sharp, be on time so that we can cover up the entire upper limb. Actually, few more topics was there for the lower limb, but I think most important topic has been done for the FMG examination. If I have to concentrate on NEET PG and INICT, I have taken few more topics, but we have already covered enough of FMG, and all these things are why important, because questions are coming from this topic this year and not repeated always. So it is important that you should be able to solve each and every MCQs. Thank you. All the best. Keep studying. Thank you. I am ending the session now. Thank you. Okay, thanks. See you tomorrow. Thank you.